Gay Health Network's board, and you're all very welcome here this morning. It's great to be here for our first live event in 3 years, and actually it's the first time that Gay Health Network, sorry, that's a last one to pass, is running a hybrid event. So welcome to everybody here who's made it in person, but also to everybody online who's joining us virtually. Most of you probably will be aware of Kieran McKinney as our chair, and may have heard that he hasn't been well recently, and I'm here partly because he's not able to be. I'm very happy to report that following a stroke, he's actually recovering very well in the rehab unit of James's Hospital, and he's hoping to watch some of the event during today. So on behalf of all of us, we're sending him our love and best wishes for a speedy recovery, and we hope to have him back real soon. We're absolutely thrilled to be in this incredible building, very prestigious building of the Irish Human Rights and Equality Commission. And that's in no small thanks to the Chief Commissioner, Sinead Gibney, who's here today to welcome us to the building and to outline some issues in relation to collaborative working. Okay, here's Sinead.
Thanks, Bill, and it's a real pleasure to welcome you all here today. I've had a run for the last fortnight of a bunch of different events, and I'm buzzing on the energy of being in the room with people again, meeting with so many of our key stakeholders, and just being in company again. I think it's just so wonderful after so many years now of adapting to remote and the blended and the hybrid and all the rest. So I hope today is going to continue that and give you all the energy that you get from just being in the room together and engaging with stakeholders and discussing the important items on your agenda. I was saying to Bill, it's a very ambitious agenda, so I wish you well, and I hope you're not too tired by the end of it. As Bill said, I'm the Chief Commissioner here in the Irish Human Rights and Equality Commission. We are the national human rights institution and the national equality body for Ireland, with a mandate to protect and promote human rights and equality in Ireland, and to promote a culture of respect for equality, human rights and intercultural understanding. So we work across all of the 9 grounds, all across the human rights that we defend and protect and promote. And I'm delighted to welcome the Gay Health Network here today, and all of your partners and stakeholders here for this important discussion. And I agree, I think it's a moment where we can start to build collaboration and work well together. It's very interesting in my role. I work a lot with our external partners as well, and international partners. And I've been really struck, I suppose, I'm 2 years in the post now, when I'm dealing or working on LGBT rights, how the external perception about Ireland is such a positive one in terms of, I suppose, access to equal marriage being such a big step that we've taken, and the way that we did it by plebiscite was such a huge thing on the international stage. And also people who've come to Ireland, often fleeing persecution in their own countries, are so grateful for the protection they get here. But I have to say, personally, I feel like we still have so much to do in terms of particularly services and access to services and health services in particular for the LGBT community here in Ireland. And also, I think just the really real threat and stigma and difficulties that we've seen in the last couple of years directed towards this community. So I think it's always an interesting perspective. I think seeing that international positivity and praise towards Ireland, but making sure that we understand that we have still so much work to do. And I think there's just so much on your own agenda today that's really important to discuss. So this is our public space, and we, like yourselves, this is our first kind of season essentially back open again. We've been closed for the last couple of years because of COVID. But just for those of you who aren't familiar, this is the idea behind this public space, is that it's available to civil society primarily, and other community groups and stakeholders who might wish to run events here. So Aoife is on our team here, and Fidelma is our key point person. So just to let you know that it is available for exactly this type of thing. And we just get so much out of welcoming so many different groups here. I get to come in and say hello and then go back to my desk and finish my day's work. So I won't be joining you for the programme today, unfortunately. I've had a very busy couple of weeks of events, so I need to catch up on a lot of emails. But it's really just such a pleasure to welcome you all here, to wish you well for the day. And all the best. Thank you.
Sorry, my slides seem to be moving on there for some reason. I'll just try and work that out. They are on the computer, but not on the screen. Is Mick in the room? No. Apologies for this. We seem to have frozen there. Sorry, it seems to have frozen. It's moving on. Yeah. Can you do your support? Yeah. Sorry about that. Sorry about that. Thank you very much, Nick. Normally, as part of the opening of the forum every year, we have the minister present. Unfortunately, Minister Fegan wasn't available today, but he has sent a message to us in video. So I'll just play the video here from Minister Frank Fegan, who is Minister for State for Public Health, Wellbeing, National Drug Strategy. It's not shown on that thing. Times like this, we have to remember that technology is our friend.
Ladies and gentlemen, a very good morning to you all. Thank you for giving me the opportunity to address this year's Gay Health Forum. I had the opportunity to speak at this event last October, and I'm delighted to be able to address the forum again this year. The various member organisations of the Gay Health Network, in partnership with the HSE, are playing a vital role in implementing our national sexual health strategy. This role has been more important than ever in recent years as we recover from the effects of the COVID-19 pandemic. And while we still have to remain vigilant in taking appropriate measures to guard against the spread of infection, we have now, thankfully, seen the easing of restrictions, including those on service provision. We have seen some very welcome developments in this area in recent years. One of the most welcome has been the success of the HSE's home STI testing project. The initial pilot phase of this initiative was very encouraging, and I am very happy to be able to secure additional funding in the recent budget to expand and further support the service. It has now been launched on a nationwide basis. Integrating the online STI testing programme with the established public STI clinics nationwide will allow people to test for STIs in the comfort and privacy of their own homes, reaching those who may be reluctant to visit an SCI clinic in person. The service is free at the point of use, avoiding both cost and stigma-related barriers to access and facilitating higher detection rates, thereby preventing both onward transmission of infection and significant morbidity and mortality for those who test positive and can then access treatment in person. Funding for sexual health also includes supports for the National Condom Distribution Service, which, in line with increased availability of free prescription contraception for women, will be made more widely available through GP surgeries and family planning clinics. Free condoms will be made available through GPs and family planning clinics participating in the free contraception, termination of pregnancy, STI testing and HIV PrEP programs to further support the STI prevention and contraception needs of men and their partners. Looking to the future, you will be aware that my department has begun a review of the National Sexual Health Strategy. And last year we held a number of consultation meetings with stakeholder groups, which proved to be very helpful in identifying the key concerns and priorities for the development of services. And some of you here today will have attended these meetings and made submissions to the review. And I want to take this opportunity to thank you for your input. Work on the development of the Refresh strategy will continue in the months ahead, and I look forward to seeing the results, which enable us to build on the progress already made. I know that you have a full and diverse range of presentations during today's forum, which I'm sure will be a source of great interest and debate. And it only remains, therefore, for me to thank you all again for your support and wish you an enjoyable forum. Thank you.
Increased availability of free prescription contraception for women will be made more widely available through GP surgeries and family planning clinics. Free condoms will be made available through GPs and family planning clinics participating in the free contraception, termination of pregnancy, STI testing and HIV PrEP programs to further support the STI prevention and contraception needs of men and their partners. Looking to the future, you will be aware that my department has begun a review of the National Sexual Health Strategy. And last year we held a number of consultation meetings with stakeholder groups, which proved to be very helpful in identifying the key concerns and priorities for the development of services. And some of you here today will have attended these meetings and made submissions to the review. And I want to take this opportunity to thank you for your input. Work on the development of the Refresh strategy will continue in the months ahead, and I look forward to seeing the results, which enable us to build on the progress already made. I know that you have a full and diverse range of presentations during today's forum, which I'm sure will be a source of great interest and debate. And it only remains, therefore, for me to thank you all again for your support and wish you an enjoyable forum. Thank you.
Where am I at the end there? Didn't want to be up in it again.
I chose because of the.
Oh, okay. Okay, thanks to the Minister for that. Apologies again for all this technical problems, not working to schedule so far. It's a bad sign. I'm the one who's cracking the whip for timekeeping and delaying everybody accordingly, so apologies for that. Normally, we would kind of give the Minister a live copy of our annual report at this stage, but we're happy to do it virtually. And in case you missed it, we did launch the annual report in September following our AGM, and it's now available online. It's packed with information about the very busy year that we had last year, with an increase in our workload over time. So COVID didn't prevent us from working during that time. And all the work that's outlined in it is carried out by a very small group of people. We have the wonderful paid contractors, Padraig Burke, who's the Director of Communications with us, and Rohit Chowdhury, who is our new Administration Manager. And joining the older members of the board, myself, Kieran McKinney, Mick Quinlan, Jamie Kenny, was Paul O'Connell, Alan Coyne, and Michael Kiernan last year. And this year, again, we've had the new addition of Adam Hurley, so we're delighted to be continuing our expansion of the board. We're continuing to look for new board members to ensure that we have a succession of board members when us oldies retire in the not too distant future, and hopefully we'll get some interest in that in the future. But for today is the 19th Gay Health Forum, which is amazing to kind of think about that. And I suppose it doesn't go without acknowledging some milestones. So it's been 28 years since Gay Health Network was founded. And the first Gay Health Forum that we organized 13 years ago was over 5 days. And we thought we had problems with scheduling today. So it's also been 20 years since the Vital Statistics program. And again, that's a seminal piece of research on GBMSM sexuality, and still a reference point, and is also available on our website if you need to look that up. It's the 30th anniversary of the Noel Walsh Memorial Lecture as well. And those of us who are old enough to remember Noel will remember him as a lovely, dedicated man who kind of came on board, coming out as one of the first people in Ireland as HIV positive publicly, and working in the agencies to ensure that we were all on stream with getting the services right for people with HIV. So we all remember him with considerable respect and affection, and we're delighted to have the Noel Walsh Memorial Lecture continue today. And it's a very interesting combination of speakers, I hope you'll find. So as I say, it's been a bumper year for us, really, continuing to work very hard throughout COVID. We've developed more campaigns in the last year probably than ever before. And this year we reached 66,000 website users with over 1.5 million social media impressions. So quite an impressive record, I think, for the year. And Paudie, our communications director, will kind of go through some of those programs with us, with you in his presentation a bit later. The big news for today for us, though, is that we're launching our Gay Health Network strategy just during World AIDS Day week this year. So we're really excited about this. It's been a very stop-start process over the last couple of years, but through the dedication of the board and our contractors, our stakeholders, and our members, we've been able to get it done. And we're really proud of the document. I suppose it's very comprehensive, but it's very brief. It is densely written, so it has a range of actions within it that are under 4 headings. So obviously the first section is information provision, and in that regard we're looking at kind of upgrading the man-to-man website, which is still the national platform for HIV and STI information in Ireland. In terms of research and lobbying, we're kind of have a good record of working collaboratively with state agencies in terms of involvement in research, but we're also hoping to kind of get together a subgroup of research to maybe more proactively look into the gaps that are there for us over the year, and to be more proactive in instigating research in the future. Our membership and development process is also going to be expanded, and we're going to be looking at trying to involve more LGBT agencies from intersectional sectors, for instance, gay travelers or intersex groupings. And then finally, we've been doing a lot of work on governance and accountability over the last year, and that will continue. We obviously are committed to making sure that Gay Health Network is fully in compliance with all its statutory and legal obligations in terms of governance. So to today, today is divided into 4 sections, and I'm chairing the first section, and we're hoping to keep everything on time. So as somebody who's instructing people to keep on time, I'm failing at it myself here, but I hope that the presentations have been asked to be no more than 15 minutes each of the chairs will give the speakers a 1-minute notification to wrap up, and hopefully that will happen. It's a very tight schedule. We're hoping to get through it. It'll engage you throughout the day. And so without further ado, I'll introduce our first speaker today, which is Fiona Lyons. I met Fiona many years ago in James's Hospital when I was there as a trainee social worker, and she impressed me as an intelligent, hardworking and dedicated doctor at the time, and I knew she was going to go far. So here she is as clinical lead in sexual health and consultant in genitourinary medicine.
Thanks a million, Bill. That was back in about 1993 when we first met, and we worked together in the Mater and in James since then. So thanks very much for the opportunity to come and speak to you today about the work that we've done in the Sexual Health Across Pregnancy Programme since the last time I spoke to the forum in October of last year. It's really great to be with you in person, and hello to the people who are online. Especially Karen, if you're there, if you're joining in, it's a big hi to you, and hopefully we'll get to see you back on your feet soon. So we've had a really busy year in the Sexual Health and Crisis Pregnancy Programme, and it is my task over the next, hopefully a little bit less than 15 minutes, to go through an update from the various aspects of the work that we do in the programme. As you know, and as the Minister outlined, we work, our primary sort of work streams is fed by what the National Sexual Health Strategy tells us to do, and we're very proud and privileged to be part of that work and to be leading on and working in a very collaborative way on doing that work, which I think we've made a good bit of progress. The work isn't finished yet, but we've made a lot of progress since the first strategy was launched in 2015. And collaborative working, I suppose, is the key to how the successes that we've had, and that's why it's so nice to be with you here today to speak to you about the work that we're doing within the HSE. So last year I started off, I'm going to just make sure I can't see what the keyboard says in terms of where page down is, to transition my slides. This one here, thanks a million. So last year I had a picture of a glass that was half full in my office as I was getting my slides ready to present at Gay Health Forum. Only afterwards did somebody say to me, Gay Health Forum, glass half full. I was like, oh yeah, I didn't realise that. So if anybody thought that I was being very clever by having glass half full Gay Health Forum last year, that was entirely by chance, because I didn't recognise the association. But I suppose it's through all of us having an objective of having our glass half full that we continue to work together, because if we have a glass half empty and we're just bah humbug all the time, we'll never get anything done. We have to stop, take check every now and again on the progress that we've made, recognise the mountain we still need to climb in terms of reaching our end game, but we really need to continue to have a glass half full approach. That has been challenging in the last year, particularly since the middle of May, when the monkeypox situation came to affect your community and those of us working in this sector within the health service. And it has been a challenging time since then. I'm not going to admit that it's been anything but we still very much have glass half full approach, and we really enjoy working with you collaboratively and have done since 1993, really, Bill. So just a very quick slide about our governance structure. So as Bill alluded to in the rolling out of the Gay Health Network strategy, it's so important that there's clarity around who we report to within the organisation. And so for in our programme, in the Sexual Health and Crisis Pregnancy Programme, we're reporting, we have a business line reporting up into the National Director of Research and Strategy, and then we have a clinical reporting line for the work that we do, that Caroline, Rachel and I do in the clinical side of the house within the programme, up to the Chief Clinical Officer within the HSE. And it's really important that there's clarity around that, and we use this all the time and we remind ourselves of this all the time. So over the next couple of slides, I'm going to go through updates from the clinical side of the house, research, communications, and I'm focusing, it isn't a reflection of all of the work that's done within the programme, because I've chosen the things that are relevant for your community today to give in my updates today. So there's other work going on as well. So the clinical updates, and there's Caroline, Rachel and myself are the clinical team in the programme, and they've given me a lot of help in getting the slides ready with the next couple of slides to give us our headline news on what's been happening from the clinical side of the house. So as Minister Fian highlighted, we are very proud that we managed to secure the funding following a successful pilot done in the midst of COVID, and with a lot of people working very, very hard to make sure this happened. to roll out, secure funding to roll out a national online STI testing service. And thank you to everybody here in this audience who has played a big part in making that happen. It couldn't have been done without a massive team effort. And this is a true example of the glass half full approach. We got the funding in 2019 to do this with the Sláinte Care Initiative. Then COVID hit and all the Sláinte Care initiatives were paused. But then towards the end of 2020, we said we really need to roll with this now because we're still facing challenges. People have huge access issues to testing. So let's do the pilot now. So we regrouped ourselves, we dusted ourselves down, we made the pilot happen between January and May of 2019. And the Minister Fian alluded to why this is important, because some people may have issues around stigma, embarrassment, or not just wanting to go to a face-to-face service. But also there are two other really important parts of this as well. One is we know we have access and capacity issues within our existing STI services. And so we need to improve that, and the online STI testing service without doubt does that. But the other thing is that we need to recognise that people have a jigsaw puzzle of how they may want to access healthcare. And we need to put people in the driving seat around what they can do and empower and enable them to taking ownership of their sexual health. And I really think that the online STI testing service goes a big way towards doing that. And I think on my bucket list of things that I wanted to achieve in my career, I think I can put a big tick. This is something that I had my first thought about in January 2016. So it just shows you how long things can take, but you need to keep going, keep having a glass half full approach in order to get there in the end. So we're delighted with this piece of work. I suppose many of you may already know what the pilot evaluation program showed, the evaluation of the pilot showed, and it's published on our website now. But just with respect to engaging your community, we know that of the 13,500 test kits that were ordered, 17.2% of the individuals were identified as GBMSM. So this suggests that this service is reaching your community as well. And that's a very important part of what we wanted to do to ensure that it was going to reach out to all the people who may get benefit from the service. People, when they get their kit, they're given a postal kit that they can return. It's all prepaid for. We know that almost 64% of GBMSM who got a kit returned the kit, which is really important as well. And that we were able, within the GBMSM community who ordered and returned kits, we were identifying new infections. So therefore, this just suggests that not only is this actually something that is acceptable within the community, but also we are actually having a positive impact, and because we're actually identifying infections, which is very important, obviously for individuals' personal health, but also from a public health perspective as well. HIV PrEP. Now, I know we're not perfect in respect of HIV PrEP, but let's just take a pause as to where we've come from. So following the rollout of the PrEP programme in November 2019, you may remember that almost a wet week later, we were in the midst of a global pandemic. And despite the global pandemic, I think we have to acknowledge the fact that we continued to engage with new users and get new people on PrEP every month, despite the severe service restrictions that were placed upon us and every aspect of our lives, particularly in the early part of the pandemic. So almost 7,000 individuals have been registered with PCRS, which is the community reimbursement scheme that's used to avail of free medication. That's 7,000 more than there were in November 2019. And I suppose the important thing to remember is that in between January and September of this year, almost 2,500 new individuals were registered, suggesting again that we're continuing to accrue new people to this important HIV prevention service all the time. We updated the guidelines earlier during this year, and they're published on the website now. Key changes in the guidelines are around eligibility. So they were quite, you might say, with hindsight, restrictive in the beginning. It's now anticipated risk. So if somebody has an anticipated risk, they don't have to have declared a risk. If they've got an anticipated risk, this is now included in the eligibility criteria for PrEP as well. We wanted to make, again, recognising that people like to access healthcare in different ways, we wanted to make sure that it didn't just have to be through public STI clinics. And so we want to increase the number of providers that are available as well. So the guidelines were rewritten with a very clear focus on who we would like to be attending a specialist service where they've access to consultants in genitourinary and medicine and infectious diseases, but also that people may wish to access through general practice services as well. So that has changed as well, and there's great clarity now for healthcare providers within the guidelines of what those parameters are, when somebody should be referred to specialist care, when somebody may be appropriately managed within the general practice setting. We also made included changes around when post-exposure prophylaxis is required for people who may have missed doses of their PrEP and may need additional HIV prevention in the setting of missed doses of PrEP. To reflect those changes, the patient information leaflets have been updated and are now on the website. They're being translated at the moment, but the design piece has gone through. And I want to just acknowledge everybody, people within the community who've contributed to this work. We were pulling on you left, right and centre to get the guidelines reviewed. And thank you, Bill and colleagues, for the feedback on that. And also for the patient information leaflet to make sure that it was speaking appropriately to your community. And so that's very, very great. We're very grateful for that contribution to this. The other thing, I suppose, is that in the last couple of weeks, we've now gotten 4 new general practice providers added to the PrEP provision services. And this is something that we really want to build on further in 2023. And we have plans for how we're going to engage with GPs around ensuring that they're appropriately trained and have the necessary skills to provide a HIV PrEP programme within the community. Fast Track Cities initiative is an initiative that is a global initiative around getting, so it's around the 1990 continuum for HIV, but there's an additional piece now around getting to zero, that we've got 0 instant HIV infections and 0 HIV related deaths. So Ireland signed up to the Fast Track Cities initiative in 2019, and the establishment of steering groups and oversight of the initial rollout of Fast Track Cities in Ireland lies with the responsibility of that lies with the programme. So Rachel Trustree does a huge amount of work on working with the steering groups that have been established in the 4 Fast Track Cities around the country to ensure that the steering groups have clarity around what it is they're trying to do. And last year, we commissioned a piece of work to get a good understanding of the state of the nation, as it were, within each of the Fast Track cities to inform each city implementation plan. And that work should be published early in 2023. As part of that work separately, we did, within the programme, did a piece of work engaging with our HIV adult clinical services, which was like a questionnaire aligning with questions aligning to national standard or to British standards for delivery of HIV care, to see how services feel they're doing in respect of that, to get an understanding to contribute to the overall city steering group's implementation plans for getting to zero ultimately. This is one slide on monkeypox. I work in the programme 3 days a week, Tuesday, Wednesday, Thursday. Since the middle of May, I would say that at least 2 days of my work has been entirely to do with the monkeypox response. And I'm sorry, many people in the audience were sick of the sight of each other because of all the meetings that we've been in related to monkeypox. But, you know, hopefully we will get there in the end. And I suppose this is a true example of collaborative, multi-sectoral team working, because this will never work if we do it in silos. And it's great to be, it wasn't our first rodeo in working together on an outbreak, so it was great to have the relationships already established. So in respect of the programme, what we've been doing is we've been heavily involved initially with the incident management team that was chaired by Dr. Derval Igo, and subsequently when that transitioned to the National Crisis Management team. And we've done a lot of work leaning. I suppose from a clinical perspective, what's been really rewarding for me has been how generous our colleagues have been overseas. So we had the UK, for example, had about a 2 or 3 week lead-in time before our first cases arrived in Ireland, and they could not have been more generous, because there was a major scramble before we had our first cases around ensuring that there were guidelines, policies, protocols, resources available for clinicians to ensure that they could adequately meet the care needs of individuals who had confirmed or suspected monkeypox. And I'm really grateful to our colleagues, particularly in the UK and at European level, who've been very generous with sharing resources that we have subsequently adapted and disseminated to our clinical stakeholders. And I've participated in a number of community meetings. Unfortunately, I'm not going to make a meeting next week because I will be on my holidays. And I'm not changing that, I'm afraid. We've We've also, a very important part of it has been participation in the webinars that have been run by the British Association for Sexual Health and HIV and the ECDC and EACS, and they've been really useful resources. And then we've, along with other colleagues here in the room, have participated in the Department of Health convened special advisory groups. So it has kept us quite busy, but we'll get there in the end. I'm moving now to areas that I am not directly involved in, and I'm grateful to Nicola, who is our research manager within the programme, around a research update, particularly relating to your community. And that is particularly relates to the plans for EMIS 2023. Such an important piece of work, and we so desperately need it now, particularly because we've had the pandemic, and we need to understand the impact of the pandemic, and we've had availability of HIV PrEP since 2019. So we need to ensure that we have really good data to inform how we're doing in respect of people's knowledge, attitudes and behaviours in respect of their sexual health. So the programme this year is working with the group to roll out the EMIS survey, hopefully in 2023. Moving now to campaign updates, and I know Paddy's going to, I didn't know we called you Paddy, but I'm going to call you Paddy and take liberty if that's okay. From now on forward, I'll call you Paddy. The campaign updates from Anita, our communication manager. I know, so Paddy's going to give us a more specific update, but really what Anita wanted me to say was that just to highlight the campaigns that have been done in partnership and collaboration with the Man to Man in the last year. And then moving on to the U equals U. I love that video, absolutely love Veda's video. And I think the stigma campaign is really important. That's been started as well, especially on the back of what was, you may remember in January 2020, was when we first had the U equals U on the bus shelters and the Lewis stops. And it was one of my proudest moments, actually getting onto the Lewis and seeing a big poster that said U equals U. It's like, that's great. And then everything, COVID, the world turned upside down. But it's really good to be re-establishing those campaigns now. Okay, I will speed up. Okay, so I think this slide is really to highlight how much we value working with you, the community. If we don't work together, we're never going to get anything done. And it's not in a hierarchical way, it's in a collaborative team way, and we really value that. And so we work with our colleagues in Empire, Sexual Health Centre in Cork, Sexual Health West, Gosh in Limerick, and that's we wouldn't be able to do the work that we do without you guys, so thank you. And then finally, the National Condom Distribution Service, these are the figures for 2021 and 2022. The Condom Distribution Service was established at the very end of 2015, and in the beginning it required that there was a health intervention, there was an intervention, like somebody had to be spoken to about, this is how you use a condom. And we were kind of going, no, please, can we just bags of condoms, lube, let's just make them available. And so that's the position we've got to now. So that's really good. So the place is awash with condoms, and we're very glad for that. And it's I find it curious, and if I'm walking along the canal or running along the canal, I'll often see a little sexual well-being, and I go, okay, that's good, okay. Maybe not the littering, but it's good that they're being used and they're getting out there. So as of the end of October, there were 895,000 condoms and over 500,000 sachets of lube ordered. And we know that a very significant proportion of these condoms and lubes were used to fill dispensers in venues and GBMSM social venues, which is really important because we know that that's like, in our clinic, for example, we have them on a corridor where you can literally you could just walk down the corridor and just put your hand in, and we make sure that so that people don't have any embarrassment or stigma or feel awkward about putting their hand in to grab a few condoms or lube. So that's another thing that we're very proud of, and an important part of the jigsaw puzzle to getting us to a position of better sexual health outcomes for your community and for everybody. So that's it. Not too far over the time. I can start, but do you want you to speak now? Then you
I was going to allow the four speakers to go and then have a bit of time for Q&A, if we can stay.
If I disappear, apologies. I'm not missing my flight to Rome. If that's okay. So if I do disappear, it's because I'm going to get a plane.
Thank you. Special thanks to Fiona for being here on the day that she's actually travelling to Rome. I don't know if many of the rest of us would have that level of dedication. So our next speaker is also somebody I met many years ago in my training of social work in James's Hospital, and that's Grania Courtney. And Grania, I think, was a GP back then, but now is consultant in St. James's Hospital and also with Gay Men's Health Service. And she's going to update us on what's happening in GMHS.
Which is the go forward button, just the mouse, is it?
Just this is easier.
Okay. Okay. Thanks very much, everybody, for asking me to speak here today, and lovely to see old friends like Mick Quinlan and Diego and all the friends we have here from the Gay Men's Health Project. So that's the full screen. Okay, so just going to give you a bit of background first on the Gay Men's Health Service. I'm sure you all know this. It was founded in 1992 in Baggot Street Community Hospital, and we celebrated our 25 years in 2017, so it's 30 years this year. We don't have any plans for a big celebration, but we probably do something small. Jessie's in the room there and she's thinking hard about it. So it was 9 months actually before decriminalisation that we started, and by 2017 we did 100,000 visits just out of hours. Now we have a daily service 4 days a week, and as I said, 30 years of services this year. So just to give you a little bit of context about where the Gay Men's Health Project sits within the HSE, because it's an entirely HSE funded service. It's in CHO Area 6, which is, you can see on the map there, this large area stretching from South Dublin, from say Baggot Street, Ringsend, down to Bray and Wicklow. And I would consider that the GMHS is the flagship service in the CHS social inclusion portfolio. At the moment, however, it's geographically located in CHO Area 7 because the building in CHO Area 6, the Baggot Street building, just really wasn't fit for purpose. And I don't know if any of you remember or any of you ever attended Baggot Street, but I used to have a room where the waterworks used to just knock all the time and the walls didn't meet the ceiling and people would go in and out and you'd hear people walking in and out while you were talking to a patient. So it was totally unfit for purpose. We got the building in the Meath Primary Care Centre on a temporary basis, but the plan is actually to move back to CHO Area 6 to the Baggot Street Hospital when that building is refurbished with a lot of other social inclusion services there. So that'll be in around 2025. It sits in the primary care centre and section of the HSE, and it's significantly aligned with the community care initiatives where they're trying to move stuff like cardiology, old people services, all kinds of services into the community with a link with the tertiary services and hospitals. And we have had that link of very long standing with St. James's Hospital. All our specimens go to the lab. We've always had links with James's Hospital between health advisors, consultants, lab, etc. And it is also the national service for gay and bisexual men who have sex with men. So that's it. So just going to touch on where we were in 2017 and then go on and talk about kind of what's happened since then. So this was a study that was done on gay health centres checkpoints. I'll see if I can get this. This is the Gay Men's Health Service here. You can see that arrow. Oh no, you can't. There's no arrow. It's actually here. This is the Gay Men's Health Service. So we're like one of the places that's performing really, really well in terms of screening and testing and community involvement in terms of gay health services all over Europe. And the one that's just above us, that big green one, is Dean Street, which is the Mecca in London for sexual health services. So the Gay Men's Health Services, even in 2017, was performing really, really well from that point of view. So what happened then? Well, Gay Men's Health Service, the pandemic, what can I say? Services severely curtailed. March 2020, actually, the service was really, to all intents and purposes, closed. All of the staff were redeployed to COVID screening and vaccinations. We had no manager between mid to late 2020 and 2021. The lab service was curtailed after the cyber attack, and I'm going to talk a bit more about that in a second. But we reopened service. We kept PrEP going during that time for the patients that were already on PrEP, but we really didn't see a lot of new patients during that time. But for patients who were on PrEP, we did HIV testing and PrEP prescriptions for them. So the cyber attack is, I don't think people really realise, I don't think the general public really realise the impact of the cyber attack on the whole of the HSE and the health service. And at the time that happened, we were really well on the way to planning moving the Gay Men's Health Service, which was completely paper-based records, everything paper, to an electronic record. Well, that totally stalled during the cyber attack, and it took a really huge effort probably more than a year to get it back up and running again. And the type of challenges there I've listed on the left-hand side, like we don't have an individual health identifier in this country, where in the UK they've had one for 60 years. That's the single biggest issue, probably. Actually, we do have an individual health identifier. Everybody in this room has one. I have a photograph of mine, which I took when I got the COVID vaccine, because somebody just showed it to me on the screen. Everyone has one. The problem is they're not embedded into the systems. They created the number first, but the systems aren't capable of taking them. So that's a big kind of bugbear. GDPR. Health systems in Ireland are really, really immature. This is a particular interest of mine, health IT, but they're really immature for a lot of reasons, but mainly at the time that we had the big recession where there was really no money coming into the system. That was a time where we really should have been moving to health IT. I think that we will move that way now, but we really are very, very behind. Patient expectations are really high because they, people think, well, I go into the bank or I go into anywhere and I use my phone and I should be able to. And so, that's a big challenge for us. And we were a totally paper-based service. On the other hand, because now we're moving into to the IT space now, we can sort of leapfrog old things and adopt new technologies and catch up maybe easier. There is investment available, I think, because of the cyber attack that the authorities realise we really, really have to move in this space. And then patient expectations is an opportunity as well as a challenge, because patients will campaign for these things and patients are politicians and they're everywhere and everybody uses health, so the expectation is there. And then the SH24, the online STI testing, has put us into a completely different space in terms of IT access. So we reopened in September 2021 in a new landscape where clinical services had to be delivered in a totally different way. We had what we used to have, Mick, the Tuesday and the Wednesday night, like you could have 100 people in the waiting room. We just couldn't do that anymore. Services had to be planned. But it was also in the context of, PrEP almost taking over our routine services. And that's been seen in sexual health services throughout the world, that a lot of the routine services are taken over by PrEP. Asymptomatic and symptomatic clinics were all booked. And as I said, SH24 has without SH24, it just has taken the pressure off all of the STI services. So it's enabled us to signpost patients in that direction and meet their needs. So the vision for the service, I'm not going to go through all of those things, but for it to get rapid access, the right patient, seeing the right person at the right time, because we know from all of these studies that have been done before, and I'm really looking forward to EMIS 2023. It's going to be very exciting with all the changes that have taken place in this area. We know that gay men are 21 more times more likely to be at risk of HIV. So this is the new IT infrastructure that has been introduced. So all the things in the blue boxes are working and working well, and the things in the orange boxes are things we'd like to implement but haven't done yet. And the principle of that is the laboratory. We've had difficulty with the laboratory ordering and downloading of electronic records. That's the last piece of work we have to do. And when we do that, that's going to free up a huge amount of nursing time to be able to deal with more patient-facing work. And the list of things along the left are the systems that we're using. So Socrates is our electronic patient record, and that's one of the GP systems that we've adapted to use in the Gay Men's Health Service. We've online booking with SwiftQ. HealthLink is the laboratory ordering that we don't have implemented yet, but we're hoping to implement it very shortly. SH24 is the online STI testing we've talked about already, and we're using HealthMail, which is the HSE mailing system, to mail electronic scripts to community pharmacies, and they're going all over the country. And that will also work really well with SH24. So somebody could literally have a chlamydia positive in SH24 and be referred to us and never even have to visit. We could do the chlamydia assessment on the phone and then send the script by HealthMail to their community pharmacy. And we're hoping to do that when we have a full-time health advisor on site. So nursing is totally critical to the delivery of our service. I'm really the only full-time doctor there. We have some sessional doctors on a Tuesday evening and on Thursday morning, and very grateful we are to have them. But we couldn't function without the enhanced nursing role. So I work with about 8 nurses. We have a candidate advanced nurse practitioner who would be working in an independent role when that gets up and running. We're hoping, we have recruited a full-time health advisor. He's sitting in the room. Really delighted we are about that, because we've just had a service 1 day a week every 2 weeks from James's. So in the context of managing early infectious syphilis cases, that person has just taken up, and even struggling to do that, never mind all the other things a health advisor has to do. So we look at vaccines by protocol, another brilliant initiative, because we weren't allowed to even look at an advanced nurse practitioner candidate until we had a director of nursing, because that's how the nursing hierarchy works. So for the first time, there's been a director of nursing appointed in the social inclusion space. There isn't a director of nursing anywhere else in any of the other health areas other than our one. So that nurse is going to bring on all of that enhanced nursing role. And we'd also look to expand our physician resources so that we can expand our prep. So I'm just going to go into a whole load of data slides now. So you can see there, the last 2022 is off the, anyway, I can get it. Yes, that's a bit of a, it's the 2022 is off the slide, so you can't actually see it. But it, for the, great, that's great. So it is. So you can see from the 2022 on that, if you can see it on the wall, that's projected for 2022, because obviously we only had figures up to September. But projected for 2022 is going to look like we're back to the figures that we saw in 2015, 2016, 2017, which we think is what we should be seeing. So next slide. These are just a picture of our first time attendees. 35% never previously tested for HIV or had an STI screen. 47% of those are born abroad, and 21% aged 24 or younger. And this is a kind of a breakdown of the clinics. As you can see, there's 35% of those are PrEP clinics. So PrEP clinics they haven't taken over our routine services, but they are a very large proportion of our service. But we're still 50% asymptomatic screening and symptomatic screening. And so we're able to offer anybody who calls us an asymptomatic screen within 2 weeks and a symptomatic screen within a week. So we're able to offer anyone who's diagnosed with an STI that they would be seen within that week. So I think we've got it right at the moment. Obviously, we'd like to do more and we'd like to do better, but I think we're doing okay from that perspective. So this is our PrEP appointments. As you can see, we only have a certain capacity for new patients, and now we've really reached, we're pretty much almost reached our capacity to take on any PrEP patients without additional resources. So as we're offering them appointments for review. So this is that we're up to pretty much over 800 PrEP patients now attending the service, and we think our capacity with the resources that we currently have is about 850. So on the left-hand side, that pie chart is what people thought, because we asked people what's their plan about taking PrEP, and usually people want to take event-based dosing, but a lot of people, event-based dosing is not suitable for them. So we bring them through the consultation, and then people decide what it is. And you can see, if you look to the right-hand side, for people who are actually on PrEP, it's mostly daily dosing. So about 2/3 are on daily dosing and about 1/3 on event-based dosing. So this is PEP, and you can see that PEP has plummeted, but that PEP has plummeted everywhere in our clinic and in St. James's Hospital because people are on PrEP. And also, from our point of view, because we don't really have walk-in clinics. So most people who would require PrEP would end up going to the emergency department or the guide clinic. We do PEP on the days that we're open, so we can facilitate people if we're running clinics, but obviously I'd say they'd have a surer bet going somewhere else. This is just a slide on our vaccinations. We did participate in the phase 1A of the monkeypox vaccine, so that was the early infectious syphilis, and that ran really well, and thanks to everyone in the Gay Men's Health Project who facilitated that, because it wasn't an easy feat. So we offered all of our own cases of early infectious syphilis, the monkeypox vaccine, and we also took the cases from 2 fairly large sexual health private practices, and also from the Midlands and from Beaumont Hospital. We did their cases of early infectious syphilis for monkeypox vaccine. So this slide might be gone off the wall as well. 22 has gone off the wall. 2022, that's only 21 for HIV there. So they're not projected figures, they're actual figures. So that's only 9 months of the year. So comparing those with 2017, you can see that they're probably going to be similar, except for HIV, which is really low. So even though I know if you look at the weekly STI reports, there are increased numbers of HIV, but we're not seeing it in the AMANS Health Project. So we're not seeing an increased number of HIV transmissions in men who have sex with men. So be very interested to see how those figures pan out as to what the increase is in the HIV cases. So still have a big problem with syphilis, chlamydia and gonorrhea. And this is my last slide. So prospects for the future. So delighted that we've recruited a full-time health advisor who'll be starting in January. We'd like to increase our capacity for PrEP screening and vaccines. We'd like to provide a hub and spoke. I think that's really important as GPs, and particularly student health. I'd really like to see PrEP expanding in student health, but then those patients will need a pathway to get their PrEP continued when they come out of university, and we'd like to participate in that, and also to take maybe complex cases from those in primary care who'd be doing PrEP. We'd like to put a focus on quality audit and patient experience. We'd like to implement the electronic lab processes. And my own wish would be to have a patient portal so that the patient could engage with their own, so maybe could complete templates online, you know, do a lot more online engagement than we can do at the moment. So that's it. That's where we are.
Thank you very much, Gráinne. That was a great presentation, very informative and great to hear. Our next speaker is Martha Neary, and we're all used to new obstacles in the last years, COVID and monkeypox and so on, but it's also important to keep up with our old foes. So here to update us on what's happening with early infectious syphilis is Martha Neary.
Can I just ask you about does the mouse work? Oh yeah, the mouse is fine. Okay.
The mouse is not very good.
Perfect. Thanks very much. Well, thank you very much for inviting me here today to talk to you about early infectious syphilis. So as we've mentioned, that syphilis is an old foe. It is a sexually transmitted disease, and it's caused by the bacteria Treponema pallidum. It spreads from person to person through direct contact with the syphilitic sore through anal, vaginal or oral sex. And despite the availability of a very effective treatment and sensitive diagnostic tests, it still remains a serious health problem for both individuals and for public health. So early infectious syphilis is a notifiable disease, and that is primary, secondary and early latent syphilis. During these stages, people are infectious and can spread syphilis. Latent syphilis is not infectious, it's not notifiable, but it is treated. And reinfections can occur because no immunity develops. So the surveillance process there's a procedure. The laboratories notify all EIS cases that meet the case definition. They're uploaded to the computerized infectious disease reporting system called CIDR, and both new and reinfections are notified. Once the case has been notified, Public Health then send a request to the clinicians to complete an enhanced surveillance form. And then Public Health enter that form, and then we're able to analyse the data. And no patient names are included in the data that we see. So we monitor trends. We provide information that can be used to plan sexual health services and public health responses. So we can see here from this slide that the notifications are increasing. The rates for the first 10 months of 2022 are the same as for the total of 2019. There was a drop in 2020, and that was due to the impact of the COVID-19 pandemic. The majority of EIS cases identify as male. Notifications in men are increasing, and we can see here that the rate is 29.9 per 100,000 of population for 2022 so far. We can see that notifications in women remain low and stable. This is a graph of the EIS cases by EpiDate, and EpiDate is the earliest known date of infection
And we can see a massive drop off in March 2020. And the reason for that, as Grania has mentioned, is because we had lockdowns and we had reduced sexual health services and reduced testing opportunities. And also there was reduced migration into Ireland at that time. So gay, bisexual and men who have sex with men account for approximately 90% of EIS cases where we know the mode of transmission. Now, the mode of transmission is known for only 57% of cases for 2022, and that drops down to 42% in 2020. So we're working very hard, public health are working very hard with the clinicians to return and upload those enhanced surveillance forms that are outstanding from the pandemic. We can see that the majority of cases here are in the East. It's very clear. Also, when we look at the data in more detail, we see, as I mentioned before, that men are mostly affected, and that the age that the highest range there is aged 30 to 34, and this is slightly older than other STIs. And the data for gonorrhea, which also is more prevalent in men, the age range there is slightly lower, 25 to 29 years of age, and lower again than for chlamydia at 20 to 24 years of age. And we can see too that women are more impacted by chlamydia than men. Now, the HIV status of the EIS cases, so the HIV negative are the red, people living with HIV are purple, and the unknowns are in pink there. And so we can see that the data is less complete for 2020, 2021 and 2022. But it's important to look at the HIV negative people in 2021 and 2022, and approximately 2/3 of those people are HIV negative. And this is important because the risk of acquiring HIV increases if exposure occurs when syphilis is present. We have data on PrEP, and it's more complete for 2022 than it is for 2021. And approximately, where we know this information, approximately 1/3 of HIV negative people with early infectious syphilis are using PrEP. And it's very important to test and be screened for STIs when using HIV PrEP. So the recommendation is every 3 months. We also look at reinfection. So we can see that the reinfection rates remain stable and have done since 2019, between about 16 and 18% of all infections. We look at the age group between those where there is evidence of reinfection and where there isn't. And we can see, unsurprisingly, that men over 40 are more, there's more evidence of reinfection in the older age groups and less so in the younger age groups. And I suppose that's not surprising. When we look at HIV status for people who have evidence of reinfection, we can see that the majority of people are living with HIV, and then the converse is true then for those where there is no evidence of reinfection. The majority are HIV negative. Where we know country of birth, approximately half of male EIS cases are born in Ireland, and then where people are born abroad, the half of those come from Central and South America. Internationally, syphilis is increasing. In the USA, rates have increased by 34% between 2015 and 2020. Also in Australia, they've increased by about 90% from recorded rates in 2015, and it's on the rise in the UK as well. This is the European situation. The rates are increasing in Europe, although the overall figures look much lower than Irish rates, and this could be due to there are differences in case definitions across Europe, and also there are different levels of testing across different countries. But Ireland and the UK have a high incidence. So what has been done about this? There was a syphilis outbreak control team, and that was convened in 2021, and it had several actions that came out of this group. One was a specific communication campaign, also to raise awareness among medical professionals of syphilis. There was a pop-up syphilis testing centre in July 21, and then as Fiona spoke about earlier, the extension of the online home testing service, and that has been extended to all 26 counties in October 22. So there's an example of the Syphilis is on the Rise campaign, and that was run by Man to Man. And in addition, HPSC also, we had an extra form that we ran in October 2021 and asked clinical services to fill out. Only 85 forms have been returned to date, and we asked people, were they aware that there was an outbreak? And we got 26% of individuals were aware of the outbreak. 45% of the individuals engaged with the service because they were symptomatic, and 28 engaged through routine testing. The pop-up syphilis testing was done in Dublin city centre, and 214 people were tested. The testing identified 6 people with latent syphilis which had never been treated, and 1 new HIV positive person was identified. So that was very useful for the individuals, but no new EIS cases were detected. This is the free home testing kit, and we're hoping that this will improve access and capacity for STI testing. It's free and it's available for all of those over 17 years that are living in Ireland. It tests for syphilis, chlamydia, gonorrhea, HIV. So people with a positive syphilis result will get a text message, and then the SH24 clinical team will refer them to a public STI clinic for further assessment and for further testing. So to summarise, EIS continues to increase in Ireland. Gay, bisexual and men who have sex with men remain the group most affected. Early infectious syphilis tends to be in older groups than other STIs, and where HIV status is known, 1/3 of EIS cases are among people who are living with HIV. The risk of acquiring HIV increases if syphilis is present, and information, regular testing are the key tools for sexual health. There's further information available on sexualwellbeing.ie and the Man to Man website. I'd like to thank my own team at HPSC, Kate, Mark, Angeline, Joanne and Derval, and I'd like to thank very much the people in public health, the consultants in genitourinary medicine, consultants in infectious diseases, STI clinics, GPs, the NVRL and micro laboratories. And I'd also like to say thank you very much for listening to this today. Thank you.
Thank you very much, Martha. That was a very insightful overview of the epidemic and very worrying trends there too, obviously. Our next speaker is Eve Robinson, also from the HPSC, who is going to bring us back to the dreaded monkeypox to get an up-to-date on what's happening there. I know a lot of us have put time and effort into getting the sorry, the mouse is playing all up there. getting monkeypox campaign up and running. But here to give us an update is Eve Robinson when I get the technology working again.
So, good morning, everyone. Today I'm going to present on behalf of all those working on the surveillance and epidemiology of monkeypox and the wider outbreak response team for monkeypox. Several of the members of that team are in the room today. And as has been mentioned several times, on top of an ongoing COVID-19 pandemic, syphilis outbreak, and lots of other challenges, another major challenge emerged this year, which was the global outbreak of monkeypox, largely affecting gay, bisexual, and other men who have sex with men. So the outbreak response here in Ireland has been multifaceted. Aspects of the response and the impacts of the event on GBMSM have already been mentioned by Fiona and Grania, and will undoubtedly come up several times throughout the day. But for this session, I'm just going to focus on the epidemiology to date, both here in Ireland and worldwide. So I'll speak a bit about what was happening with monkeypox before May 2022, then how the current outbreak emerged and how it's evolved in Ireland and globally, where we are currently and what the future might hold. So monkeypox virus and monkeypox disease have been around for a long time. The first human case was detected in 1970 in the Democratic Republic of the Congo. And for several decades, it remained quite rare and confined to a small number of countries in West and Central Africa. About 11 countries were considered endemic. And even in those countries, for a long time, cases mainly occurred in rural areas close to rainforests. And in those areas, the virus circulated in various animal species, and humans were infected by coming in contact with infected animals. And then there was occasional onward human-to-human transmission. However, in more recent years, in these endemic countries, there has been an increasing number of cases occurring in urban areas and probably due to human transmission. Outside of those endemic areas, prior to May 2022, there were occasional travel-associated cases occurring in people that had recently returned from one of those endemic countries or had a link to somebody who had returned from one of those countries. Around 20 years ago, there was an outbreak in the US linked to imported animals. But all that changed in May 2022. So on the 7th of May, the UK did report a case in somebody who had recently returned from Nigeria. As I said, sporadic cases have occurred in the past, so although not a run-of-the-mill event whatsoever, it wasn't completely unexpected. Then, a few days later, on the 13th of May, the UK reported 2 other confirmed cases and 1 suspect case. And these 3 cases were a family unit. They had no travel history, no link to the previous case of the 7th of May, and no link to any other people that had recently travelled. So this was a very unusual event. On the same day, public health authorities from Portugal shared information that clinicians in Lisbon had been reporting to them that they were seeing cases of young GBMSM men attending their sexual health services with a very unusual rash. These cases in the subsequent days were confirmed as monkeypox infection. Then on Sunday, the 15th of May, the UK detected 4 confirmed cases of monkeypox in GBMSM in London or linked to London. Then by the following Friday, so just in a 7-day period, 72 confirmed cases have been reported across the world from Europe, Canada, Australia, Israel. All were in men, and where information was known, all were in GBMSM. So cases continue to occur. Sorry, the slides are cut off. Cases continue to occur and spread worldwide over the subsequent weeks. And on the 23rd of July of this year, the WHO declared the global situation for monkeypox, so including cases in endemic countries and non-endemic countries, as a public health emergency of international concern. So just to speak a little bit about what that means. So a public health emergency of international concern, or a FEC, can be declared by the WHO based on the recommendation of an international emergency committee. And it should be declared if a disease outbreak is considered an extraordinary event, when there's a risk of spread internationally, and when it's considered that a coordinated international response is required. So the first meeting of the Emergency Committee of the WHO was held on the 25th of June. At that stage, there were probably about 3,000 cases worldwide across 47 countries, mainly in Europe or other high-income countries. At that stage, they didn't consider the event to be a public health emergency, but they did advise that the situation continued to be monitored and that they'd reconvene in a number of weeks to reconsider the situation. So they did reconvene on the 23rd of July. At that stage, there were 16,000 cases worldwide across 75 countries. There had also been several deaths, and I think one factor that contributed to their decision at that stage also was that there was now spread in middle and low income countries. So then the third meeting of the Emergency Committee just happened in the 20th of October, and they determined that the situation continued to be a public health emergency of international concern. I'll speak a little bit more about that later. So in Ireland, we saw our first case. The laboratory diagnosis came in on Friday, the 27th of May. That case, because it was our first case, it wasn't notified to our official system until the following week. So in week 22, which was the week starting the 30th of May, that first diagnosed case, along with 6 other cases, were notified. And now up until last Saturday, so just shy of the 6-month mark, we've had 214 cases, confirmed cases notified to us. So you can see, although there is week-on-week variation, you can generally see that there was an upward trend in the number of cases notified per week up until the mid to late August. So the highest number of cases notified were in the week of the 20th of August. And then a gradual downward trend in cases. So last week, we had 4 cases notified to us. So all but 2 of the cases notified in Ireland have been in people identifying as male, and cases have ranged in age from mid-teens to 65, and the highest incidence has been in those men aged between 25 and 40 years of age. We know the sexual orientation for about 90% of our cases, and amongst them, over 99% are GBMSM. 78% are resident in Dublin or the Greater Dublin area, where we have information on country of birth. 44% were born in Ireland, and 33.5% were born in South or Central American countries. 28.2% are known to be people living with HIV, and amongst those who are HIV negative, we know that 61%, where we have the information available, we know that 61% of cases are on PrEP. So that's just interesting compared to Martha's presentation, where 30% of the HIV negative cases are on PrEP. So in terms of the symptoms that cases in Ireland have had, the majority, so over 3/4 of cases have presented with either oral or anogenital rash, and 72% have also reported systemic symptoms such as fever, headache, fatigue. In terms of the severity of the disease, we know that 19 of our cases were admitted to hospital. A small number of them, so 3 were admitted for isolation purposes, and that was mainly in the early days when other facilities for isolation weren't available. And we know that 11 were admitted for the clinical care of their monkeypox infection. We've had no cases admitted to ICU in Ireland or no deaths. So where the most likely mode of transmission is known, the majority of cases, so 96.2%, have been deemed to be sexually acquired through sexual transmission. In terms of the sexual history of confirmed cases, from the information we have available, surprisingly, given that the cohort of younger people, the majority did have sexual or intimate skin-to-skin contact in the preceding 3 weeks. In the majority of cases, that was male-to-male contact. The median number of partners was 2, but it did range from 0 up to 75. And we know that 23 reported participation in group sex in the preceding 3 weeks. So just in terms of the global picture, up until the 16th of November, over 80,000 cases have been confirmed to WHO across 110 countries. The most affected country in terms of number of cases is the US and Brazil. And interestingly, 10 countries across the world account for nearly 90% of the cases. So just to show what the trend looks across different regions of the world. So this shows the weekly number of cases by the 6 different WHO regions. So you can see Europe is the pinkish color, and Europe was where the outbreak initially took off. So you can see it rises before the other regions, with a lag in the region of the Americas, which is just under in the blue. I suppose just things to point out in this, although the region of the Americas cases are decreasing, it's much slower and longer decline than what we saw in Europe. And there is a lot of inter-country variation in the region of the Americas, with some countries still seeing increases. And I suppose another interesting thing is the top graph, which is the region, the African region. So you can see in the early part of the year, a small number of cases, because these were endemic regions. But since the global outbreak started, the number of cases have also increased in that region. It's unlikely that there's a true increase in circulation, but probably more there's better detection as part of the overall increased awareness. So just in terms of deaths, so worldwide 52 deaths have been reported to the WHO. And I think it's just interesting to point out there is a huge disparity in the distribution of deaths compared to the distribution of cases. So if we look at the African region, although it only accounts for 12% of the cases reported, it accounts for 27% of the deaths. So just to focus on Europe, so far there have been over 25,000 cases reported in the WHO Euro region. The first case with known symptoms onset was the 22nd of April. So that was retrospectively identified, so before the first cases were recognised. And just the situation in Ireland really reflects what's seen in Europe in terms of the age group and the HIV status of cases and the severity of the disease. So I suppose one of the big questions is, why have cases gone down? It's probably several factors are contributing to it, and it's not clear the contribution of each of these factors. So the outbreak emerged and accelerated during the summer period, where there was a lot of travel, there were a lot of mass gatherings of social and cultural events, and which may be associated with changes in normal sexual behaviour, so increased partners. And there may be behavioural adaptations, so those most at risk may have reduced partners or practiced safer sex. Immunity after vaccination is probably a contributing factor. However, several countries noted that the cases began to decrease before they implemented their vaccination campaign. And they've also decreased in several countries where their vaccination campaign has still been very limited. And there may also be an element of immunity from previous infection. So those most at risk may have already been infected and now have immunity. So what might happen next is a big question, and really we don't know. Modelling from the ECDC suggests that between 55 and 95% of GBSM are still susceptible to infection. So that's a very wide range, and there's lots of caveats to it, but I think most of us would accept that there's still a huge cohort that are susceptible to infection. ECDC outlined several future potential scenarios. So one is that the outbreak will resurge. One is that the cases will continue at a low number, with sporadic outbreaks occurring linked to specific travel associated cases or specific mass gathering events. And the third scenario, which they don't consider likely, is that the cases will wane and it will finally be eliminated across Europe. So, sorry, I am 2 more slides. So in terms of the current assessment of the situation, ECDC, in a rapid risk assessment of the 18th of October, determined the risk for monkeypox infection for MSM within Europe as moderate. The WHO, at their third International Emergency Committee, as I said earlier, determined that the situation remained a public health emergency of international concern. They're particularly concerned about the region of the Americas, where they upgraded their assessment of the risk from moderate to high. For Europe, they downgraded it from high to moderate. And the main reasons they gave for their ongoing concern was that there was ongoing transmission in some regions, and several countries across the world were still not very prepared. There is emerging potential for greater health impact in some vulnerable populations, and there's a continuing risk of stigma, and there are a lot of research gaps, so there's so much that we still don't understand. So given all that, what do we need to do? And I think the main thing is that we don't become complacent by our low number of cases currently that we're seeing. We have to continue our ongoing multi-sectoral coordination with really strong community engagement, with actions across the whole spectrum from prevention to clinical diagnosis, management of cases, surveillance. We also really need to focus on research, so we need to better understand what happened, what's happening now. And an important thing is that while monkeypox is circulating anywhere in the world, there's also always a risk to us here in Ireland. So regardless of any moral obligation for equity, we have a very selfish reason as well that we need to ensure that there's a response across the world. So we need to advocate for greater global equity and access to diagnostics, therapeutics and vaccines. So I'd just like to thank all those involved in the surveillance of monkeypox in Ireland. So our team in HBC, Departments of Public Health, the labs and the sexual health services, and most importantly, those people that have been diagnosed and that have shared their information with us. So thank you very much.
Thank you very much, Eve. That brings us right up to break time, but I think it's worth giving over a few minutes to questions and answers there. We've had 4 very excellent presentations with a lot of dense information in each of them. So I'd just like to open to the conference any questions that people might have. It's an unlikely shy group of people we have today. Yeah, sorry, Nick.
I was just wondering, one of the ones that struck me was the SH24, that I used is brilliant. But the prescription for treatment, do you have to pay for it? Because under the infectious disease act, we have to have free, so that's why clinics.
That's why it's being clinics, yeah, and so we hope that we would hope that by the end of Q1 2023 there will be an option for entirely management of complicated chlamydia within the online service. So the person doesn't have to go anywhere apart from community pharmacy. The step to getting access to free medication will take a bit of time to do it. So by the end of Q1 2023 we won't have that in place. I will say, however, that doxycycline is the first choice medication that we use for this infection. It's one of the best antibiotics that was ever made, and we use it widely. is not expensive.
No.
It's cheap as chips. And actually, interestingly, in James's company, what we had to do is we adopted this model for uncomplicated infections in James's in the pandemic, where we wanted to, from a population level, there was still restrictions on movements, people who were diagnosed with chlamydia through the LIS to have testing service. Within James's, we developed an option for individuals to have their prescriptions sent to their community pharmacy. We haven't looked at the figures, but I can tell you based on the volume of requests, the volume of get prescriptions, that a significant number of individuals, despite having to pay for it, will actually opt for this less complex route of going to a community pharmacy of their choice.
Yeah. And it's, yeah, I mean, cost of living and all that, but it's not even about paying, it's that principle of that.
No, I know, I
That's
understand.
really,
Yeah.
So you're speaking a mechanism for it, that's
Yeah.
the difficult.
I don't understand.
We got the mechanism for that, not easily, and we will get there.
We have another question at the back there.
I know statistics aren't there, so is it expected or imagined that the populations that aren't under as much health surveillance because they're not going to regular prep appointments, they're not going to regular STI checks, that there are more cases of monkeypox?
Potentially, yeah, and I think that's a factor. I think, and you could say the exact same thing for before COVID, when you looked at the cases, and I was thinking, hopefully I'm speaking out of turn in terms of interruption of the data, but when you look at the cases of syphilis before the pandemic, a significant proportion of those were individuals were asymptomatic, and probably because of it, they were engaged with healthcare and having testing. So you absolutely there may be undiagnosed, unrecognized cases within the community. From a clinical perspective, what I would say is that we were very keen, and it has been adopted, but there's a very low, very sensitive definition for using the type test, and we've adapted that. That's adapted as we learn more about how people may present with this infection, and also working with the community around developing videos to kind of, if people felt deterred from coming forward for testing, to try and demystify the situation a little easier. So there may be some factors to mitigate. That's from a clinician's perspective.
So maybe that's okay, just about, I suppose Eve, I think, said that there are a lot of unanswered questions, and one of the unanswered questions is, so there's studies on the just on the UK and one in Berlin, actually looking to see whether there is, people may have it but without symptoms, and I think that's probably still an unknown, so that would be relevant to them, not only with people who are screening, but whether it's really, if it really is asymptomatic, then you will be presenting them with
Yep.
Check about the SH24 kits. We've had a number of clients come back and say they struggle to do their blood sampling. I'm just wondering, is there any information about the number of kits returned that have been able to have a complete screen? And make sure you're running, well, because the number of people that pay because of results.
In the evaluation of one in 10, let's say the kids were to complete and missing or
Fiona, sorry, I'm just wondering what uses microphone view. I'm not sure if everybody can hear what's going, your replies. Okay. Sorry.
So the question about the blood testing part of the STI testing service, I can do evaluation of 1 in 10 for some reason, because of either because of difficulty doing the test or it was incomplete, and that may have been down to the user's challenge with getting it, but also the sample may have been raised, which may not be entirely down to the user's interface with the kit. So well, this is a phenomenon that is not unique to SH24. It's the same with all self-sampling blood testing kits. I know that if I were to try and do it for myself now, because my hands are cold because I'm a bit nervous chatting to you guys, but it would be more difficult for me to do it, and sometimes get people, like when I've done this in the prison session, get people to sit on their hands before they come forward, try and get their fingers nice and warm. The SH24 is analysed, the service needs to be very responsive to those challenges that people are having, so they have developed resources to make it easier, like YouTube videos around how to try and get the test. I suppose in time we may move to a position where if there is really good HIV testing across the population. We may not need to always include the blood test as part of the kit that's offered to people. But I don't believe we're at maturity, a position of maturity around normalisation of HIV testing in our population at this time. So we do need to continue to make that offer. But the return, like they do know that if you don't include the blood test in the return, in the offer, you will get a better return rate. So it is definitely impacting, but we're not at a level of maturity in terms of how we offer HIV testing and have normalised HIV testing within the population to make that offer as yet. And the steering group has been stood up to oversee the rollout and to try and understand the impact and to how the service needs to flex as time goes on, and when we get to a position of having more widespread availability of testing, more widespread practice of testing, and whether or not it can be not included in the kit. But I don't know if there's any way you can make it any easier other than giving people the information.
Okay, thank you. I think we had one more.
Yeah.
It's for me.
Yeah. Yeah, so I just want to understand the 13 clinics that you presented, because you know the bigger the number of service providers are there, then the wider the reach of PrEP. So how will they be like geographically distributed in Ireland? Like assuming somebody in Lisbon wants PrEP. So how easy will it be for this person? Then number two, what will be the characteristics of these clinics in terms of, you know, some of us who cannot access PrEP in some types of clinics?
So, there's no doubt, Andre, that we definitely need to increase the number of providers. And in order to do that, we need to make it possible for providers to have the correct training and resources to ensure that they provide a good service. The pandemic has, the other thing, the impact of the pandemic and cyber attack on, we've never audited how we're doing in respect of PrEP, so we need to be really careful around. We definitely need, I know we need to increase the number of providers and we need to increase access for sure. But before we go too much further forward, we need to also understand how we're doing. And we haven't had an opportunity to do that because of the impact of everything that's happened in the last 2.5 years on everything that we do. So people need to not only have access to PrEP, they also need to have access to PrEP that's delivered in line with the national standards, and we have to really ensure that we hold those standards in high regard and ensure that providers are able to provide it. And that's not to say that somebody in Lisbon couldn't provide it to standards, but just to make sure that we do it that way.
Okay, thank you very much. I think we'll leave it there for now. We'll just go on to our break, coffee break. So enjoy that and have chats there.
To make it easy, there's 3 tables of tea and coffee in each, and then the last
I'm Susan. I'm the coordinator of our prevention, education and training services at HIV Ireland. And I'm a big Star Trek fan. Any Star Trek fans here? Yes. Oh, there's a few. Oh, brilliant. Well, the name of this session is called New Horizons. So that's why I mentioned Star Trek fan. And New Horizons was the name of a NASA space probe that was launched in 2006 as part of a New Frontiers program. And its primary mission was to perform a flyby study of the Pluto system. And it didn't get to the Pluto system until 2015, some 9 years later. But at the time, it was the fastest man-made object ever launched from Earth, with a speed of 58,500 kilometers per hour, or 16.26 kilometers per second. And that record wasn't beaten actually until 2021 by the Parker Solar Probe. But what's my point? Well, I'm not expecting my speakers to speak that fast, but we have gone a little over time. So I will be holding you to, I'll let the alarm go off at 13 minutes and you'll know then you have 2 minutes to wrap up, okay? So let's get started, inviting David Field, who's a clinical nurse specialist at the Mater Hospital Sexual Health Clinic, and he's going to present some preliminary findings on a review of risk related to sexually acquired infection and sex between men since 2015. I'll just get your presentation up, David. Thank you. At your own risk, that's it. No. Thanks, David.
Thank you. Hi, thanks very much. It's lovely to be back at the Gay Health Forum with so many people I've worked with and have taught me like everything I know about sexual health, so it's really nice to be here. Yeah, I'm David. I'm the clinical nurse specialist for the Sexual Health and PrEP Clinic in the Mater Hospital, and I'm the mysterious new sexual health advisor for the Gay Men's Health Service as well, so thanks for that earlier. I also started my PhD in 2021 looking at the concept of risk and how it relates to sexually transmitted infections and sex between men, basically. So I stole the title of this presentation from Derek Jarman, who was an artist, director, author and gay rights activist. And he said, understand that sexuality is as wide as the sea. Understand that your morality is not law. Understand that we are you. Understand that if we decide to have sex, whether safe, safer or unsafe, it is our decision and you have no rights in our lovemaking. And that quote just kind of, I suppose, underpins kind of like the perspective that I'm bringing to the PhD research and to my clinical practice as well. The background is gay and bisexual men have long been associated with high-risk sexual behaviours, particularly the HIV and AIDS epidemic of the 1980s and 90s. But over the last number of years, the landscape of sexual health has changed dramatically. As we've spoken about this morning, the introduction of the National PrEP Service in Ireland, which kind of coincided with the initial partner study, which paved the way for the U equals U, or the undetectable equals untransmittable message, being adopted by the World Health Organization, the NHS, the HSE, the CDC, and kind of leading health organizations globally. So that's really changed, I think, the perspectives of sexual health and risk related to gay and bisexual men. But what I was interested in, I suppose, was getting a greater understanding of if that change is reflected in clinical practice and in research. So the research question was, how has risk been related to the sexual health of gay and bisexual men been conceptualized following PrEP and U equals U? The aim is to investigate the perspectives on risk related to the acquisition and transmission of sexually transmitted infections, including HIV. And kind of my rough hypothesis was that definitions and conceptualizations of risk and risk behavior vary substantially from clinicians to gay and bisexual men to policy workers, etc. So what I've done so far, we've chosen the databases. I kind of carried out a fairly systematic literature review, not fairly, really systematic, and using Medline, Synal and Scopus. Our population was gay and bisexual men. We used the search term risk and some other kind of, I suppose, synonyms for gay and bisexual men. And then also sexually transmitted infections, or STD, sexually transmitted disease. And we use kind of, I suppose, the big five that would have been identified in BASH guidelines for testing with gay and bisexual men, which would be chlamydia, gonorrhea, HIV, hepatitis C, and syphilis. We were looking at cross-sectional perspective, randomized controlled trials, kind of a vast kind of selection of different research. And then our inclusion and exclusion criteria, we were looking at research that was published between 2015 and 2021, because we wanted to see research where, I suppose it was that post that PrEP and U equals U era, and then pre-COVID, which I feel probably altered how people perceived risk as well. Research was from our selected regions, Europe, North America, Australia, New Zealand, and collected before January 2020. And that, again, was just, I suppose, to kind of thwart the effects of COVID. So we found lots of literature. I found 7,417 articles. And after doing a title and abstract review and removing any duplicates, we got it down to 1,724 pieces of literature. Which for anyone who's done it is still way too much research to look at. So we kind of have to go back to that research question and say, well, what are we doing here? Initially, this was supposed to be a systematic literature review. I was never going to be able to get through that much research in that way. So we were left with two options. It was either to change the scope of the research, maybe to focus only on the UK and Ireland, maybe to change the population slightly and look at one section of gay and bisexual men, or to change the approach that that we were taking to kind of come to our conceptualization. And changing the scope of the research didn't sit well with me, because I suppose what I was setting out to do was get a better understanding of how risk is being conceptualized in a broad way, as opposed to kind of looking really specifically at certain geographic areas or certain subgroups. So how can we answer this question? So I went back and we looked at different kind of methodologies. And what we've landed on really is that we're doing a scope and conceptual review using a data saturation approach that was outlined by Francis et al. So data saturation, for any qualitative research in the rooms, will be researchers in the room will be really familiar with that. It's where generally when you're doing interviews, you maybe do 10 interviews and then continue interviewing participants at a rate of 3 people per kind of set of interviews. And once you do 3 consecutive interviews where no new data emerges, you've reached that saturation point, and that's where you kind of start analysing the data. I'm doing that same approach, but with research papers. So initially, so at the point I'm at now, I've reviewed the initial 10 papers and coded them using NVivo, which is qualitative research software. And my plan now is to continue reviewing papers in groups of 3 until no new data or conceptualizations of research emerge. The data is then going to be analysed to develop a new comprehensive conceptualization or model of risk. So far, this is what NVivo has given us back recently. So these are the words that have come up, the 100 most frequently used words in the papers that we've reviewed so far. And it's nice to see that risk really is in the middle of that. So researchers are talking about risk, clinicians are talking about risk. Actually, what I can't stop doing now since I started this is counting risk. And we've mentioned risk 13 times here today, but I don't know necessarily each time what we were talking about. At present, risk has been conceptualized under the following broad categories. So we're looking at behavioral risk, biomedical risk factors, demographic, external and environmental risk factors, knowledge-related risk factors, so that would often be knowledge deficits, outcome-related, so if we're purely looking from an epidemiological perspective and we're saying, well, risk is associated with the outcome, which is acquisition of an STI, a lot of the papers will take that approach. Psychological, social and interpersonal, and my favourite, which is undefined, where people talk about risk as if it's this kind of magical creature that, you know, that we can't really pin it down, but we know it's there and it's something. And I'm hoping to be able to dig into that a little bit more. And I really like this chart. So NVivo also, as you're going through and you're coding the different kind of implicit and explicit definitions of risk, from the last slide, these are kind of, I suppose, the frequency. So the bigger the square, the more conceptualizations or definitions of risk which are in that category. So we can see that behavioral definitions and demographic definitions of risk are the 2 biggest ones. Demographic and population-based definitions of risk are problematic in a lot of ways. You know, I suppose discussing an entire group or an entire like cohort of people as inherently risky, generally, you know, it isn't. I don't know about the appropriateness of that in research or in from a clinical perspective. And then you can see that they kind of do get smaller as they go down. So the kind of psychological components, outcome related, I was surprised at. I thought we'd look at risk from an outcome perspective a lot more in research, but so far that doesn't seem to be the case. And then just zooming in on one in particular. So the biggest one, behaviour and risk. So things that tend to increase risk amongst gay and bisexual men from that research perspective are things like alcohol use, attending sex on premises venues, inconsistent condom use, or just condom use, or condoms anal sex in general. Drug use, esoteric sex, which I thought was a lovely way of putting fisting. MSM sex. Multiple sexual partners, prolonged encounters, violence. PrEP use has been highlighted in both perspectives, so it both increases and decreases risk. We know it decreases risk from a HIV perspective, but it has been linked with increasing risk from other STIs. So what might a new model of risk look like? So I imagine that it will, or I hope that it will encompass the different kind of categories that we've identified in the research so far. But also, is it intersectional or relational? Are there, like, how does behavior kind of, I suppose, relate to demographics, which relates to psychological risks? And that's something that I'm really looking forward to kind of digging into as the research continues. And the practical applications of this, I suppose, in my work every day, you know, risk is a term that's regularly used in sexual health assessments and consultations and policy. But with so many definitions emerging, what are we communicating when we're talking about it? Is a healthcare professional's meaning of risk the same as a patient's? Is that the same as a policymaker's? Is there potential for miscommunication or poor outcomes related to sexual health? And are there cultural components involved to risk as well, which we're maybe not fully understanding? And then the real world applications as well. I suppose we're seeing more and more PrEP assessments, identifying people for monkeypox vaccines, identifying people for syphilis testing. We often attempt to do this through the lens of risk, but that definition is so nebulous that I'm not sure necessarily what we are doing there. And I suppose it is all about targeting approaches and using the limited resources we have in the most efficacious way. So that's my reference. And that's me. Thank you very much.
Thanks very much, David. We pulled up a bit of time there, all right. No. I learned a new word in esoteric. Yeah. Don't you love the English language? Now we'll just get this up. Now I'm delighted to introduce our next speaker, Kitty O'Sullivan, who's a health psychology graduate with NUI Galway, who's going to present to us on critical evaluation, how HIV self-testing constructs and shapes our opinions and experiences both individually and collectively. Thanks very much, Kitty.
Hi everyone. So I'm going to talk to you about a study that I did as part of my Masters in Health Psychology at the University of Galway, and I just want to firstly acknowledge the rest of my research team, Siobhan Healy-Cullen and Chris Noon, who were my co-supervisors on the project, and also Adam Shanley, the manager of Empower, who worked with us on this study also. So this study set out to explore the meaning of HIV self-testing in Ireland with specific relation to the Empower HIV self-testing service. So we were interested in understanding the socio-cultural context which underlies the experience and the acceptability of HIV self-testing. And we also wanted to evaluate the ways in which HIV self-testing, in comparison to more traditional forms of in-clinic testing, could create and shape new subjectivities on both an individual basis and for the collective. So we conducted a qualitative interview study, and we had 15 participants who took part in semi-structured interviews, and the questions in those interviews were constructed in relation to the theoretical framework of acceptability. All of the participants were users of the Empower HIV self-testing service, and they had consented to be contacted for research purposes when they ordered the test. So 13 of the participants identified as gay, 2 identified as bi. The ages range between 18 and 64 with a mean of 36. Nationalities included Irish, Filipino, Mexican, and Argentinian. 11 were single, 2 were married, and 2 were in a long-term relationship. So we used a social constructionist perspective in this research. And by this, I just refer to the fact that the results are seen to be reflective of conversations which happen within the specific context of a research interview. So they don't necessarily reveal a universal truth, but they're based on knowledge derived within that specific context. We used critical thematic analysis to produce our themes. So this involved identifying patterns of meaning within the interviews. And then that critical aspect involved linking the patterns of meaning with wider social ideologies and dominant discourses. Reflexivity was an important aspect of the project, which involved myself making extensive notes and journaling throughout the process in order to maintain awareness of how I, as the researcher, influenced the process of collecting data and producing the themes. The theoretical lens that we conducted our analysis through involved theories of biomedicalization, biopower, biocitizenship, and the sexual and reproductive justice framework, which are cited at the end because I couldn't fit them all into the slide. So this is like our analysis was, I suppose, very in-depth, as qualitative research tends to be, but this is, I suppose, a breakdown of our key findings. So number one there, self-test shaped imperatives to test for HIV, but it also made those responsibilities to test easier to fulfill. So we saw in the interviews that participants did demonstrate a strong sense of social responsibility to engage in testing behaviours, but that the motivation to test is not always driven by a concern around exposure, but it can be sometimes driven by a desire to confirm one's negative status or to be seen to be doing the socially responsible things. We can see in Frank's quote, you know, he talks about I suppose really feeling that it was most likely that he would be negative, but he still wanted to test. And then in Frank's quote, he talks about, in Colm's quote, he talks about self-testing as being something you do to take care of yourself, to get a handle on your health, again, demonstrating that not knowing your status or being untested can be seen as a threat to health. And that self-testing, I suppose, again, is a demonstration of fulfilling that responsibility, demonstrating what's called, you know, good biocitizenship through health maintenance. Our second finding related to risk, which David, I'm sure, will be happy to see. So self-testing acts as a tool through which self-perceptions of risk are managed and transformed. So when I talk about risk here, I'm referring not to objective risk in a clinical sense, but to the social categorization of risk and the way, I suppose, participants manage that feeling of being perceived to be at risk within their sexual and social lives. So for participants, self-testing created new categorizations in which self-testing regularly made them feel either less at risk or less risky. And in this sense, self-testing transformed those personal knowledges. So Patrick talks here in this quote about, he describes himself as someone who gets tested regularly, and therefore he sees himself as somebody who doesn't put himself at risk. He also talks about being really worried or not being really worried about the test result because he was getting tested frequently. George also talks about the fact that he was keeping on top of it, the fact that he was doing it regularly meant that there wasn't the same anxiety around testing as there would be for somebody doing it for the first time. Again, suggesting that process of self-testing regularly can make people feel less at risk in terms of social categorization and how they experience that feeling of being perceived to be at risk. So in the center here, I have included a reference from RACE 2021 in order to distinguish between the two differing perspectives that exist around HIV self-testing within the literature. So in some ways, self-testing is seen to be part of the biomedicalization of sexuality, where sexual practices and therefore sexuality produces a requirement for individuals to engage in biomedical practices. And sometimes this is seen as an imposition of medical authority in people's lives. However, Race also argues that we could be seeing, or he reconceptualizes this as the sexual socialization of biomedicine, where biomedical objects and practices, things like self-tests, are seen in more normalizing and sex-positive terms, rather than being seen as purely biomedical. And they're kind of, I suppose, seen as something that can facilitate people within their sexual and social lives. So this concept was evident in our research. Number 3 there, we saw how self-testing was a means of offering increased agency and symbolic demedicalization. So a lot of the participants in the study talked about feeling uncomfortable accessing traditional clinical spaces. And there was lots of reasons for this, but primarily there was an anticipation of judgment on a social level. And this also related to that perceived association between being risky and needing a test. So participants felt that by virtue of going to a clinic and asking for a test, they were admitting to being risky. And this was, I think, particularly troublesome to them because they didn't see themselves as risky, and rather they actually saw themselves as, being responsible, protecting their health and that of others. So self-tests, on the other hand, were not seen to represent an admission of risk-taking. And I think this is because of the amount of agency involved in terms of a person ordering their own test, administering the test, interpreting the result. It really places them almost as being their own healthcare provider, rather than being a passive subject. And it allowed them to demonstrate to themselves that they weren't risky, they were responsible. And I think Brendan really highlights in his quote, he really captures this. So he talks about being on the phone to a friend when he was doing the self-test, and he just brought it into the conversation. And, he does say that it was a close friend, but he still says it felt easier for him to take ownership of doing it, to say to somebody, I did this, and not feel weird about it, in comparison to having gone to STI clinics in the past, where maybe that wasn't something he would have shared with a close friend. So we really see how that sense of agency and regained control feels like a positive step forward. The final aspect that I want to address is around how self-testing can address some social and structural barriers to testing. There was a keen awareness amongst all the participants of the multiplicity of factors that could prevent somebody from accessing a HIV test in a clinic. And I think in terms of community mobilization, people were highly aware that offering an alternative to people who just felt they would never be able to walk into a clinic and ask for a test was really, really important. And so some of the factors that I suppose that they touched on were things like this was structurally not having access in your local area, having to travel long distances, socially that stigma or shame associated with accessing services. But one of the more subtle aspects that we identified was the way in which people's ability to access service can be restricted by the perception that health services are underfunded or under-resourced. So some participants talked about not seeing themselves as risky enough, not being as in need of services compared to other people, which kind of forced them, I suppose, to engage in negotiations around whether they had the same needs and rights to access as somebody else. So in Brendan's quote, he talks about how the self-test service allow the schedule to be freed up for people who actually need treatment, for people who actually need PrEP consultations, etc., because these things are important and they need a clinician. So the self-test doesn't conjure up this notion of scarcity, I think primarily because there's no reliance on healthcare professionals to administer the test. In Graham's quote, he also talks about, feeling guilty ordering the test because he says he's not super sexually active, and he knew he was okay. But then he says, why not? So I think there was an aspect as well that with self-testing, not only are you not being judged in the sense of being perceived as a risky person, but you're also not being asked to justify why you want the test, which makes it more accessible overall. And lastly, I just want to highlight the perspectives of participants with multiple marginalised identities. So one of our participants was part of the deaf community and 3 participants were non-Irish nationals. And they emphasised that the self-testing service was much easier for them to access in the context where they were unsure of whether they had this equal rights to access for the people who were non-Irish nationals and what that process would be like for them. And then in the context of also being understood or accepted or treated as an other within traditional clinic spaces. So this quote from James, who was hard of hearing and was part of the deaf community, he talks about panicking, being in the waiting room of a clinic, that he wouldn't hear his name and how stressful that was. And I suppose being in an STI clinic, you're already feeling vulnerable, and then those extra worries and concerns, having to notify somebody that you're deaf, draws more attention to you and makes you feel more uncomfortable. So I think this perspective really highlights the ways in which self-testing can offer a much needed alternative for people who maybe don't fit the parameters of the way in which traditional clinic spaces operate. So in summary, I think the self-testing service has transformed the experience of HIV testing and has certainly reshaped the impact of HIV risk and HIV testing in participants' sexual and social lives. However, of course, there remains a need for holistic approaches to HIV prevention, which are attentive to the social context, which can hinder engagement. So I'm happy to take any questions. And if anyone has any questions after the study or would like more information, my contact details are on screen. Thank you so much.
Thanks very much, Kitty. I'm sure there will be questions afterwards. Close that down. And we'll try and take questions we mightn't take questions at the end of this session, but what we'll do is we'll take them maybe at the end of the session directly following this, so that we keep time. And just remind people, if you are tweeting, use the hashtag #GHF2022. And I'm delighted to introduce the final speaker for this session is Philippa White, who is a specialist registrar in public health medicine in HSE South. And Philippa is going to present to us on exploring the prevalence of and factors associated with self-reported hepatitis A and B vaccination in GB-MSM.
Great, thanks, Wayne. Hi, it's lovely to be here. My name is Philippa. As the host said, I'm a specialist registrar in public health medicine, and I'm delighted to be here to present these findings on behalf of a group of us who did this study. So we looked at the prevalence of and factors associated with self-reported hepatitis A and B vaccination among gay, bisexual and other MSM in Ireland. So before I begin, I just want to thank all of the co-authors of this study. I think some of them are here today in this room, and I don't think I've ever met any of them in person, or some of them in person, so it's a bit odd, but thank you so much to all of them. And thank you for letting me present on your behalf. So very briefly, for those of you who are not familiar or very familiar with hepatitis A and B, hepatitis A is a virus that causes hepatitis or inflammation of the liver. It usually causes an acute, mild infection, but rarely it can cause a relapsing infection, and very rarely it can cause a severe, sudden inflammation of the liver or hepatitis, leading to liver failure and death. Transmission or spread normally occurs when you come into contact with an infectious person or after you ingest contaminated food or water. And after you get infected with hepatitis A, you're immune for life, which is good. And as you can see from the graph on the left-hand side, the case notification rate has dropped in Ireland for hepatitis A significantly in the last 2 decades, which is great. But on the flip side of that, it means that most of the population is not protected against hepatitis A and is therefore vulnerable to infection. Hepatitis B causes an acute and a chronic infection. So it unlike hepatitis A, which is mostly just acute, mild infection, hepatitis B can lead to, if you are in the minority of adults who get infected with hepatitis B and you can't clear the infection, over a number of years and decades, you can go on to have liver damage and develop complications such as liver failure, cirrhosis, liver cancer, and death. The spread of hepatitis B is normally through coming into contact with contaminated body fluids. And so that's a quick round of hepatitis A and B. So for GBMSM, this is an important topic because they're particularly vulnerable to hepatitis A and B infection due to a higher prevalence of certain particularly sexual risk factors. And as a result, GBMSM are disproportionately, carry a disproportionate amount of the disease in Ireland. So although GBMSM account for roughly 6% of the male population, I looked at some of the data of hepatitis A and B in Ireland over in the last few years, and they account for roughly 18% of the cases. So very disproportionately affected. And as a result, they're recommended to get vaccinated for both hepatitis A and B. And unlike something like COVID, where you've got your lovely mass vaccination centres and you've got lovely databases and everyone knows who's vaccinated and when and so on, hepatitis A and B vaccination does not happen as systematically, and it occurs opportunistically in STI services and GP practices. So as a result, it's not certain what proportion of the community is vaccinated and what proportion is not protected against infection. So the aim of this study was to try and estimate the prevalence of previous hepatitis A and B infections in GBMSM in Ireland, as well as estimate the vaccination coverage against hepatitis A and B in this community, as well as explore some of the factors associated with being with vaccination. So we used the Irish data from the European MSM Internet Survey 2017. I'm sure many of you in this room are familiar with that survey. It was a large survey that was done in 50 countries, mostly in Europe, that looked at the health needs and behaviours of GBMSM in those countries. And so we used the data from those who responded to the survey in Ireland. And so EMIS 2017 was an online anonymous survey, and the participants were cis or transgender males living in Ireland who were at or above the age of consent. And at the time in 2017, 2018, there were about 4 months to respond to EMIS 2017, and participants in Ireland were recruited mostly through, through a number of channels, apps, social media platforms, NGO websites, and so on. So in this study, we took the data from the Irish respondents to EMIS 2017. We looked at their responses to the questions about whether they were previously vaccinated against hepatitis A and B and whether they were previously infected with hepatitis A and B, as well as many other responses. And so we used those data to try and estimate the proportion who said that they were previously infected or previously vaccinated. And we also did some statistical modelling to try and look at some factors that are associated with hepatitis A and B vaccination. And also we analysed men living with HIV separately, just because we predicted that they would be more likely to be vaccinated due to the high level of planned formal engagement with health services. And if we thought that if we included them in our primary analyses, that it might bias the findings. So we analysed them separately. So in terms of the results, there were over 2,000 respondents to EMIS 2017 in Ireland. And then excluding the men living with HIV, there were about 1,941 men who responded to EMIS 2017 in Ireland. And actually, those figures all below all relate to HIV negative men. So there was quite a young cohort. 32 was the median age. The vast majority identified as gay. 3/4 were born in Ireland, over half were living in Dublin, And also apologies, I've updated these slides and these are the old slides, so apologies, but also wanted to highlight that it was a very well educated group. Over 70% had at least undergraduate level education. And of note, just below half of all respondents were out to all or most of the people they knew. So as I said, the respondents to EMIS 2017 were asked about if they had ever been infected with hepatitis A or B and if they'd ever been vaccinated against hepatitis A and B. And so these were their responses. So as you can see, for just over half said that they had they were either fully or partially vaccinated against hepatitis A and B, and that means they received at least one vaccine dose. A very small minority said that they had previously been infected with either infection, and then a sizable, not insignificant proportion said that they were either unvaccinated or they were unsure of their vaccination status. And as I said, we looked at the factors that were associated with saying you're vaccinated against hepatitis A and B. So we found that men were less likely or had lower odds of saying that they've been vaccinated against hepatitis A if they lived outside of Dublin, and if they had at most second level education, if they had lower levels of knowledge about hepatitis A and B, if they'd not been tested for HIV in the last year, if they'd never tried to obtain PrEP, and if they'd not been diagnosed with an STI in the last year. And in this case, an STI relates specifically to chlamydia, gonorrhea, or syphilis. Then for hepatitis B vaccination, the findings were almost the same. And men were less likely or had lower odds of saying that they've been vaccinated against hepatitis B if they lived outside of Dublin, had at most second level education, lower levels of knowledge about hepatitis A and B, had not been tested for HIV in the last year, never tried to obtain PrEP, had not been diagnosed with an STI in the last year, and identified as bisexual or other. And there were a small cohort of men who were living with HIV, and as predicted, they did have a higher proportion reported to be vaccinated against hepatitis A or B. Sorry, take a little bit of water. And also, there were some similar findings with the men who were HIV negative. So men had lower odds of being vaccinated against hepatitis A or B if they had lower levels of knowledge relating to hepatitis A and B, and they had lower odds of being vaccinated against hepatitis A if they were not diagnosed with an STI in the last year. So, in summary, we found that there was a small proportion of respondents who said that they'd previously been infected with hepatitis A or B, which is very good. But on the flip side, we found that just over half of all men said that they were fully or partially vaccinated against hepatitis A and B, which is obviously suboptimal. And we found that there were the same factors, very similar factors associated with lower levels of vaccination against hepatitis A and B, and they were living outside of Dublin, having lower levels of educational attainment, having less engagement with health services, and identifying as bisexual or other. So that's the findings from the survey, but what does all of this mean? So I think the main point from this study was that we need to improve vaccination coverage for hepatitis A and B among GBM-SM in Ireland, just over half said that they had received either at least one vaccine for either infection. So we found that men who lived outside of Dublin had lower odds of saying that they've been vaccinated against hepatitis A and B. And so clearly we need to expand our sexual health services. As many of you here are aware, the sexual health services in Ireland are very much concentrated in Dublin. And out of the 26 counties in the Republic, there's only 15 of them that have publicly funded STI services. And that is where men can get vaccinated for hepatitis A and B for free. So we need to expand sexual health services to all parts of the country so that men living in Monaghan, Cavan, Wexford, Kilkenny, wherever, will not have any barriers to accessing vaccines and will not have to pay out of pocket to go to a private clinic. We also found that men who don't engage with the traditional health services, as we saw by they're not getting tested for HIV, not being diagnosed with an STI, and so on, they're much less likely to be vaccinated against hepatitis A and B. Therefore, we need to meet these men where they are and think about new services, such as having vaccine clinics in outreach locations or having mobile vaccination clinics. We also need to put explicit vaccination targets in service delivery contracts. So if someone is going to be the head of a sexual health clinic or open up a clinic, it needs to be in the contract to say, these are the hepatitis A and B vaccination targets that you must reach, and to incentivize healthcare providers to meet these targets. And also, there's no explicit targets about hepatitis A and B vaccination in the National Sexual Health Strategy, and that's wrong. There should be explicit targets to raise awareness and to create that incentive. And finally, as we saw, men who have less knowledge about hepatitis A and B are less likely to be vaccinated against them. Therefore, we need to increase the awareness about these infections. I know there's been a lot of, efforts to do that in the recent years, particularly with hepatitis B, but it's not sufficient. We need to improve this. So I don't think I have enough time to go through all of the strengths and limitations, but I think one of the main strengths was that this was anonymous and online. So any male could respond to it, which was good, and therefore men who are not out to everyone were able to participate freely, and theoretically everyone could answer very honestly and openly and so on, and potentially more openly than in a face-to-face survey. And one of the main limitations of this was that so rather than men were asked if they'd been infected or vaccinated against hepatitis A or B, but this wasn't followed up with looking through medical charts or looking through blood results to corroborate that answer. So as a result, using self-report may not be the most accurate way to measure hepatitis A and B infection and vaccination. So that's an important limitation of the study. So in conclusion, we found that there was a low prevalence of self-reported hepatitis A and B infections among GBMSM in Ireland, which is very good. But on the flip side, we found that the self-reported vaccination coverage was suboptimal and needs to be improved. Some GBMSM have lower odds of being vaccinated, and they include men who live outside of Dublin, who have less education, and who do not engage with health services. And so we need to take action immediately to try and increase vaccination coverage for this community. So thank you so much. Very happy to take any questions, and my email is at the bottom if anyone wants to give me a shout after this. Thank you very much.
Warp speed, guys. Warp 7, that was. Can I just ask David, Kitty and Philip, if they're staying around? You'll still be here after the next session. Okay, well then what we'll do is we hold the questions until the end of the next session because we may make up some time there. So I'm going to just thank David, Kitty and Philip for wonderful presentations, and hold those questions, guys, for afterwards, okay? Thanks a lot. I'm going to hand over the captain's chair now to... Are you Janeway or retired? Are you? Okay. To Dr. Trevor Lygo, who's going to chair the Noel Walsh Memorial presentation. Thanks, Trevor.
I'm asking Church to do the timing because we have to shorten the time. And I realise the biggest challenge for this session is to chair because it's between yourselves and your lunch. But there's a really important session that we're speaking about now, which is the Noel Walsh Memorial presentation, and we have Fury and R for this. Could I ask, we're starting with video, and then I'm going to ask Enda Veda. Is Enda Veda? Oh, brilliant. Brilliant. Do you want to come up here and sit up here, and we're going to then start with the video, and then we have a bit of a chat, if that's okay?
Yeah, absolutely.
Brilliant.
On? While getting this ready, the bad thing is that the weather got cold, but the good thing is we ordered soup instead of taking coffee for lunch, so we won't do it.
U equals U stands for undetectable equals untransmittable. And what it means is that the person who's living with HIV, who's on effective treatment, gets the viral load so low in their body that they can't pass it on to a partner. was a huge game changer for me personally because I became HIV positive in 2009. So your biggest fear was passing on the virus to somebody else. Then U=U came along, and it was hard to get my head around the science to really accept it in the beginning. But now that I have, I think it's just one of my favorite kinds of activism to promote because it's such a positive message, and yet so many people out there don't realize that that's the case. This journey that I've been on with HIV activism has made me fall madly in love with the queer community all over again because they've just been so supportive. Everybody deserves to have a shame-free, happy life. Everybody, whether you're HIV positive or not. So I'm what we call in show business a double threat. I do music, I do comedy, and I'm HIV positive, which is absolutely no threat to anyone.
Well, I'll try this one. It sounds kind of cabaret. I'm going to stand up because I think it will be more effective. How are you feeling? My name's Beta. I'm the most beautiful woman in the world, in my price range. Shoestring budget here, but we did what we could. Anyway, firstly, I just want to say, on a personal note, I want to say thank you to Porrick at Man to Man because not only did he come up with this as a concept and help us to get it across the line, which took more diplomacy than Frank Underwood in Game of Cards. Is that the right name? Anyway, not only did you do that, but also you put up with my soap opera actress tendencies. And when it comes to talking about U=U, I discovered I can be quite triggered. When we get into talking about the language, there's a little pushback maybe about the concepts, I was like very personally invested, and you were wonderful. So I'd like you to give him a round of applause, please. I would apologize for my behavior, but I'm a drag queen, so they take my card away, my union card, if I did that. But anyway, you saw our video, I hope you liked it. It's a testimony to how much love there is within the queer community and how much we can achieve when we collaborate. This whole idea, I guess, started with myself and Babs Daly, the photographer, in lockdown, in Dublin, bored, frustrated, decided to get out there in the streets and take a few snaps, as it were. That, at the center of that, I wanted it to express my non-binary gender and my HIV positive status. So that was what the messages that we were trying to get across with those very artsy, very glamorous images. And luckily for us, they captured the imagination of Porrick, and he's since then launched a national campaign, a U=U campaign, using one of our photographs, and it's the first of its kind in this country, so that makes me really proud. Speaking of collaboration, you may know that I have a podcast, and I did say podcast. It's a podcast for people living with HIV called Pause Vibes. It's a collaboration between myself and Robbie Lawler. It has changed my life in the most positive way, pardon the puns, because it's brought so many amazing friends into my life and helped me to build a really strong connection with other people like me living with HIV and work towards just a more shame-free, happy life for all of us, which it seems is so much more achievable it is together than it was when it was just me and Robbie at the very start. So I want to give a special shout out to Robbie. I also want to talk about our film collaboration with Invisible Thread, which is called How to Tell a Secret. I'm going to say that again because marketing is important. How to Tell a Secret. It's getting a national release in cinemas across the country for World AIDS Day on the 1st of December. I need you to do me a favor. I need you to go and see it. And I need you to tell your friends and family to go and see it. It will open your minds and your hearts, I think, about the experience of people living with HIV. And I'm really proud that it went from being a little queer documentary to now being a general release. It really blows my mind, and it's because of the community and the support in the community that that's happened. And finally, I just want to tell you guys, I'm very proud to say this. I know I sound like I'm just bragging, but you know, I'm gorgeous.
That's bragging. But what I'm actually doing is just showing you how proud I am of the people that I've been working with. And so finally, I just want to let you know that myself and Robbie are on our way to World Pride next year to represent all of you, to represent the Irish contingent as guests of the Irish Consulate. And while we're there, we're going to make a whole season of Pause 5 for the Sydney Queer Irish. And it blows my mind as well that this little idea that we had in Dublin has been so celebrated that now we're being invited to do our thing in another city on the other side of the world. And again, I couldn't have done that without the support of so many people, including Man to Man, Empower HIV Ireland, a lot of other amazing people in this community. So that's it from me. I'm going to do the song, I think, maybe. That's right, darling. It's incredible that someone so undetectable knows that they are untransmittable to.
Thank you so much. I was going to ask you some boring questions, but you've really given us a fantastic performance in the last few minutes, so thank you so much. That was really interesting. Well done. So I'm really pity the next two speakers because how do you follow that? But I know they are up to the challenge. So I'd like to, without further ado, I'd like to welcome Fernando Ongolu, who is a PhD student in UCD, who's going to speak to us on access to PrEP and HIV services amongst marginalised groups, a comparative case of Kenya and Ireland. And we're going to have the questions after both Fernando and then David Carroll speak, so at the end of the session. Thanks very much, Fernando.
I don't speak English, so Billy is going to translate my presentation in Swahili. Yeah, so I'm very happy to be here today for two reasons. Number one, because this is the second time I'm in this forum. I was in the last year's forum and it was awesome. It was online. Number two, because I missed this is the first proper in-person event and I didn't need the visa to come here. So I couldn't go to Montreal for the AIDS 2022 because of visa, but I'm here now. So let's share the knowledge that they missed in Montreal. Then for the very high standards that have been set up about U equals to U, I don't know, I'm not an entertainer, but I will try to match that. But yesterday I was with Robbie, for the past 1 week, I've been doing a speaker tour. Well, if you have been keen on Twitter, we have been there. And we had a chat about U equals to U and actually what it means to people in Ireland and in Kenya. And that's a story for another day, especially among healthcare providers. So probably I'll ask that question because healthcare providers, and I'm going to tackle some of these issues here, they can really influence how people access health within different cultural contexts. Like from where I come from, the confidence of U equals to U among healthcare providers might be high, but a healthcare provider telling a client that actually if you take your ARVs, you cannot pass HIV, or you can have a partner who is HIV infected and virally suppressed and they cannot pass HIV to you. I don't want to be the one who told that client that and they got HIV. So this is how healthcare providers can influence. Anyway, let's go to PrEP. And I'm going to reduce this presentation. It's not going to be more of an academic presentation. So the academics were there in the previous sessions and they set a very high standard. I'll try to make it entertainment like the one that was there. So, but since I'm in UCD School of Business, let's talk about business first. Because all this business of accessing health and accessing PrEP and accessing HIV services. They're just products and services that we have to access. So my research focuses on the last mile point of delivery because that is the most important point. You can have PrEP in this clinic if there's a clinic, but it's useless if it doesn't get to the right people, right? So how many of you have ever ordered something online, like you bought something from Amazon or, yeah. So where do you think is the most difficult part of that delivery in the supply chain? Bill, you want to try?
The delivery system.
Yeah, so this part, when you order that thing, you order that iPhone and it comes from that manufacturer in China and it's carried in one big ship, Emma Musk, and all to Ireland, to Dublin in a big distribution center, it's not a problem because they come in big ships, right? But now, the most important part is that part, and that is same to PrEP. Like, you can have PrEP from this big pharma, you can have PrEP in, like for the case of Kenya, in the Kenya Medical Supply Agency stores. But the most important point is that part at the clinic or at the community where this intervention has to reach people. You get that? So that is my area of focus. I'll just give you a bit of a background. We call that like the last mile point of delivery. So it's going to refer to that last leg of delivery. And I'm just looking at, you see, for instance, if there's a pharmaceutical company and when the drugs come from there, they go to the medical supplies agency, then they go to the pharmacies or they go to the clinics and the hospitals. But the most important part is this part, because it's useless if it remains here. It's useless if it is here and people in the community do not know that it exists. Then why is it here then? So we really need to enhance in advocacy to make sure that they get to the end users. So next, so today, because my research is so big and I'm not going to talk about like the bigger part, I just want to focus on one thing. PrEP access among marginalized communities. And because I'm an anthropologist, I'm a medical anthropologist, I'll be politically correct and contextualize my definition. So when I talk about marginalization, I'm referring to those communities that in different various contexts that might not have like the power to influence how they access services or how they can, or what services they access. So whereas in Ireland, for instance, migrant communities might be marginalized, in another setup, they might not be marginalized. Like in Kenya, Kenya has one of the biggest refugee camps, Dadaab and Kakuma. Kakuma might be even bigger than the population there might be even bigger than a big town here in Ireland, and it's running as a town on its own, so they know how to self-advocate. But when it comes to Ireland, the migrant communities will be considered as marginalized. So I'm focusing on these groups, mostly migrants, gay men, sex workers, adolescent girls and young women, and people who inject drugs. Because in both these different setups, one group might be marginalized and another one might not be marginalized. And this presentation is based on stories from fieldwork in Kenya and in Ireland. And I'm glad to say that a lot of you supported me in this research when I was new in Ireland and I didn't know where to start, I didn't know where to go, but I found you. I'm glad. So just to put you into perspective, if you don't know where Kenya is, let me take you to a safari. Take a plane, go to London, fly to Nairobi, down there. So over here, and Ireland, 11,000 kilometers apart. So I conducted 14 qualitative interviews here in 2021 with healthcare providers, with activists, policymakers, and researchers, just to understand how PrEP is accessed and what are the barriers and what will be the barriers. How can we improve PrEP access? Because I'm an academic myself, yes, but I don't like it when my research wrote in journals and in, where people cannot access. Like, we want to find this problem, we fix it immediately. Then in Kenya, I went to Kenya after 2 years of being locked down in this country. Earlier this year in February, conducted 40 qualitative interviews and 4 focus group discussions, again with healthcare providers, community health volunteers, advocates, policymakers, researchers, and implementers. So the reason why we have a bigger sample in Kenya is because the population of Kenya is 10 times the population of Ireland. And equally, Kenya bears the highest, a higher burden of HIV compared to this country. So how is PrEP accessed in both setup? And I just said the previous presenters have already tried to give us like an example of the ecosystem of PrEP over here, but my role here is to take you to a safari in Kenya and compare. So PrEP was rolled out in Kenya nationally in May 2017. And I remember at that time, I didn't know about PrEP because I came from maternal health research. And I was being hired, and in the interview, I was asked, do you know what PrEP is? No. But that gave me the motivation to get into PrEP activism and HIV prevention activism, especially around knowledge creation, because there was this beautiful, this awesome intervention, but we didn't know about it. Like how many people were infected with HIV because they just did not know. So at the last mile, it is there in the clinic, but because of the information gap, it is not there because we can't access. So it's mostly delivered in HIV clinics and governmental and community-based organizations and research clinics, drop-in centers, community delivery and home-based care, and community pharmacies. So you can see the type of multiple channels. You know, you can access, it's like pizza. You can access your pizza from, let's say, a big restaurant, a delivery, and, you know, a small restaurant or cook at home. But in Ireland, this is based now in my research. It was rolled out in November 2019. And then after that, there was this big thing came and crashed, COVID-19. And mostly, based on the interviews, it was accessed through the GMS clinics. So limiting access to those people who cannot access the pizza from the big restaurants, you know, those ones of us who can only who can only do delivery, yet it's not there online. So the barriers, just comparing these two countries, these two setups. So I was looking at, you know, the biggest barriers in Kenya, they're cultural barriers. And when I talk about cultural, they're both like Kenya has 43 communities and different kinds of communities, and we have all this kind of belief and the way we practice our cultures and all that. But religion has also played a big role. And that is one thing that Kenya and Ireland share in common. Like, I think most priests in Kenya that I knew when I was growing up, they were Irish. So, and the biggest problem that hinders PrEP access is the issue of heteronormativity and gay stigma, because there is no any other way that is culturally approved of having sex than heterosexual sex. So any other discussion other than heterosexual sex is not sex. It's a taboo. It is something else. It's no. In fact, in other countries and in other cultures, you will not be allowed to talk about that. And I will not make such a presentation because I'll be labeled as gay, and it is against my cultural and the expectation of my people. And also HIV stigma, like the stigma revolving around HIV. PrEP was mostly targeted to sex workers, targeted to serodiscordant couples. So me going for my PrEP in a HIV clinic, then what am I telling my friends? This guy goes to a HIV clinic, so that's HIV, you see. So then taboos around sexuality, we don't talk about sex. I just got my daughter the other day. Like, I have 2 kids now, and I have a beautiful daughter. My son calls her Princess because my son is called Jasper and my daughter is called Vesper. So Jasper doesn't want to agree that Vesper has a name like him. So and my parents, as I speak right now, still assume that I don't engage in sex. But how did I get these 2 kids? You see, so we don't talk about sex in the cultures that we come. So it's difficult to talk about even prevention, because you can't talk about prevention without mentioning sex and risk. And legal issues affecting access among teenagers. And so there are all these age limits and I saw a presentation that will give free self-testing kits to those ones who are 17 years and above. What about the ones who are below 17 years and at high risk of infection? What happens to them? So let's come to Ireland, where we are seated right now. So for the case of it's mostly structural barriers. And I'll give a case of myself as a migrant and someone who is just moving into Ireland. And that is the community that is mostly affected, and heterosexuals. And especially when you come from Africa and you need ARVs, you need PrEP, and it's not being offered in almost the same setup that was being offered back at home, then can I really go to a gay clinic? Like, my friends will think that I'm gay. Come from a very highly heteronormal culture. So then you carry that with you. Like for 32 years, that's what I've known. And that's what I've been told. You see, I don't have sex myself, but I have 2 kids. So, you see, when your visa is written there, you are allowed in Ireland with no recourse to public funds. What is no recourse to public funds? Like, what can I access? What can't I access? Can I get a medical card? Can I even go to a public clinic? Can I even use public funds? Because going to a public clinic, technically you're using public funds, you see. So it's very vague, and some people don't avail of services because of that. Then some of us are here undocumented. So you think if I go to that clinic, then they might call Big Brother, and Big Brother will put me on a boat back to the kingdom of Eswatini, where I didn't want to be, because, you get that. And like, I don't have a PPS number. It's difficult to, get these documents and all that. But I need PrEP, like, with urgency, or I need even PEP, or I need a service. But you need, like, oh, what's your PPS number? Can you get that? So then some services are far. The question that I asked, when you're a migrant, you can only afford to live where accommodation is affordable. And accommodation is a big crisis right now in Ireland. I live in Nice in County Kildare. I work in Belfield campus. No, I don't. Do I drive? Let me not talk about that. But I have a car. I've failed my driving test 4 times. I was supposed to have a driving test today, but I postponed to 12th of December. And I'm going to fail again, I think. Because I'm such a great driver, but I keep failing. So these are the challenges that migrants face. So how do I drive to that clinic that is 80 kilometers from where I stay? You see? What about that guy who lives in Radangan, where there's bus 126X? In the morning, you miss that one, you're done. How are you going to get services where there are no services? What about, somebody who lives in Listonvana? And I went in Listonvana, and it was, it looks so awkward, because this guy is walking in pubs. He looks like he's not from here. How am I going to access the services? So let me just give you like quickly so that I conclude. I know I have 20 minutes, but I will not use the 20 minutes. So from the field, both in Kenya and in Ireland, and sorry if you see your quote there, I didn't mean to bring it here. You participated, but it's okay. So in Kenya, most of these services, especially to marginalized communities, are discreet. Due to the stigma that is associated with visiting, for instance, gay clinics. And there is a clinic. I've lived in Nairobi because I was raised in Western Kenya. Most of my life, I lived in Western Kenya. I went to uni in Nairobi. And there's this road where I must cross, like, every time I was going to college, to town. I never knew that there was a clinic there, an MSM clinic. Never knew. Until when I came to Dublin, designed my research, and went back down there, and I'm conducting my interviews, and I'm asking, this is so great. It's a great clinic. For how long have you been operating here? 15 years. So you see, from that quote, you can see, even I don't know of other clinics, but I'm sure other drop-in centers might be as discreet as this one. So you might not even know where to refer someone. So that was an interview from that clinic. Like, look, I know this one, but I don't even know if someone else in a different town, they needed like services that will suit them as men who have sex with men, where will I refer them to go? There are no even posters advertising the clinic, or even just a signboard giving you direction, because Google Map might not take you there. So you need a signboard. Because around there, even if you put the signboard, you are engaging in things that are culturally forbidden, you see. So these are just some of the challenges. It's not like in Ireland, where you'll be stopping at a bus stop, then you see this very nice ad of U equals to you, and there's this gay man there, and, you know, and so these are just some of them. Then some service providers judge their clients mostly based on their religious and cultural values. And before we take up our professions, before I became an anthropologist, or before I became a researcher, I was born in a Bantu community called the Luyas. We eat a lot of chicken in our community in Western Kenya. Google the Luyas. We are very, very famous down there. So I subscribe to certain cultural values before getting into this profession. So it becomes, again, very difficult to move out of these cultural values. And as a healthcare provider, a gay man walks into a clinic, they have an STI, you don't even know how to engage with this person. So in this interview, I interviewed an activist, and this activist told me that there's a time one of his friends had an STI, like, and when he walked in that clinic, and the doctor was saying, like, "Oh, how did you get this? Because this one is in your in your bum." Let me, for YouTube, let me not mention that one. This one is in your in your bum. Like, you must be engaging in anal sex. So then, okay, fine. You wait. We'll help you. So she went out and called another doctor. So the client thought that, oh, he's going to call a more experienced doctor. So, but it ended up just being, oh, come and see. Have you ever seen this kind of a person? Come. So they were walking in and out. That guy ended up being a museum, like a sculpture in a museum. So he never got the service. So then there are also other service providers who are fixed with their religious values and their religious principles. They will not see you, they will not attend to you if you they think that you go against that religious value that they hold and their cultural value. And then also, some communities have been left out of the PrEP conversation, just as I mentioned earlier. So mostly in Ireland, and this mostly the migrant communities. Like, we have a lot. When I was conducting my research, the biggest difference between Kenya and Ireland is that in Kenya, for you to, PrEP is there. PrEP is widely available. There is PrEP almost everywhere. But people are not availing of PrEP because of the lack of appropriate knowledge, the knowledge gaps in the community. I've worked in HIV research for almost 5 years. But my own parents, there's a time I asked my dad, like, sometimes I ask my dad, Dad, what do I do? What do I do? Can you tell me what I do? Then I'll give you 100 euros. And 100 euros, like, that would be like giving him like 700 euros, like, you know, that's what it can do. Then he said, I think you work in a university, I think. So there's a big knowledge gap, because I can't discuss about sex with my dad. I can't discuss about this kind of things with my dad. Let him go and learn there in the called Busa Club, like, you know, it's like a local drink where they go to drink there. Let him go and talk with his peers, like, you know. So the conversation here in Ireland, the difference is that there was a lot of knowledge in the community already. So when the intervention came, you already knew it was there. So it was just a matter of availing of it. So in fact, the demand is higher than the supply. You get, I mean, like, the services are overwhelmed. But on the other side, services are there, but they are underutilized. So a plane ticket to Nairobi, round ticket is around 500. You can just go there and seek services. So what is happening in terms of advocacy from these two countries? I have 2 slides. So in Kenya, advocates play a very key role in facilitating access to medicine, just like here. And activism is mostly centered around knowledge creation and educating communities about availability of medicines. Whereas in Ireland is around, like what Robbie does and others, is around influencing policy, and demand has already been created, so there's less of demand. And to my last slide, what lessons can we learn from both of these divides? So number one, it's important to have PrEP in multiple points. So those ones who cannot avail in point X can go to point Y. Community delivery model is very important so that some of us who cannot go to clinics can get from maybe community pharmacies, or even, PrEP can be sent home. Targeting multiple community to prevent more people from HIV, not only, like serodiscordant couples, like for the case of Kenya, but the different communities. Then more demand creation in communities with less PrEP knowledge, like migrant communities. And lastly, expanding PrEP in all regions, like outside Dublin. Then what can we learn from Ireland now? Lessons to Kenyans. So stigma reduction among groups that we think we have not, that are not culturally approved, because health is a right, and it's important that everybody has access. Then stopping PrEP labeling as HIV. As HIV, somebody taking PrEP, and intensifying on advocacy, and just the government investing more on PrEP, because most of the PrEP down there is donor funded. Thank you. I'm sorry for taking a whole decade.
Thank you very much, Fernando. That was absolutely amazing comparison between two countries, and I suppose we need to learn from each other. It's not one location has all the answers. So I'm going to move now on to David Carroll, who's a doctoral scholar in sexuality studies with the Irish Research Council, working with SALAS, which is the School of Applied Language and Intercultural Studies. And he's going to give us, I'm sure it'll be very entertaining again, Digging Your Scene, pop music's response to the emergence of HIV/AIDS. David.
It's a gay health forum and mix out a computer.
We just received this late. Sorry. Hope it works now. Imagine the first one after 3 years that we're all together.
That's great.
Yeah, and it's such a lot has happened. There you are.
Thanks, man. Good afternoon, everybody. It's great to be back, as Mick said, at the Gay Health Forum physically after a couple of years, and it's great to meet over the last couple of years online. I've met a couple of people who I've met for the first time physically today, and it's a real reminder of the isolation we were under, and it's great to be back away from it. I have to say, I've got a new pair of varifocals, which I haven't got used to using yet, so I'll probably be taking these on and off as I go in and out of focus with you. And I'm also really envious of the other presentations today, because I've got like pages of notes. I don't know how people just do it off the realm, so I'll be referring to these. But to say to you, I think my presentation, the other presentations today have been absolutely amazing, and this is kind of really different to ever, so I hope you'll bear with me. The title is Digging Your Scene, which you may know is lifted directly from a song taken from 1986, which was released by the Blow Monkeys, called Digging Your Scene. And it's attributed as being one of the first songs to deal with HIV and AIDS stigma lyrically. And throughout the presentation, I'll talk about other firsts in relation to pop music and its reaction to HIV and AIDS. But essentially, the title is doing what it says on the tin, which is exploring pop music's response in the early days of the epidemic, and also the intersection between the two. A little bit of example of how HIV began to impact on pop in a negative way, as it did with many other cultural forms of the time. So to move on, if you bear with me again, I'm going to talk a little bit about my research. because it's kind of a niche area and it gives you some context as to why I'm presenting to you today on a fairly, again, niche area of pop music meets HIV and AIDS. So in 2018, I was lucky enough to be awarded the inaugural Gabrielle Carty Award from DCU, and this was in order to start my research, which I recently just completed, which is called Songs to Save Your Life. In 2019, and I was then lucky enough to be entrusted by Irish Research Council to finish the second, third and fourth years of my PhD, which I did under the supervision of my excellent supervisor here today, Jean-Philippe Imbert. But essentially, the aim of my work over the last 4 years has been to unearth and explore the abundance of queer messaging in pop music and iconography of the 1980s. Now, there's lots to this. I suppose as a previous activist and somebody who's been involved in sexual health as well over the years, I really wanted to explore the kind of socio-economic, political and cultural context. This was, after all, you will know as an audience of people working in sexual health, Larry Kramer described the 1980s as a decade in which just staying alive became a political act for queers. And I wanted to kind of build that into the research. Also, from an Irish perspective, I really wanted to talk about transnationalism. I suppose most of the songs I came out to and most of the songs we danced to in the 1980s, despite a really rich and lauded Irish musical heritage, were imported. They came from the United Kingdom, sometimes Europe, and also North America. Many of the songs, again, I'll mention today, you'll be familiar with, but again, it's worth reminding ourselves that almost all of these, despite this really rich musical heritage when it comes to pop music, were imported, which I think says a lot about Ireland of the 80s in itself. Also, I'll return to it later, but I just want to introduce you to the concept of pop music's kind of traditional underrated reputation as a field worthy of study, both in academia, but almost generally, usually in music analysis, seen as a weak or certainly inferior counterpart to rock, which is associated with much more authentic kind of outcomes. And also there's a gendered aspect to that, I believe, as well. But interestingly, while I was doing this research over the last 4 years, I think there's been a real kind of look back and an exploration of how queers came to impact on popular culture and the presence of queers in popular culture of the 1980s outside of HIV and AIDS. But simultaneously, in the last number of years, there's also been an acknowledgement of a glut of cultural reproductions which have visited the early days of the AIDS epidemic. Now, such as the abundance of these in the last couple of years, that Kerr and Juhas in 2018 termed this phenomenon AIDS crisis revisitation. But they also acknowledged their kind of frustration at what they saw was all but most the nominal and kind of boring representations of queerness, bland representations of queerness in these cultural products. However, more recently, programs, television has been an interesting medium in coming forward and progressing, because more recently, TV programs such as Netflix's Pose and Channel 4's It's a Sin have shown the kind of epidemic and the effects on queer communities through a much more intersectional lens, which I think is really welcome. And also relevant for this research, and indeed the presentation today, is the fact that in both of these television programs, they really illustrate how pop music played a huge role, both as a queer soundtrack to the 1980s, but also with the impact of queer-tinged artists over the general pop landscape of the era. This would, is a quote from the late great Pete Burns, who kind of backs it up, saying that the charts are full of, this was in 1984, the charts are full of faggots, myself included. It's a real kick in the face to the moral majority. Trying to bring it back a little bit to academia, Lecklider in 2004 notes that although we're quite aware of the presence of queerness and homosexuality in the charts of the 1980s, the full history of gay male sexuality in 1980s pop has yet to be written. And I suppose really that's what I hoped to aim to fill that void with my research. And also I get to show entirely gratuitous pictures like this one of Lenny Kravitz. So I kind of harped on about it, and some of you will be too young to remember, but other people will remember. But if you were around in the 1980s, you kind of noticed pop in the 1980s was spectacularly queer. So you had the Gender Benders, Boy George, Pete Burns, Divine, Marilyn. You had the kind of synth pop pioneers in the shape of Erasure with Andy Bell, the Pet Shop Boys, Neil Tennant and Chris Lowe. You had Jimmy Somerville here on the top left, on the left side of the picture, in two guises, both with the Communards, but originally with Bronski Beat, and of course the pioneering song that most people remember, Small Town Boy. You had Mark Almond and Soft Cell. You had kind of existing rock gods who'd established their careers in the 70s, but consolidated them in the 80s, like Freddie Mercury, Elton John, and David Bowie. You had indie swoonsters like Morrissey and the Smiths, teeny bop stars like Lamal from Kajagoogoo and Big Fun. You had women who were tearing up the kind of previously rigid gender roles, women like Grace Jones and Annie Lennox. You had the punk pop front of the B-52s. You had the kind of emerging career of K.D. Lang, the absolute unadulterated filth of Frankie Goes to Hollywood and Man to Man. You had emerging lesbian artists like Frank, and also even from Ireland, you had Derry's Baltimore, who scored a hit with Tarzan Boy in 1986, I think it was. So this isn't surprising, if you ask me, because all you have to do is scratch beneath the surface of any pop history, and you really begin to see that pop has always concerned itself with sex, sexuality, and in particular queer sexuality has always been a focus in pop. Now, I mentioned earlier, I suppose, that pop music had originally a poor academic relationship, but this actually began to change in the 1980s when the likes of Simon Frith proposed that pop music actually has many important functions and purposes. He talks about how it helps us answer questions about our identity, how it assists us in framing our sense of time and memory and events. It helps us manage the boundaries between public and private. And importantly, this is all delivered through a medium which the listener feels some kind of an element of ownership over. So, when people talk about their song or our song or a specific song reminds you of something. So it doesn't take a genius to begin to kind of see how these kind of functions can be, and indeed have been, utilised by LGBT folk, by queer folk, in terms of coming to terms with identity over the years. And it begins also to give you a bit of a hint of the special relationship that can exist between pop and its queer audiences. More specifically, when it comes to queerness, the Nora in 2000 has explored how pop music is used by audiences to articulate self-identity, to undergo the exploration of simulated possibilities. And that's what I like to think of as the hairbrush and the mirror thing that we've all done. So that kind of exploring possibilities and to accentuate or reflect frame of mind. Flanders in 2012 has showed how music has been utilised by LGBT communities for the purpose of aiding identity formation. And Cohen in 2000 has explored pop music's importance in the sensory development of places, in particular looking at safe spaces, again, notion really cognizant to queer and LGBT communities. Irvin has also explored how gay and lesbian audiences often, particularly in the 1980s, used decoding practices to kind of interpret queer meanings and queer readings through songs. And then finally, more recently, in recent years, Doggett, Stanley and Aston have all contributed to a kind of a chronological re-queering of the history of pop music from the 1950s onwards. Now, despite this really rich and kind of diverse kind of queerness, which seems to really epitomise pop music of the 1980s, I really am talking about the early part of the decade and the mid part of the decade, because what happened next was there was a bit of a backlash. So in talking about the backlash, I suppose it's important to note that other scholars have already talked about a reticence to address HIV and AIDS in pop culture. Particularly Goldstein's work, he looks at television and film and shows how that it was really belated, any kind of exploration of HIV and AIDS. And then when there were portrayals, it was often done in a very two-dimensional way. So it wasn't very effective at the time. I would argue that the same happened in pop music, and it had two very distinct kind of outcomes. The first one was pop, which was really traditionally able and used to shocking its queer audiences and its general audiences with its promotion of sexuality and sex. There was a really delayed response. But secondly, and I suppose more relevant to HIV and AIDS, I think that the backlash really kind of came about on foot of the emergence of the virus. Mark Simpson, a queer commentator, English queer commentator who you might be aware of, really hits the nail on the head. He talks about how the traditional values of Reagan and Thatcher had already chilled the political atmosphere, but it was the eruption of the gay plague into the news headlines in the mid-80s that was to decisively turn the tide on both sides of the Atlantic against the androgynous, gender-bending culture of New Wave. Keeps then talks about how pop and AIDS compromise each other. They form a contradictory alliance between an industry that markets sex as fun and a disease that links sex with death. Either way, back to Simpson, who notes that good old, authentic, straight, reproductive, patriotic album-based guitar rock was back. And taken from that article, which I referenced at the end, I love this picture showing the kind of new romantic guy with his pictures of Duran Duran and Boy George with their lipsticks, the posters falling down off the wall, and then the epitome of male heteronormativity, Bruce Springsteen, who was held up as this kind of icon of everything normal coming back. Oh yeah, sorry. Can people hear me? Sorry. Good. I'll do a bit of rapping. It's important to say as well that I think that kind of general backlash was really emboldened by a hostile media, and I know in one of the presentations earlier we had a glimpse of some of those awful headlines, but I think in particular, and relevant to today's presentation, the epitome of this, the English tabloids in the 1980s as these various kind of awful show. But my particular actual favourite headline from story from the 1980s doesn't involve Freddie, but it's simply a headline from The Sun in 1987. I don't know whether you can see it here, but it's actually an editorial where The Sun offers gay people to come to their office to collect a one-way plane ticket out of England. And this is a pretty serious offer advertised by The Sun in 1987. So in the midst of all of this backlash, HIV, AIDS was taking hold, its stigma was being felt everywhere, and including in pop. And despite that ferociously queer presence in the 1980s, the decade was also epitomised by efforts to rein in the morally corruptive influence of pop. And I want to talk about two examples of these. So the Filthy 15, you may have heard of. It was an organisation. It was set up by the Parents Music Resource Centre, and they listed a name of corruptible songs. The Parents Music Resource Centre was set up by Tipper Gore, who was the wife of Al Gore, in 1984. She managed to get a Congress hearing where they brought this list of 15 songs to Congress, and they actually had a whole Congress debate, and this led to the adoption of this image, which you're probably familiar with, which is the Parental Advisory Explicit Content, which has been adopted by UK and United States record companies ever since. Ironically, like most efforts to censor or prohibit any kind of art, it's absolutely backfired, and the Parental Advisory logo has become a kind of an icon of graphics. You see it emboldened on t-shirts, and actually most bands kind of see it as a badge of honour to have on their albums, so the exact opposite effect. But what's really interesting, and let's see if I can get this up here. No. What's really interesting is the actual list of the corruptible songs, which were divided into 4 categories. And the 4 categories were violence, drugs and alcohol, the occult, because seemingly in the 1980s people were very worried about the occult, and also the sexually explicit. But of the 15 songs brought to Congress to show this example of the morally corrupt pop music that existed, 9 of the songs concerned sex, including really odd examples like Madonna's Dress You Up, and literally it's that the title is as explicit as the song gets. It's Dress You Up, and this is from an artist who in the same year released a song called Like a Virgin, and they picked Dress You Up as the morally offensive one. So however, also as a reaction, I think, to HIV and AIDS, there was this mini trend which I like to call abstinence pop. And this was a brief kind of thing we kind of saw in 1986, 1987. You had the likes of Janet Jackson, Let's Wait a While, with her refrain of Before We Go Too Far. But my personal favourite is by this man here in the bottom left, Jermaine Stewart, with We Don't Have to Take Our Clothes Off to Have a Good Time. Now, Jermaine had a worldwide hit with this, but he obviously thought he was onto a good vibe because he followed this up with Don't Talk Dirty to Me. However, Don't Talk Dirty to Me was not nearly as successful as its predecessors. And I suppose what's really interesting and ironically sad is Jermaine used to give lots of interviews where he would gush about the women he fancied and the attributes of the type of women he fancied and the women he was dating all around the world. And more recently, he's been described by the queer academic Richard Smith as coming across like a gloriously unreconstructed Nelly. And sadly, he also died of an AIDS-related illness in 1997. As a brief side note, the paltry response to HIV and AIDS in the early days of the epidemic, it's made all the more pathetic by what we know about the effectiveness of pop music as an effective tool for transmitting sexual health messages. Despite all of the doom and gloom, there were some exceptions and firsts, and I want to talk a little bit about these. The first example is Elton John's Stevie Wonder, Gladys Knight and the Young Warwicks, That's What Friends Are For, track from 1984, which some people might remember. And this was the first charity record for HIV. And again, if you're familiar with pop from the 1980s, you'll remember, because of Band-Aid and Bob Geldof's efforts, the charity record was a big thing. So these four acts coming together to describe, to release a charity record for HIV was quite a big thing. However, there was no explicit sentiment or mention of HIV in this, and it's really exemplified by, if you actually YouTube at the Top of the Pops performance for this song, the presenter introduces the song and says it's for charity without being even able to say the words AIDS in the introduction. The Blow Monkeys, Digging Your Scene, I've mentioned from 1986 as one of the first songs to deal lyrically, and one of the first and only songs of the 80s to deal lyrically with stigma. 1987, you had the Communards with Jimmy Somerville, For a Friend, and this has been described as his most passionate moment. You had Prince with Sign of the Times in 1987. Again, no direct mention, but the lyric starts with, "And Francis man died of a big disease with a little name." You had Lou Reed with Halloween Parade in 1989, but it would take all the way up until 1990 until the first mention of HIV or AIDS explicitly in a chart song, which was with Nina Cherry in her cover version of I've Got You Under My Skin, the Cole Porter classic, which she kind of adopted for the Red Hot and Blue album, which also came out in 1990.
We're just coming up on time.
Cool, so almost done. So I've kind of talked about how the 80s didn't respond well, but to move on, in the 90s we saw that silence on HIV and AIDS end, thankfully. And also that backlash that I talked about at the end of the 80s, it wasn't to last, as the new genres of popular music like grunge and dance also actually proved equally as accepting to queers and queer identity and expression. But in the 90s with the silence ending, you had two types of songs which really kind of came out. The first were accolades to friends and lovers who lost their lives. So you had the likes of Madonna, Janet Jackson with Together Again, Bruce Springsteen with Philadelphia, Elton John with The Last Song, the Pet Shop Boys with Being Boring, and then kind of safer sex anthems. So you had Delight with Rubber Lover, you had Salt and Pepper with Let's Talk About Sex, you had TLC, pictured here, he used condoms as fashion accessories. Yeah, George Michael with Do You Really Want to Know, and more laterally even the Spice Girls with their kind of oblique but fairly emphatic message of come on use, put it on, put it on. So beyond this, I suppose, it's also worth noting in the 1980s, an awful lot of artists died of AIDS-related illnesses. The likes of Oliver Haza, Dan Hartman, Freddie Mercury, Baltimore, who I mentioned from Derry, Sylvester, Klaus Nomi, and Joe Bride, all passed on. What was common about these deaths was the cause of death and any kind of AIDS diagnosis was never revealed, except for the case of Freddie when the tabloids press pulled it out of him, and it was never revealed. And I suppose to finish on a positive note, even though the 1980s response wasn't great and surprisingly so for pop music, it's worth noting again how this began to change in the 1990s. Again, with pop stars from the 1980s. In the early 1990s, you had the likes of Andy Bell's Erasure, and Frankie Goes to Hollywood, or Holly Johnson from Frankie Goes to Hollywood revealed her status. And since then, you've had a kind of a rake of artists like Conchita, John Grant, Jake Shears of the Sister Sisters, and Billy Porter come out as openly HIV positive. And I suppose knowing how important that kind of brave step of public self-identification is, perhaps there's some solace to be taken about how things have moved on as pop music continues to kind of represent and reflect the lives of its ferociously queer audience. Thank you.
I'd just like to thank our three speakers, well, two speakers and one performer for this session that we've just had. We are a little bit over time, but I'll give, if two people have burning questions that they'd like to ask, now's your chance. Otherwise, we'll go in next door and people can ask people in private. So does anybody like to ask a burning question of both this session, but also the previous session? Anybody would like to ask anything? Going, gone to lunch. Okay, thanks very much. Bye.
Some people ask for vegan and one or two gluten-free. So they are out there separate.
That's speak true.
That's the sandwiches. And then there's other types of sandwiches. But also importantly the soups. There's a vegetarian and vegan soup. There's a stew and there's a chicken.
Good afternoon, everybody, and welcome to. Yeah, we might just give a nod to those people who are just outside. We will. Well, good afternoon, everybody who is here today in the RF building, and also everybody again watching online for the second half of our event, the Gay Health Forum. My name is Stephen O'Hare, Executive Director with HIV Ireland, and I'm delighted to be chairing the Community Reports and Development section today. And we have quite a number of speakers to get through and a really varied discussion agenda today. So I really don't want to take up too much time talking myself. We're going to hear today from Pádraig Burke, Communications Director with Gay Health Network, and he's going to be followed by Martin Davern from the Sexual Health Centre in Cork, by Gillian McInerney, the Chairperson of Gay Switchboard, and by James O'Hagan from LGBT Ireland. And then we're going to have a very short break, just to basically stretch your legs, and there'll be no dilly-dallying at all. We want to make up time. I'm going to be a strict timekeeper if I can, which means I'll be tapping my pen when your time is nearly up. But otherwise, yeah, let's crack on and see what else we can learn today. So I'm going to invite Pádraig to come up and give his presentation on man-to-man online campaigns and messaging.
Thanks. Thank you all. Yeah, so I'm Pádraig. I work with GHN and I look after the mantoman.ie website, and it is run in conjunction with Sexual Wellbeing. So that's Anita in the what's called Sexual Health and Crisis Pregnancy Program, and then Mirren as well, who works in HSE campaigns. I work very closely with both of them on this, and obviously with our stakeholders. So this is just sort of like a look at what some of the stuff we're doing. There's like digital ads on poppers. There's syphilis. Oh yeah. Well, I'll take it out. So we have syphilis there, which is a Grindr ad from last year. We did a PEP video last year for World AIDS Day. You can see this year a Pride project with Rainbow Project and Veda. And then there was Shigella as well at the start of the year. We did a very nice campaign on that. And then obviously there's monkeypox as well, which we worked with HIV Ireland, Empire, and the wider subgroup from the crisis management team. And then, yeah, there's some posters and toilets. And yeah, so that's just a flavor. So how do we reach our audience? We reach through the website, through social media, Grindr, digital displays, advertisements and poster promotions, Pride events and cinematic displays, washroom display promotions, Google search, TCM magazine, and Reels and TikTok are more recent ones. The Google search is now called paid search, I think. So I'm going to go through all those. Okay, so that was the PEP video that we're not going to watch last year. So yeah, that's just the website. In 2021, we had 66,000 users, which was up 34% from last year. And you see, like with our branded partnership, we had 2 messages going out from April of last year to April of this year. So that really helped with our figures. Paid searches, 16.5 thousand visits. Digital display, 13, organic search, 9.6, and social media, which we actually spent a lot of time on, is 5.9K. So I think a lot of that, what that tells us is like that we need to tell our stories on social media because people are reluctant to come off it. So, and we have been doing that more this year. Okay, so let's look at the messaging from last year. So there's PEP, mental health, harm reduction around drugs and alcohol, syphilis, consent, PrEP, and time to get tested for testing. Now, this was reflective of COVID times as well last year because of shutdown. And so here then is like a look at some of the stuff we're doing this year. Yeah, so you see here we have a partnership with Rainbow Project at the moment, and we just the first thing we've done is PrEP. So there's a sort of animated social story, there's a poster, and we have another one as well you can see later. So there's You Can See with Veda, and there's the Shigella, the monkeypox, and the poppers that came out late last year, early this year. And this one then is the testing. So we have digital display ads done for that as well. The HSE kindly gave us resources, and then we added our logos and stuff. So these are going out on our socials, but also on as digital ads. which is really good because they're very eye-catching, and I think they really set themselves apart, these ones. Okay. So yeah, Facebook and Instagram. So looking at last year, our reach was 573,000 impressions, 1.5 million. We did spend a lot last year on it because of COVID as well, and people were at home. So we really pushed the sort of digital stuff, and along with the Grindr messaging as well. And the top 5 posts last year were syphilis, you, sex and COVID updates, symptoms get tested, and symptoms get tested. So this year as well, I imagine monkeypox will feature us quite significantly in our output, and less so than sex and COVID, which really doesn't feature at all. And of course, you as well, that we did with Veda. And Twitter then, like, I think it's quite good. You know, reach impressions 423k last year. I don't know how we did that, because this year it's only 178, but we had 35,000 profile visits. And I know a lot of that has to do with collaborations. When we did the video with Veda, there was a lot of sort of interest, and there was a lot of people played it. So yeah, they're good. And this is our Grindr. So as I said, we were doing 2 a month up to April of this year, and since then it's been less frequent. So maybe 3 to 4, 4 to 5. Miriam is here. So yeah, they're targeted messaging to the core audience, with 2 going out in December. So they're a really good way of connecting to our actual target audience, and sort of gay imagery and iconography actually works more so than something that's a bit more sedate. Okay, so digital displays, these are all the ones, these are from last year. So programmatic display 2001, second year running these. So mostly they will appear in GCN magazine, and since last year on Grindr, but there's other places as well, like the Daily Mail and stuff like that, they will appear. You can see the impressions there and the clicks and the click-through rate for the different ones. So the Grindr click-through rate is very good. Then it's a great place for advertising, sexual health and well-being information. And so these are the ones that we worked on this year. You can see there the monkeypox one, there's the populous one, and I'm just going to play this video. So yeah, they're all going out at the moment, except the monkeypox one now we have a new one going out this next week for the vaccines, information on the vaccines. We pulled them the last time because there wasn't enough vaccines, as it turned out, so we were lucky we were able to pull them out. But hopefully from next week we should be able to go again. Now, okay, there's just washrooms, and there's the monkeypox one over there. There's you on your bottom. They're in 106 venues across the country. Now, last year there was a large reduction in this because of COVID, and the year before. So this year we haven't had any obstacles, and sort of, I don't know, every few cycles we have 3 different posters going out across the country in 106 venues, and they work really well. And when we do our omnibus at the end of the year or start of the year, and feedback is always, out of home posters is very positive. We also have paid search now. This is done by the HSE. These are the figures: 280k, 29% impressions there, click-through rate of 6.6%, which is very good. So yeah, that's coming out. Get the facts in HIV, man-to-man, and chlamydia. So there you go. And the GCN magazine, we always feature at least 2 ads, so 2 full-page ads and 2 quarter-page ads, and always sexual health modeling. So we do that as well with the Marion at the HSE. So we're organised with an outside company called Spark. So as well, what we did this year, we had some Pride advertising. So I'll just play this for a second. Sorry, how do you go back? How do you go back? Yeah, and this second one, yeah, I don't need to play it. So we had mobile advertising at both Dublin and Cork Prides, and it just worked really well. They were very colourful, a great addition to the actual Pride festival. So the other thing we did this year for Pride was a project with Veda, and some of you were here earlier for Veda speaking. She was, absolutely great to work with. She's already doing great work on You Equals You, and it just felt good to support. And because it was art as well, and the photos that Daily taken were excellent. So the You Equals You video was ready in July. We didn't get it ready in June, but we put out that poster in June. And it was played before every film at the Gays Film Festival. It was seen thousands of times on Twitter, thousands of times on Instagram. And so we're gonna. But the other thing we've done, we've made it into sort of a TikTok. So a portrait. We've changed the size. We're gonna put it out on TikTok. And yes, the partnership is ongoing. We've done other videos with Veda as well that we put out on TikTok and Reels, and they're doing really well. So here, I'm going to show you them.
I don't think we look after our sexual health enough. I think as queer people, we maybe do it better than the rest of the community. We have a history of testing, we're more familiar with it, and we're more proactive about it. So that's really good. But sexual health isn't just wars, sores, bumps. It's also about your emotional health, your mental health. And that's where I feel like we could do with a bit of work.
What we did is we did a long interview, so we were able to get lots of bits and pieces that we could use, and we'll be doing more for World AIDS Day next week as well. We have 2 more videos.
It's vitally important to know your status. There are amazing resources now for people who want to be tested. There's at-home testing kits that you can get delivered straight to your door, totally private, confidential, and so convenient. You can get them from sexualwellbeing.ie. They'll be delivered to your door discreetly. It takes about half an hour to go through all the steps. You send them back, and in just a few days, I got results. Good one.
The George shared it as well, so we had about 3,000. They had over 3,000. The George shared it, and they had over a few thousand as well, and other people shared it. So we're going to make more and ask people to maybe share them. It's just a great way of connecting with the audience. Even if you have a small number of followers, it can still be seen thousands of times on Reels and TikTok. So the other thing we're looking at as well is the Man-to-Man project, Man-to-Man and Rainbow project. So that's ongoing. This is just some of the stuff we've created. We worked as well with our partners on the U+E for Beta. We're working on some more creative for the new year with John Doherty, who's here today. Thank you, John. It's great. And thank you for helping us out with this. Yeah, that's that again. Okay, so coming to the end, we did Voices from Afar as well. So this was a series of 5 short films for about people who live in Ireland but who weren't born here. There were intimate portraits, very personal. So we covered issues of rape, living with HIV, direct provision, sexual racism, and homophobia. So these are all the people that took part: Pradeep, Pritam, Bulalani, Alejandro, and Jordi. And so we launched this on the night before Culture Night, and then we had a screening on Culture Night as well at Outhouse with Gays Film Festival.
My art comes from my experiences as a gay person of color living in Ireland.
I found out that I was HIV positive when I was 18 in Barcelona. I personally believe that if everybody was recognizing openly that they are HIV positive, people would have normalized it in their lives.
I came from a very poor family, but my family never accepted me the way I am. They always thought like I'm mentally diseased.
He said, you want to tell me anything? And I said, yes, I'm here to claim asylum. And she said, you're safe now, relax. Do you want some water? And when she said these words to me, like, I wanted to cry because I didn't know what, like, if I felt safe at that moment, I knew I was safe.
People look to Ireland for progressive ethos, and yet we don't see that coming through in the direct provision system.
Things won't change overnight. It will take time, but we had to start somewhere.
You can see all of the films at VHF.ie, Voices from Afar, and we're going to be promoting them as well in the coming weeks and months. So another thing we're doing, we got these done for World AIDS Day. So Jordi particularly living with HIV, so we've made some TikToks. I won't play them all, but I'll play one or two right here.
If I had known information from before getting my diagnosis of HIV, I wouldn't have suffered this stigma that I did with myself. Nobody gave me that talk on school. Nobody gave me that talk at home. not even with my friends. My advice for any young person that found out recently that they had HIV will be, don't be afraid of the world. I am physical proof that you can do everything that you want. If you overcome the stigma, then you overcome everything else. I think there is a connection in between sexual health and mental health, because sexual health, unfortunately, is linked to a stigma. I personally believe that if everybody was recognizing openly that they are HIV positive, it will be so many people coming out that people will have normalized it in their lives. I think.
So yeah, thank you. So what's next? Like campaigns, business as usual. Vaccines, PrEP, condoms, consent declares, monkeypox. There should be testing in there as well. Sorry, at the start. Monkeypox, HIV, stigma use, drug, alcohol, harm reduction, sexual health and well-being, the mental health and well-being, and we're going to do it with videos and partnerships and collaborations. We're going to be working more with people. I think it does great. We get great results when we work with people. I want to say thanks to for them to type out the SHCPP and HSC, especially Anita and Maren, for being so helpful. And I have to say as well, everyone I've worked with at the HSC from the digital team and everything has been so helpful and accommodating. Thanks to the COM subgroup, Chris, Jason Doyle and Paul O'Connell. Chris is here today as well, helping us out. The GHN board, thank you. And thanks to our partners at HIV Ireland that we're working with this year, Adam Empower for the work on monkeypox, Rainbow Project, Sexual Health Centre and GOSH. Thanks to Dublin Pride and GCN, thanks for helping us out today. We would be lost without you. So to everyone from Pride and Alice from GCN, thank you very much. And thanks Bill and Mick for helping us organise this, and Rohit in India. Thank you. Thanks.
Thank you, Cork. Thank you, and thank you for today and for organising today, and to Bill. A fantastic amount of work and a fantastic amount of innovation and some really powerful imagery there, just in time for Twitter to be gone. But sure, look, I like that you've gone with TikTok. That's the way to go. Our next speaker is Martin Davern from the Sexual Health Centre in Cork. And Martin is going to talk to us about the World AIDS Day run, tackling HIV-related stigma within communities. So, Martin.
Sorry.
Thanks, Mick. So, hi all. Lovely to be back and see everybody in person again, and lovely to be out of Cork for a day. So, my name is Martin Davern. As Stephen said, I'm Executive Director of the Sexual Health Centre, and I'm going to talk to you about a campaign we've been running since 2018, which is our World AIDS Day run, and we're looking to tackle HIV stigma within communities. Great. So, just to acknowledge that this campaign wouldn't be possible without a good number of people that have been supporting us over the last number of years. So, my own team in the Sexual Health Centre, who found themselves at park runs across Cork, handing out dry fit tops, or posting tops to people across the country when COVID hit us. To Anita, Caroline and me from the Sexual Health and Breast Pregnancy Programme, who've been flooding us and talked to us about how we can change and improve the project over the years. We've been facilitated in Kerry by Maura Leary and Caroline Doyle from HSE. Our partners in Cork City Council and Kerry County Council have provided us with permits in order to get in and out of sites, and Cork Healthy Cities really devise an awful lot of the work that we do back at base. So we can just convert it here, but just to put it in context, this all started with around in 2018 looking at the volume of people that were being newly diagnosed and living with HIV in Ireland, and really the stigma that they were living with. So the stigma in many ways can be thought of or defined as the co-occurrence or labeling, stereotyping and discrimination in contexts where real power is exercised. This handy diagram that you might be able to see on the side is from UNAIDS, and it really details out how marginalisation can lead to sickness and poor health outcomes. It can lead to poverty. It can lead to a risk of isolation and sticking from the world that you're living in. But we're also at a point in time where things have never been better. So, with all of the options available to us, like PrEP and PEP, the U equals U message, and how far medication has come, what actually we're facing in society in some ways is a knowledge gap. A knowledge gap about what is the reality of living with HIV today and what people in society believe the reality to be. So with that in mind, that's where the World AIDS Day Run came into place. So we wanted to go and meet a community that maybe never interacted with the Sexual Health Centre, never knew that we existed, or had never walked past our door. About HIV to mark World AIDS Day every year. So in 2018, we approached the Sexual Health and Crisis Pregnancy Programme, and they supported us, and we also worked with Parkrun in order to meet a group of individuals who were out every Saturday within their own communities, and where we could tag team with them. So they would support us in delivering this initiative, and we would meet a group of people and be able to talk about HIV to them on the day. Cork Healthy City supported, as I said, as did a number of other members, and it all shared under the Healthy Ireland umbrella of making Ireland a healthier place to live. At the start, its real focus was to tackle stigma, myths and misconceptions in relation to HIV in Ireland. So our plan, or the process of the way it was going to be implemented, was that we would have a myth a kilometre. So our myths were focused on the back of the HIV Ireland survey that was conducted in 2017, which looked at the myths that were held in Ireland around HIV. And so our 5 were HIV is not transmitted from saliva, tears or saliva. You cannot get HIV from toilet seats. HIV is not transmitted from sharing food or utensils. You cannot get HIV from kissing. And the U equals U message. So as participants ran past at every kilometre, one of my team members was standing there holding up one of those signs, and all of those signs were then brought back to base and at the finish line for people as well. We launched, as I said, in 2018, and our launch was just with one parkrun. So we were in Ballincollig. They were very friendly and very open to us from the very get-go. And we had about 350 participants on the day in Ballincollig. So everyone got one of these lovely dry fit tops that you can see. And at every kilometre, people would have ran past at one of our myths. We were promoting heavily on social media at the time to try and get participants to attend. And many of our local groups in Cork continued to support us during that time. In 2019 then, we had 2 parkrun events. So there was a second parkrun in Cork that was open to hosting us. It always just takes one to get over the line like Ballincollig, and then once people see it's happening, that kind of gives an impetus for others to get involved. We signposted people here to have their local parkrun events, so people just registered themselves to either participate in the event or to volunteer. We encourage people to test and signpost them to our service. We still had our myth busting signs, and everybody who attended got a free private talk, as you can see. So that year we had 430 people engaged with this, and 430 people that maybe wouldn't have engaged with our service in the past. And then we had to go virtual. So into 2020, everything changed, and I suppose we felt we were on a roll and didn't really know what to do. But my team were really committed to the idea of we're 2 years in, if we stop now, maybe that'll be it. So how do we make it work? And at the time, we were all in our either 2 kilometre or 5 kilometre circles and radiuses. And the one thing we were all doing was walking. Everyone was going for a walk in the sun. So that's what we promoted our World AIDS Day Run as that year. So to use your 5K in order to educate the community you're in, bringing out your top and having conversations with somebody maybe that you wouldn't have a conversation with before about the reality of living with HIV today. So with this we asked people to take a picture to promote it more via the social media messaging, and to use one of the myths that we had on cards from our parkrun and promote that on our social media, and perhaps link a service. So would have to be our service, but a service in your local area, a service that would be useful for the community or for individuals that you think may be following you. And thanks to everybody, we had 500 participants in 2020, which was fantastic. Now all of those t-shirts had to be posted out, and that's why I thank my team. It was a lot of work to get those t-shirts out to people, but it was a fantastic initiative to see, and great to see so many people, so many diverse people interacting and engaging with the run on that World AIDS Day. In 2021, then we kept, because virtual part of things had worked so well and we enjoyed it, we kept that. So we now have a mix. We went back to our park runs. So we were in Tralee this year, in Ballycollig and in Glen River. And part of it worked as well online, so we posted a number of t-shirts out. Our slogan remained the same. It had been since the very beginning for individuals to know your status. And for people to try and access a test and know a service where you could. In 2021, we had 1,000 participants take part in the run, all running with Nancy Red, and thankfully we ran out of t-shirts last year that we could distribute, and this year we're the same. So for 2022, we've updated our slogan. We're looking at ending HIV stigma this year in the front of our t-shirt. We're in Tralee, Ballincollig, Glen River, and Tramore Valley Park, as well as running the event online for anyone to run in their own community. And to bring that message to the community via social media. As I said, we've run out of t-shirts for this year, which is fantastic, and we're scheduled to undertake this initiative on the 26th of November. So what I'd say is for everyone to wear red where possible and support where possible. And we, over the years, we've seen a real increase in the level of engagement with this initiative. It's been fantastic because it's helped us raise awareness around the U-Equals U message in our local area. The event has grown, and the positive impact, I suppose, of that is that more and more people that maybe wouldn't interact with our service in Cork are getting to know our service, but also getting to see and talk about living with HIV on the 1st of December every year within their local community at their park club. So, yeah, 26th of November is the date. Keep in mind, we're red. We're on any social media, so you'll find us, and we're out there all day. Thank you very much. I think that's it for me.
Thank you, Martin. The run is absolutely fantastic. A fantastic event. I love running. But we're going to move on because we are pressing for time. So I'm going to ask Gillian McInerney, who is chairperson of the Switchboard, to join us to talk about a new approach to call logging, report on findings 1 year on. Gillian.
Hello everyone. I don't know if you're in the same boat as me, but I'm feeling particularly sleepy after that lunch. It was lovely.
There are some chocolates outside for the break to wake me up. Yeah.
Excellent. Thank you so much. Well, thank you so much for everyone for being here, anyone joining us online. My name is Gillian McInerney, and I am the current chairperson of the Switchboard. I've been in this role for about 6 months now, and I've been an administrator with the Switchboard for about a year. So what I'm going to talk to you today is one of my brain children, and has been a relatively small change for us as an organisation, but has had a huge impact already. So a little history about us. We have been many things over many years. The Switchboard has existed since 1974. And then we were Telefriend, and we remained Telefriend up until the late 80s, early 90s. I'm sure some of you know this history better than I do, when we became Gay Switchboard. We stayed Gay Switchboard Dublin then until our 40th anniversary, which was 2014, when we became Gay Switchboard Ireland. And then in around the time of the pandemic, we decided to just change to Switchboard, because in general, that's what people called us. But also we wanted to diversify. We wanted to get away from the word gay, to be honest, because we were viewed as a service for gay men. And in reality, that had never been the case with us. We had always been for everybody. So in line with our rebrand as the Switchboard, we put out a schedule of different nights. So now we have a neurodiversity and disability night on Mondays, women's night on Tuesday, men's night on Wednesday. We have a kink and sexual health night on Thursday. Friday night is trans, intersex, non-binary. Saturdays at the moment are isolation, COVID-19. We're still keeping that there because we're still having people calling us about it. And then our Sundays at the moment are bi, pan and queer. So we've always said that anyone can call us on any night, and that is still the philosophy, but we want to make this schedule because sometimes people feel that they need permission to call us. And that was another thing about getting away from Gay Switchboard. We didn't want people who maybe weren't gay or didn't use the word gay about themselves to feel that they couldn't contact us. So that's a little about us. We are a confidential and anonymous service. So anyone who calls in, we do not see their phone numbers. We do not probe for any information. All calls are caller-led, so it's whatever they want to tell us. We have always had a system of logging calls purely for statistical purposes. Some of our funding, funders would ask for stats, how many male callers do you have, how many callers about sexual health, how many trans callers. And we collected that information where possible. But before this system that I brought in, the old system was you would write down your call logs in an email, send it in at the end of the day. The unfortunate thing about that was there was no specific format. So some people were brilliant at it. You would get a full breakdown. You would get this call started at 7:33 and lasted for 7.5 minutes. And you would get all of the details, and other people might write in and say, had 5 calls tonight. So it was very inconsistent. Also, because it was done by email, you couldn't gather stats from it. You had to go through each individual email, take out the stats, build it back up. So I joined the Switchboard when we were doing this, and I thought there has to be an easier way, there has to be a simpler way, and most importantly, there has to be a free way, because we do not run on very much money. And also, anything that is implemented needs to be long-lasting. We need to have access to it. We need to be aware of the fact that while we may be in a good financial position this year, that may not continue. It also needed to be simple. I operate on the KISS principle, keep it simple, stupid. The stupid one being me. But if I keep it simple, then it's easy for me to explain to others of all varying tech levels. And to be honest, all of the team have really taken to this system, and that includes the people who, I have to talk through email every shift. They are brilliant at the system. So our new system, which I don't know how well you can see over there, but that is a snapshot of our call logging form. It's based on Google Forms, so it's free, completely free. All of the data is stored online. That was something else we were very conscious of, because GDPR is something that I don't fully understand, but I know we're compliant with because somebody smarter than me has told me we are. But I wanted to be very sure that we were storing everything properly in the right way. It is all stored in this Google account. The only time it leaves it is if we download the Google Sheet with it in it. And then, even then, it's only myself and a few others who have access to that kind of data. So it's an online form, very simple. So you get the times the call started, how long it's lasting for. There's nature of the call after that, which can range from anything from logging abusive calls, which unfortunately we do get, being an anonymous service, right down to sexual health, women's calls, men's calls. This is fantastic because it's tick the box. It is very simple. And something we want our volunteers to be able to do is to focus on the phone calls, to focus on providing the service. We are all volunteers, and to make this as easy and quick as possible. So we beta tested this with some of my tech savvier people who could tell me where I was going wrong. We did a great beta test for a month, and it went brilliantly. We got some improvements to do, and we changed some of the wording of things. Something we were very conscious of is actually the 4th point there: collect only what is offered, no digging and no assuming. You cannot tell somebody's gender by how they sound on the phone. So at the moment, if I was to make a call, because my voice is quite husky at the moment, I can be read as male by some people. You cannot assume. So unless somebody told us, we have a section that says caller did not disclose. And it's the same with age, gender, and location. Now, some finicky bits of that, people might say, oh, I'm in my 40s, or I'm down the country. So we also have sections that say rural but unspecified, or age brackets in tens. So it's one of these things, it's simple when you think about it, but we have to sit down and stop and actually think about it. I can tell you right now that we have had over 1,200 calls. That's of Wednesday this week. So that is this year alone. 32% of those are hang-ups, and that is something that we count because we have found, and callers have told us, sometimes they will call and when they hear a voice, they get scared, they hang up, or somebody walks into the room, or something like that. So we count hang-ups because we don't view them as just, an end of call, a wasted call. This is somebody who has tried to reach out and for whatever reason couldn't speak to us, didn't speak to us. There are some interesting insights from this already. Our caller base is over half male, so that's of the 1,200. 608 are male, majority of others did not disclose. 32 identified as female, 15 trans women, 3 trans men, no non-binary people, and 4 people who are in the other bracket. Again, all of these questions, it seems really simple, but we have a write-in option below gender. So we have male, female, trans man, trans woman, non-binary, and other where it can be written in. Another one, which I found particularly interesting, and I figured you all might too, is that our sexual health calls last on average 10 minutes. So this can be really helpful for us because it means that we can train new volunteers and say, okay, people may not just call and say, okay, I'm looking for sexual health advice. They may call about something else and then slip it in somewhere differently. So it was really interesting to see that something that I knew from being on the phone lines was actually true. And we have data to back it up. So where are we going to go from this? I have a feeling this is going to get better the more we use it. We're going to actually have stats and data that isn't compromising our ability as an anonymous organisation, but that we can actually put information out there and we can work in collaboration with other organisations. So for example, I know Men's Aid have approached us and have asked us about our stats on domestic violence calls. And could we share some of that anonymised data? So this is kind of the future for us. And it's simple, and it works, and it doesn't crash, and it's very pretty. So some ideas for next year, we're going to look at maybe logging our repeat callers to maybe give an idea of how many times one person might be calling back. We're going to look at our missed calls, so we may look at when it might be helpful to have a second volunteer on. And we're going to look at logging emails because we do email support quite low at the moment, but I think if we start tracking it, we can maybe start advertising it a bit better. So it's small changes. We're a small organisation, but this has made a massive, massive impact. And for the first time in a number of years, we're now going to be in the position to put out a proper annual report early next year, where there will be a lot more of this data gone into in a lot more depth, and just talking about our futures and planning for the future. So I think from an organisation that almost shut 2 years ago, we are making small changes and they are having a huge impact. And with 1,200 calls so far this year, people are obviously still reaching out. People still need services like this. And it's really heartening for me anyway to be able to stand up here and say, I do have numbers for that actually. So thank you all very much for listening to me. I know call logging isn't the most interesting of topics. I have tried to jazz it up a wee bit, but if you are interested in this at all and interested in what's been going on with the switchboard, keep an eye on our website or social media. We'll be putting it out there when our annual report launches. And we would love to hear from any of you. If you want to talk to me about this, you'll be my best friend. But yeah, so thank you to the GHN for having me here and letting me talk about this and listening to me talk about this. And thank you to all of you. It's been fantastic catching up and talking to you all.
Thank you, Julian. That was absolutely fascinating. In fact, it really is evident that you've thought through that process, and there's a huge amount of learning. And I'm not surprised that organisations are now coming calling and wanting to know a bit more about that. I think there's a huge amount that can be learned from that, particularly about how we can plan services. So that information is critical. So well done. I'd like to invite James O'Hagan from LGBT Ireland as our final speaker just before the break. And James is going to talk about Pride in Death, hosting an LGBTQIA plus focused death cafe, focusing on end-of-life care. So thank you, James.
Thank you very much. I'm also joined by the programme manager from the All Ireland Institute of Hospice and Palliative Care, Paula Pinto, who will be talking about some of this with me. It is, I suppose, it feels borderline ironic to be sitting here at 3 p.m. when everyone is dying after lunch, sort of trying to keep themselves awake, to be speaking about death. But it is, I think, a conversation that can be somewhat challenging for people to have, speaking about it outside of a kind of a humorous way. But I'm here to talk about a collaboration that came about between ourselves and LGBT Ireland, the Hospice and Palliative Care Association, and the Irish Hospice Foundation, in trying to understand what are the needs of members of the LGBTQ plus community when it comes to end of life and death. And I suppose it started out for me in talking to Paula a little bit about what actually, say, palliative care is. And there's an assumption that palliative care kind of lives exclusively at the very end of your life, that it's something that you only engage in once you are kind of facing those sort of final weeks or month. But in reality, palliative care is something that that will improve your quality of life over the period of time that you engage in it. And many people don't understand that, which is they aren't engaging in services that would give them a better quality of life throughout any stage of life-limiting illness or throughout a terminal diagnosis, if that is the case. But to talk about how it came to be, so Palliative Care Week happens every year, and I suppose it is primarily to educate and help people understand and make them more aware of the fact that these services are available. 43% of people don't feel ready to have conversations or make decisions about palliative care, and 43% also agree that if they do know about palliative care, they don't have enough information to make those decisions. So this year in Palliative Care Week, and Paula will speak a bit more about this, the decision was made to reach out to more marginalised communities who maybe aren't necessarily targeted for these sort of events, to sort of see if we can start community-focused conversations, taking some of the anxiety, some of the fear out of this subject, trying to bring people together to understand what is our perspective as a community on death, dying, end of life, and palliative care. So to give a sort of an understanding of, to paint a picture of, I suppose, when it comes to older members of our community and sort of who it is we are primarily drawn to identify when speaking about this particular subject. It is a population who are more likely to rely on a range of external services. So more likely to live alone, more likely to be single, and more likely to be lonelier as they age. Now, of course, very important to say that just because you live alone or single doesn't mean you're going to be lonely. It is just something that ties together a need, perhaps, for a reliance on external services as you age to help you live the best quality of life you can. With our older population, many of them perhaps haven't had the best experience throughout their lives to allow them to feel confident to assert their needs in spaces where perhaps they aren't sure of the treatment they'll get. These stats come from the Visible Lives study, which is from 2011 and is a little outdated, and probably if we looked at it again, I'd like to feel that we may have seen changes, but certainly with conversations I've had over the last number of years with older members of our community, I know for certain that many of them don't feel understood or respected by their healthcare providers and are afraid of harassment if they, particularly when they are engaging in intimate care, are to assert their identity or needs. And many of them have had negative experiences when they're engaging in civic services and healthcare services as well. Also, only less than half have discussed their final wishes and thought about their end of life. The good news within all of this is that this is a generation who are proud to be the first generation of LGBTQI people who are living out as older members of our community, the first people who are going to define what it means to grow old as an out gay, lesbian, bisexual, transgender person, and the first person who's going to define what it means to die as those people, and what do our rituals and traditions look like as we get the space to define them and create them. And I suppose it goes somewhat without saying that advanced planning in any circumstance in your life is going to give you is going to make you more comfortable and provide a setting to allow you more more benefits as you're kind of going forward. It's going to allow you to feel more confident and comfortable, particularly for members of our community. If you understand what you need and feel confident to assert those needs, you won't risk having your identity erased, because many times when people move into these services at a time of crisis, or when they aren't sort of at the place where they're able to, to speak on behalf of themselves, and there's no one there, they haven't prepared to have people speak on their behalf, their identity gets pushed backwards, because people do see the world in a more heteronormative sort of way. So we partnered with a number of organisations, ourselves, the Hospice Foundation and the All Ireland Institute of Hospice and Palliative Care partnered. We knew that we needed to have people in the room who could have the sort of conversations that were going to put people at their ease. They were going to sort of allow people to relax in a space, to have these sort of conversations that are challenging and are difficult to have. So we asked Bettina Corn, the End of Life Coordinator in St James's Hospital, to join us. She's run a number of death cafes within her service with people who are facing that end of life moment, to help them sort of understand and make the best decisions that they can. We also invited Liz Gleeson, the host of the Shapes of Grief podcast, who is an expert in the area of bereavement and grief, and deals regularly with the intersection of bereavement, grief, and identity. And from here, I'm going to pass over to Paula, who'll speak a bit more about the event as it unfurled, and sort of what we began to learn from the conversations as they happened.
Thank you, James. So before the event took place, we obviously had a lot of meetings to prepare and discuss about how this event was going to take shape. And we had the general idea of a death cafe, but we also knew that we wanted to change the format a little, so make it bespoke for the community, and as well to spin it around advanced care planning and the general theme around palliative care, and the fact that it's conversations that people in general don't have because we shy away from them, and they're tender conversations and we're scared of having them, but also to understand also the community and their specific needs. So the first thing we knew is we need to have a welcoming environment, because these are conversations that are difficult to have, but we also want the community to know that we thought of them when we were inviting them to this event. So we chose the Pierce Library, which has a great room full of natural light, but that's also private. And we had little details, so we didn't want to overwhelm with too many flags, but we did have one there as a symbol. But we also had flowers to fill the room with life and with color. We had tissues, we had a quiet zone in case at some point somebody needed a moment for themselves and just to step away from the conversation, because it can trigger all types of emotions. And we had images of queer icons who had died. So little details like this to make people feel welcomed. And as we continued meeting before the event to discuss on how we would run through it, we had a very structured facilitation in mind. And we also kept having in mind, based on previous experiences with death cafes, but also just previous life, personal experiences, that because these are hard conversations, that we would have to have a very structured approach. We would have to have prompters. So we had so many ideas. We had snippets of movies, of showcasing, a conversation that you could show to people so you could sort of set the room. We had structured questions. We had thought if we have too many people, or we would divide into groups. We had interactive elements. So all these things we thought that we would need to get the conversation going. It was all set in place. But then when people arrived and started coming in, we had around the room these posters. You see a picture there with questions just to get people thinking. So for example, at the end of my life, I want my care to include, and you would put your answer. Or at my funeral, I would like this song to be played. So just to get people talking. And then after you filled that out, you would sit around, people started sitting around the table. So when it was actually time to start the event, I remember James, Valerie, and myself huddled, and we said, should we move everybody now to the side to get like our videos running? It sort of felt like we were killing the mood because it was already a nice energy in the room. So we said, let's just all sit around and start the chat. And the response was overwhelmingly positive. So when we started setting out the scene in terms of this is palliative care, this is why we're here, and all the facilitators started presenting themselves, and all of us gave a little bit of our own personal reason for being here and shared a little bit of personal life, and the conversations just started flowing. So in terms of what we anticipated, we thought people would be afraid, that they would be anxious to talk. But actually people were incredibly engaged and talkative. And what we thought, we would need to fill time when we had these videos and these extra things, we went overtime. We had 2 hours set and we were at 3 hours, and we had to, bring the event to a closure because people just wanted to keep on talking. We thought there would be more men than women, but we also had gender diversity. We thought it would be older men, but we also had age diversity, and we thought it would be primarily white Irish, and this is the only thing we got right. It was primarily white Irish. So these are just some pictures of the day in terms of showing the atmosphere and the environment that we wanted to have that day, knowing that these can be dark conversations, and at times maybe they did take dark turns, but everybody was very respectful and engaging, and everybody was taking learnings from each other. And here are just a bit more examples of all the questions that were coming out. So for example, thinking about end of life makes me feel, I don't know if you can see it, but the first answer is anxious and it's red. That's my answer. That's the only one that I was actually able to respond from all these questions. I was completely blocked that day. I don't know if I was facilitating or presenting, but you can see people were putting all kinds of things in terms of song. There's Hold You Close from the Secret Sisters, Feels Like Home. My gravestone should read, it says, I don't want to have a gravestone. Others say, please scatter me in the forest, in the mountains, or in the sea. So it's just, giving people that trigger to think about different things. So on that day, there was 4 main takeaways that we took. So I think you'll present on 2, and then I'll present the other 2.
You may have seen in the request as to what song you'd have at your funeral that I was the one who had Carly Rae Jepsen Cut to the Ceiling. So, make it a party. So there were 4 main takeaways. I'll speak about the first 2 and pass back then to Paula to address the final 2. So I suppose the first thing that became quite evident as people were having these conversations and were so eager to speak and so eager to be able to kind of have this space was that there's a need for LGBTQI plus specific bereavement support that doesn't exist. So there is a bereavement support line. There's the switchboard and the LGBT helpline and many other support services that exist for LGBTIQ plus people, but nothing with a specific bereavement lens. And so we identified that this is something that was needed because people brought to the conversation not just conversations around their own anxieties around death and dying, but also their experiences of death and dying growing up through their life, their experience of bereavement and grief, where they sat with that. So we have developed a partnership now with the Irish Hospice Foundation, and LGBT Ireland will be giving LGBT training to the bereavement support line, and we in turn for our volunteers will be having support or sort of getting training to allow our volunteers understand where to signpost people to for that sort of specific type of support. The other thing that came through very strongly was that there's a want for more intergenerational networks and intergenerational spaces within our community. We'd made an assumption, a somewhat stereotypical assumption, that this would be a one-way desire, that this would be something that sort of older members of the community would want access to spaces that they were perhaps perceiving belonged to younger people. But in fact, it was a reciprocal want, but one that is very complex and nuanced, and that will take a community-wide conversation to understand how exactly we challenge this, because so many people, a number of people articulated, older men in particular, said that they felt shame about perhaps one man said that he would never dare cross the threshold of Bridie's bar because it would somehow indicate that he had failed, he had given up, he was someone who was a lost cause. That attitude lives within him and within many people within the community, and it is something that we need to talk about. But any of the spaces that do exist for connection intergenerationally tend to be limited to pubs, nightclubs, nightlife, and that's something we do need to talk about more so as a community, and as us individually as well, how we think about people who are aging and our own aging. That's back to Paula.
Thank you. So the other 2 findings one was about creating an end-of-life reference group, and this is in relation to the resources that are out there for members of the public and the resources for healthcare staff when they're being designed, when they're being with the information that's being put into them. They need to be informed by the community, because a lot of the things that were being brought up is when I see a leaflet, for example, the LGBTQ community, when you see a leaflet, if you don't see yourself represented, you're not going to pick one up. And while we already have this misconception around palliative care, for example, it even makes it harder then to reach this community if we're not designing it and in terms of what you need and what you would want to see there. And the same thing for staff in terms of training and educating and communicating in the right way, but making this in the way that the community is involved within the design and implementation of these types of documents. And a concept that came out of the conversations was the pearly gatekeeping. So talking about end-of-life rituals, and most of these are around religion, and religion usually takes the individual away from their own individuality and takes away from the community. And so we're talking about how we can go about this in a creative way, and even reaching out to funeral care homes and trying to put a spin on it so people, when they're reaching this end of life and going through these rituals, are not lost in that final stage of their life, but that their individuality still comes out and that there's creative ways to do this and to engage.
So these were just some remarks that came out of the data, so have prompted us to move forward to try and do more ourselves as a group, and to encourage other people to think about this as a subject that can be confrontational. But so I suppose one thing that came around, I suppose, not the timidness, not exactly, but the I suppose the sense that when you're from a marginalised community, it can be more difficult to assert your needs. So people spoke about how feeling like asserting what they wanted within death and within end of life felt confrontational, but there was also a sense you had to get over that because it was the way you write your way into life. So I think it's about how you can make your death your own. And the last thing before we finish up is just to say that we're going to be having another Death Cafe in Outhouse on the 8th of December from 5:30 p.m. I would really encourage you, if you are at all interested in what you've heard here, or have thought of any of these issues, to come along. It was one of the most life-affirming events that I have been to, hearing people so openly discuss something that is sort of such a taboo and there's so much fear around. And so get onto Eventbrite, register and come along and sort of find out for yourself if you want to. Thank you.
Thank you, James. Thank you, Sarah. Absolutely wonderful initiative. It seemed like a lot of empathy in the room, and that's something that's very hard to teach. So really well done. Congratulations on such an amazing initiative. Well done. We're going to take a very, very quick break, so people can grab a coffee, grab some sweets, and then I'll see you back here in less than 10 minutes if that's possible. Thank you, folks. Hi, folks. All right, we're going to take our seats once again. Welcome back, everybody who's joining us online. Yeah. Welcome back to everybody joining us online. Welcome to everybody here again. We've made it to the last session today, and some really, really interesting and exciting projects and outcomes that we've heard so far. I'm going to invite our final four speakers to give their presentations. John O'Donoghue from the Rainbow Project, Phil Corcoran from the Sexual Health Centre, Noah Halpin from TENI, and Adam Shanley from HIV Ireland are all going to talk now. So we're going to kick off, without further ado, with John O'Donoghue, Director of the Rainbow Project, and John is going to talk about the sexual health experiences of LGBTQIA people in Northern Ireland. Fantastic all-island focus of this conference. So without further ado, John.
Thanks very much. It's absolutely wonderful to be with you all today, and thanks for affording us the opportunity. Great to meet with old friends and meet some new friends, and great to catch up with our partners, excuse me, in the Man to Man project and in LGBT Ireland as well. And great to see an all-Ireland approach to the work to banning conversion therapy on the island of Ireland. I will start my own timer to keep myself to time here. Hopefully some of you will be aware of who we are and what we do, but the Rainbow Project is Northern Ireland's largest LGBTQI plus support and advocacy organisation. I can't go through everything we do because I'm so tight for time, but we provide a range of services to LGBTQI plus people, including counselling, sexual health testing, peer and social support groups, listening ear services, and a whole range of other services that I don't have time to go into, but check out our website and you'll find out more about what we do. One of the things I just wanted to touch on, because I'm trying to promote it everywhere I possibly can, in Northern Ireland, we're really pleased that we have now seen an end to the MSM blood ban and the ability for all gay and bisexual men to donate blood, or certainly no continuation of identity-based banning of people being able to donate blood. And I was really pleased last year to be one of the first gay and bisexual men in Northern Ireland to be able to donate blood. And a new deferral process, I'm not sure if it's the same here, is basically everyone can donate blood other than a few deferral points. If you change partners, have a new partner who you're having anal sex with, you have to wait 3 months before you can donate blood again. And there are also restrictions around the use of PrEP as well. But what I'm ultimately here to talk about today is our State of the Community survey. So the Rainbow Project runs a biannual, every 2 years, survey across the needs of the LGBTQI plus community. Previously, we'd done this on quite a thematic basis. We'd done research into homelessness, into hate crime, into mental health experiences and substance use. But we're finding that very hard to keep up with, to really be able to reflect the work of our organisation based on the needs we're seeing within the community. So what we've brought together in State of the Community is a single survey which reflects all different aspects of LGBTQI plus people's lives. So these are some of the results from the 2021 survey. You can see we had over 1,100 responses to the survey. 507 of those identified as male, 484 as female. So a good gender split there in terms of the gender binary. We also had 81 respondents who were non-binary, 16 gender fluid, and 42 presented their gender as other, and a total of 174 of all respondents identify as being a trans person or a person with a trans history. And you can see the breakdown of the different sexual orientations there. And a continued theme that we're seeing in Northern Ireland is a large number of LGBT women who will use the term gay to refer to their sexual orientation rather than lesbian. They don't feel that affinity with that term. In terms of age demographics, we were quite good. Really interesting to hear about the Death Cafe and some of the work that's happening with older LGBTQI plus people. As you can see from our results, we really hit a dip once we get into the 60 plus age categories. And I think a lot of organisations find this, particularly with online work, that it's getting harder and harder to reach some of those more marginalised members within our community as well. Then looking at some of the specific results we had in terms of sexual health, so you can see that 29.75 or 285 respondents had accessed sexual health testing in the last 3 years. So that's about almost 70% of people who hadn't accessed any testing in the previous 3 years. Men were substantially more likely to have tested in the last 3 years than any other groups, and you can see the breakdowns there and the substantial difference between women, trans people, people living with disabilities, and those who identified as male. Women and trans people were much less likely to have accessed testing, and respondents overwhelmingly were very satisfied with the services that they had accessed, whether that was through GUM clinics, through the home testing service, which we call SH24, overwhelmingly very happy, or indeed services with us at the Rainbow Project. And GUM services were the most common access services during that time, followed by the at-home testing, and you can see there 60-30 kind of split, with about 10% accessing community-based services on top of that as well. Moving on then, so 2 out of 5 respondents had never accessed a sexual health test within their lifetime. Trans people were least likely to have accessed any testing, with 68.2% having never accessed testing within their life, and then followed by people living with disabilities as well. And more than half of all female respondents had never accessed testing within their lifetime either. 12% of trans and non-binary people choose not to attend appointments at GUM despite requiring one due to concerns about discrimination. So these are people who have had signs or symptoms or have been presented with some level of risk who have said, no, I'm not going to a GUM clinic because I'm concerned about facing discrimination. And 6% of trans and non-binary people said they wouldn't attend GUM due to previous negative experiences. And this is something we've been speaking to Public Health in Northern Ireland about. Basically the gender split that we find in a lot of our services. So you've got male waiting rooms and female waiting rooms, and often the services that are available in those different spaces are very gender specific. So for example, a certain service that a trans man may need to access is only available on the women's side of the clinic. And you can see there an example of a story from one of our respondents who tried to access care before, but being led into the male section from the female section was soul destroying for a trans woman. 77 respondents had previously or are currently taking PrEP, with 42 of those currently on PrEP. 57 of those had accessed PrEP through the GUM clinics and 15 through I Want PrEP Now. The most common reason for stopping using PrEP were that it was no longer required. That was 14 of our respondents. And 9 clients reported that they were unable to access PrEP through GUM. We're certainly not seeing the level of uptake of PrEP in Northern Ireland that we're seeing in other constituent parts of the United Kingdom, or indeed in the Republic of Ireland as well. And you can see that of our 400 and something male respondents, that only about 60 of those either were on or had previously been on PrEP as well. Now, we've been working very closely with Public Health to try and encourage people to access PrEP, which is available through all of our GUM clinics across Northern Ireland, but there still seems to be substantial barriers to people accessing PrEP or identifying themselves as somebody who should be on PrEP as well. 14% of respondents stated that they felt they needed to access a sexual health service but decided not to, and men were more likely to attend, but were also more likely to identify that they needed a sexual health screen and choose not to do that. Reluctance to speak to family GP was the most common reason for not attending. So again, getting that information out about how sexual health services are delivered, what information is required to be gathered within those services is going to be so key to continue to break down some of those barriers for accessing testing. And you'll see on the sides of my slides here just some examples of some of the ongoing work that we're doing. This was an event we held for World AIDS Day. No, it wasn't actually. It was a talk just about living with HIV. And as much as possible, we try to platform people who are living with HIV and people with lived experiences to talk about these particular issues. And this young man here, Hugh, is living with HIV along with our Leo, our Sexual Health Development Officer, talking about living with HIV in modern day Northern Ireland. Some of the key issues, I guess, that we've identified through the State of the Community, and there's a lot more information available on this on our website, and we'll be doing a fully published report in January of this year for anybody who's interested and wants to read it. But things that we've identified is to ensure that services are promoted to and are accessible to trans and non-binary people. We are definitely seeing substantial barriers to accessing some of these services, particularly sexual health services, and the lack of understanding, acceptance, and even the systems that are in place for trans and non-binary people, the questions that they're asked, the level of understanding that exists within sexual health services of the experiences of, the needs of, and the issues that may be faced or barriers for trans and non-binary people are not well understood. The need for dedicated support and information for lesbian, gay and bisexual women around their sexual and reproductive health needs. Again, this is something where certainly we feel that we've fallen short, and we're seeing an increased number of LGBT women coming to us seeking information and support in terms of their reproductive health needs and wider sexual health needs as well. And I would include in that some physical health needs as well. And in Northern Ireland, we're continuing to see the refusal of or a suggestion that lesbian, gay and bisexual women don't need to worry about particular health screening processes around certain cancers because they're not having sex with men and therefore are deemed to not be at risk, which is a myth that unfortunately is perpetuated for many years around the health needs of LGBT women. Continued targeting of GB men around sex, key sexual health messages and support as well. And then another little event that we run, these have been really successful with the regional colleges doing student sexual health drop-in sessions for information, support and advice, but we also offer rapid HIV and syphilis testing during those sessions as well. Some of the other work that we're doing, we're running currently our Steps to Zero or HIV to Zero campaign, which is seeking a government commitment to work towards zero new HIV diagnosis in Northern Ireland. This is a campaign we've been running for about 10 years at this point, and it's really heartening to see so many governments across the world, but including across the United Kingdom, committing themselves to working towards zero new HIV transmissions by 2030. Something that is entirely achievable with medicine being where it is, where our understanding of HIV being where it is, and access to appropriate medications and understanding of how HIV is transmitted, in particular around the U equals U message. There's so much that we can do to work towards that zero new HIV diagnosis target for 2030. And our Steps to Zero campaign is about addressing stigma, increasing testing, increasing education, working on preventative measures, etc. The Rainbow Project also delivers RSE programs in partnership with Relate, the relationship charity in Northern Ireland, and Nexus, the sexual violence charity as well. And partnership has become a key part of how we're working, realising that as a small organisation, we can never be all things to all people. So seeking to work in partnership with other peoples with either expertise that we don't have, or indeed who can open doors that we still are unable to open, has been so key to the growth and the development of both the organisation and the services that we provide. And in Northern Ireland, there is no requirement for sexual orientation or gender identity to be included within relationship and sex education. And I imagine quite similarly to here, all of our schools are religious ethos schools. So while there's no specific requirement under the curriculum for them to be inclusive of LGBTQI plus people, lots of schools choose not to be. So we're continue to perpetuate this problem where so many LGBTQI plus people are not getting the information that they need to be able to make informed choices about the sex that they choose to have. A lot of the sexual health information that they're receiving is entirely irrelevant to them, and then are moving into adult life seeking to self-educate or are required to be educated. One of the services we provide is our rapid HIV and syphilis testing, which on the face of it, you would imagine that service is all about results. Let's find all the people living with HIV and living with syphilis and get them treatment and support. And that is a key part of the service. But for me, the most fundamental part of what we do is our risk assessments and our information support and advice. So every client who comes in, we ask them about their sexual history. We ask them about the types of behaviours that they engage in. And we're able to give bespoke one-to-one support and advice to that individual to say, look, if you're engaging in fisting behavior, for example. Here's ways that you can minimize the risk to yourself. Here's the way that you can minimize your risk to your partner, ensuring that those people who need to be on PrEP know how to access PrEP, are getting signposted into clinics, etc. That one-on-one education time to give people the information they need to make informed choices really can be life-changing to that individual. In terms of training, we deliver an awful lot of training. Last year, we delivered 136 training sessions across Northern Ireland to a whole range of different organisations. And we deliver training around sexual orientation and gender identity. We've also developed non-binary awareness training as well, which has been one of our most successful training sessions to date. It can only be accessed after accessing the sexual orientation and gender identity training, because it is so bespoke to the experiences of non-binary people as well. So rapid HIV and syphilis testing I've already talked about. Safer sex materials, outreach and support, and information and advice clinics. We distributed about 100,000 safer sex packs every year, outreach to different bars and clubs and different LGBTQI plus venues. And we also provide safer sex materials to the gay saunas in Belfast as well, ensuring that anyone using those facilities has access to free condoms and lube and wider sexual health information, support and advice. We run Northern Ireland's only co-cultural LGBTQ plus affirmative counselling service, which is a big way of saying all our counsellors identify as LGBTQI plus, and they only work with clients who are either questioning their sexual orientation or gender identity, or those who are LGBTQI plus. It doesn't mean that we don't think that cis-het people can work with LGBTQI plus people. Of course they can. But as many of you who work in organisations like ours will know, the cultural competency that comes from seeking services from another LGBTQI plus person can be so key to removing barriers for clients to be able to access services. Some of the new work that we're working on, we're developing a feasibility study around a new community-based testing service and a community-based PrEP clinic for Northern Ireland as well, to try and address that shortfall in uptake of PrEP that we're seeing. I say I've run out of time. Yes, also partnership, which Padraig has already talked about today with the man-to-man service on PrEP and PEP testing, safer sex and chemsex as well. And we also run Northern Ireland's only sex worker support group as well. And that's not just for LGBTQI plus people, that's anyone who is currently a sex worker or has a sex working history as well. Yeah, all of that I've touched on. And yes, responding to the increasing chemsex activity as well, something that we're seeing on the rise in Northern Ireland as well. And I'll stop there. That's my 15 minutes. Thank you very much.
Well, what have you done today, John? That's the question. That's a fantastic amount of work and a fantastic coverage. I am pleased to say, just as you mentioned it, that the blood donations criteria has changed and is much more in line with what's happening across the border. So that's good. It's great to see that. Our next speaker is Philip Corcoran, and Philip is going to be joining us by Zoom, a little bit of technology. And Phil is the Health Promotion Officer down in Sexual Health Centre in Cork. And Phil is going to be talking about, the title is We're Here, We're Queer, and We Need LGBTI plus Sexual Health Support, Supporting the LGBTI Community and Those Questioning in Modern Ireland. So this is based on work that's been done. Oh, no, I'm sorry. Noah, in that case, we'll skip that. And thanks, Phil. Our next speaker is Noah Halpin, who is the Healthcare Officer with Transgender Equality Network Ireland. And Noah is going to talk about using PrEP as a trans person. So welcome, Noah.
And which is the change?
The space bar.
Space bar. This one. Excellent. Thank you. Thank you. Firstly, full transparency. The past hour I feel a little bit weak, so apologise if I drop to the floor. I won't drop to the floor, don't worry. If I don't present as strongly as I normally do, though, I'm sure there's enough nurses in the room to quietly drag me out from the floor. But firstly, Gina, John, thank you for having me. I really appreciate it. I guess when we talk about sexual health, we don't always solely speak about the trans community. And specifically when it comes to PrEP, we don't hear very often about the fact that when trans people take PrEP, it can be a little bit more nuanced in terms of the histories that we might have to go through, the different body parts that we might have, and how that might affect how we take PrEP. So firstly, my name is Noah Halpin. I'm the healthcare officer for TENI. TENI is the Transgender Equality Network Ireland. We're the sole trans representative organisation in Ireland. We are governed by our volunteer board, and our operations are led by our CEO and our staff members. So my role as healthcare officer is quite broad, but part of that is helping the trans community to navigate sexual health services, giving information about the likes of PrEP, where people can seek PrEP, and the different kind of things that might be a good idea to inform practitioners of if you are going to go on PrEP. So just a little bit of a content warning, just in case there is anybody in the room that might be a little bit uncomfortable with anatomical terms in terms of genitals or talk of sexual behaviours. I will be mentioning a little bit of that throughout. It's unavoidable, I'm afraid, so just to let you know. So firstly, just for anyone in the room, and for those who are already aware of this terminology, please be patient with those who aren't. So I might be using some of these terms throughout the presentation. So gender affirming hormone treatment, we no longer call it HRT because it's for trans people. We're not replacing a hormone. We are using gender affirming hormone treatment. So this is the more up-to-date term that we do use. So that's what that will mean when you see that. Transmasculine, we're moving more away from solely calling people trans women and men, because not all people will refer to themselves strictly as a trans man or as a trans woman. So this is what I will mean when I speak about transmasculine, transfeminine, non-binary, someone who does not identify strictly within the male or female binary. When we talk about the word frontal sex, what we normally mean is receptive vaginal sex. And then when we talk about neo-vaginas or neo-penises, that's basically a vagina or a penis that's surgically created. And leading on to lower surgery. So someone who might have a neo-vagina or neo-penis might be someone who's had gender-affirming lower surgery, so surgery of the lower genitals. So, question, can trans and non-binary people take PrEP as a HIV preventative method just like their cisgender counterparts? You're all very quiet. Can they? Can we? Yes. Okay, very good. Yes, you're all very good students. Okay, so to get into the kind of nitty-gritty information of it. So evidence, there has been a number of studies does strongly suggests and actually confirms that PrEP does not affect the blood levels of gender-affirming hormones. So for a very long time, a lot of trans people, and more specifically trans women, were avoiding taking PrEP because of a misconception or a myth or a misunderstanding that it might affect their hormone treatment. We now know that that is not true. So gender affirming hormone treatment, it's not been found to raise or lower the levels of PrEP in transmasculine people who are on gender affirming treatment. In terms of transfeminine people taking gender affirming hormone treatment, there does appear in all studies to be slightly lower levels of the PrEP drug tenofovir, but it's not enough to affect the protective levels of PrEP within that person's system, which means that you can take both effectively. So that means that both trans feminine people and trans masculine people can take both PrEP and hormone treatment effectively with the correct dosing and adhering to the correct regimen. But there are some things that we kind of trans people, when we talk about PrEP and trans people, there are some things that we need to know a little bit more about. So what is that person's gender identity? And this is what we should be asking everybody who is seeking PrEP. What is your gender identity? Was that the gender you were assigned at birth? If that person says no, you immediately know them to be a trans person. It's a kind, polite, understated way of finding out if someone is trans without directly asking the question. If they say yes, an important point to find out is, are they on hormone treatment? Another important point is to find out if they've had lower surgery, and my next slide will explain why. And also, What's also really important is to ask how the person has sex and what body parts do they use to have sex. And this is why. So like all individuals, like every person in this room and every gender identity, every sexuality, trans people have sex in many different kinds of ways and all types of ways. But our bodies can be a little bit more different from what some people might perceive from the outside. So this is why clinicians finding out exactly what type of body parts that we have in a respectful way, finding out exactly what types of ways we have sex, and what kind of hormone treatment, if any, that we are on in order to correctly prescribe PrEP effectively to us. So a daily dosing PrEP regimen is advised for all trans people taking hormone treatment. Trans and non-binary people who are not on hormone treatment and only engage in receptive anal sex or insertive penile sex, they are candidates for daily dosing and also for event-based dosing. They're not on hormone treatment. They might be only having receptive anal sex, or it might be a trans feminine person who only uses her penis for sex. Which means they can take both regimens. But there are other considerations with trans people that we don't often have to, or well, we never have to think about with cisgender people so for example, trans masculine people who are on hormone treatment, a really common symptom, side effect, not symptom, of testosterone for trans masculine people is what's called vaginal atrophy. So that could be the thinning, or the weakening of the vaginal wall or the cervix. So that can make an individual's vulnerability to HIV that little bit higher, which is why, again, daily dosing is very important. And then also if somebody might have had lower surgery, so in that case, they might have a neo-vagina or a neo-penis, which is a surgically crafted piece of surgically crafted vagina or penis. Now, there is not enough, if any, real research to understand the absorption rate of the tissue of a neo-vagina or neo-penis to advise any other type of PrEP dosing other than daily dosing. And these are the two kind of considerations that we need to make for trans people that we don't often need to make for anybody else. So this might better just kind of, I know that's a lot of information, so it's a little graph of how you kind of determine how you can prescribe, or if you are a trans person, the information you need to know. So if it's a trans or non-binary person, the first question, are you taking HRT? Sorry, I even used the wrong term. Gender affirming hormone treatment. If the answer is yes, it's always daily dosing. If the answer is no, there's a couple of more questions. So is that person having receptive vaginal sex? If the answer is yes, it's always daily dosing. If the answer is no, that they're only having receptive anal sex or insertive penile sex, well then that person can event-based dose or daily dose. But then there's also this consideration in the corner here. No matter whether someone is on hormone treatment or not, if they have had lower surgery and they use those genitals for sex, again, daily dosing is always recommended because there is not enough research around the absorption rates of these types of tissue. So when we're thinking about creating an inclusive space, and John touched on this just before me about trans people often reporting having negative experiences in healthcare, and this is across all sections of healthcare. It's across general health, sexual health, gender affirming health, and the reports that we really often get are things like point blank transphobia in a healthcare environment, and things like what we call trans obsessionalism, so where people can only see your transness and nothing outside of that, where clinicians might obsess over, say, your hormones. If you go in with a broken toe and they spend 10 minutes asking why you're on hormones, it has nothing to do with it. So this is what we call trans obsessionalism. Infantilization. This is something that often happens to trans people. For some reason, we are seen as less knowledgeable, like we don't have as much agency over our bodies as other people do. We tend to be infantilized within healthcare an awful lot. Discrimination, also a lack of knowledge from healthcare workers, and little microaggressions like people calling you your name to your face but going around the other side of a curtain, which for some reason a lot of clinicians think is soundproof and is not, and will refer to you as a different name when they're talking about you. So there's these kind of, and this is what kind of prevents a lot of trans people from seeking healthcare, and especially sexual health, where it might be a little bit uncomfortable to talk about genitals, sex, you know, your bodies and things like that. We can change that. We can make this more inclusive. And one of the first things I always say is education and training. Get in touch with and reach out to organisations, trans organisations. I do trainings all the time. Other organisations, HIV Ireland, belong to, things like that. We all do trainings. Inclusive registration forms is so important. Sometimes it's much harder for someone to speak something that's uncomfortable. So, you know, these questions on a form can be a lot easier for someone to give out the information that people might need. Asking people their gender identity, their pronouns can go a really long way in being able to create a trusting relationship with someone. Then again, it's ensuring that you receive the relevant history, but doing that in a manner that is not super intrusive, that it's respectful of that person. But especially when we're talking about something like PrEP or sexual health, consistency in care is so important. And with trans people, it might require a little bit more attention to detail, a little bit more double checking charts, because I can't tell you the amount of times I've gone to the sexual health clinic and one day they give me 3 swabs like I'm supposed to have. The next time I go in, they give me 2 because they don't read the fact that I'm trans and they think I'm a cis man. And so it's a little bit more of looking into people's charts again for a second time, especially if you're being seen by a different person each time. And also people's circumstances might change. The last time you saw them, they might have had a vagina, and next time you see them, they might have a penis. So it's updating that information an awful lot for trans people is really, really important to ask if any of that have changed. They might have a new partner who have different genitals, so they might change the way that they have sex as well. Then again, signposting. This is something I think most people here will agree. We need to get better at being able to signpost and communicate information about sexual health and PrEP to trans people. The amount of calls I get from trans people, whether it's trans masculine people, trans feminine people, non-binary people, saying, am I allowed to go to the Gay Men's Health Service because I'm a trans woman? Or am I allowed to go because I'm a trans man and will they still see me as a man? Am I allowed to get PrEP because it says GBMSM? You know, so it's changing that language, letting trans people know that they are allowed to go to these services, they are eligible. And this is maybe something we as a community and as different entities need to work together on to make that messaging just a little bit better. And the very last point is collaborative care. Patient involvement is really important. Getting the opinion and the experiences of patients going through services is going to do nothing but make for really, really good therapeutic relationships. And what I always say, trans people often have to be their own doctors. And for some reason in Ireland, clinicians get a bit threatened by knowledgeable patients. But when you have a knowledgeable patient, it can make for one of the best therapeutic relationships. Knowledgeable patients are not people to be afraid of. They're people to learn from, where each other can learn together, which is a really, really important point that we often forget in healthcare. So these are just the key points that I will leave you with that we learned today, and I hope people learned today and were able to take in. That understanding the bodies of individual trans people and how they have sex is important for effective use of PrEP. Oral PrEP drugs do not raise or lower the levels of gender-affirming hormones. Hormones taken by trans women appear to slightly lower levels of the PrEP drug, tenofovir, but not enough to affect the efficacy of daily PrEP. Hormones taken by trans men do not appear to raise or lower the levels of PrEP. And event-based dosing is not recommended for either trans women or men on hormone treatment. If anyone would like to look into any of these studies or would like to read a little bit more of the interesting, more in-depth information about all of this, feel free. You can contact me. I can send you this information, or you can take a picture of that slide. And that is about it. If anyone would like to contact me in future, that's my email just there. And I hope I kept the time, Stephen, did I? Okay, thank you very much.
Thank you, Noah. It's really critical that we keep talking about trans healthcare in this way. It's an issue that's really difficult in Ireland. There's not enough being spoken about it, so that's an excellent and very comprehensive overview in relation to PrEP. Now, is it Phil? Adam. So our next speaker is my colleague Adam Shanley from the HIV Ireland Empower programme. And Adam is going to provide an update on the work, the great deal of work that's been undertaken this year by the Empower programme. So, Adam, thanks. You can have it all you want.
You can use that or the click down.
Oh yeah, fine. Thanks. Hi folks, how are you? My name is Adam Shanley. I'm the Empower Programme Manager at HIV Ireland. It's really great to be back in a room with people again, and I was just actually musing that the last time that I stood up and spoke about the work of Empower in an actual room was actually the evening we launched Empower. So it's kind of nice that we're back. It was a very packed room in the Irish Museum of Modern Art. And we were all very excited about getting Empower on the road, and then the very following week we were all in lockdown. And the excitement of that was, of course, Zooms galore. So it's really great to be back in the room and to be able to share the work of Empower that we've been doing since then. So just to give you a bit of an overview of what Empower is, we're a peer-driven community level interventions that are looking to respond to the sexual health and wellbeing needs of gay and bisexual men. We kind of, I guess, the foundation of all of the things that we develop is that they're sex positive, is that they come from a space of a judgment-free space, and that they're harm reduction based as well. The overall aim is to achieve a reduction in the acquisition of HIV and STIs, but also to improve our sexual well-being as a community. So since we launched, there's been a number of different things that we have developed, either that they've continued from before or that we've looked into the community and responding to the needs. So we've rapid HIV testing, HIV self-testing, outreach. We're involved in outbreak responses in our community, developing responses to chemsex. Almost all, if not all, of our work is based on evidence. So research is a really important part. And obviously then as well, we're involved in advocating for our community in different elements that touch off sexual health. So I'm going to give you a touch point on a couple of these things and delve into a couple more. But first, I just want to introduce you to our team, who are all in the room, which is great. We have Davey. Davey is the Empower project coordinator, and he looks after all of our volunteers delivering our rapid HIV testing service, also our HIV self-testing service, and also ensures that we all kind of work over different elements of outreach, and so Davey feeds into that too. Diego, who has been with Empower from the very start, and we've worked together for a very long time. And Diego is one of our outreach workers, and while responds to anybody who needs support through outreach, has a particular interest in supporting the needs of our very vibrant Latin American community, and also sex workers, male sex workers in our community too. Mark's not here. Mark actually had his PhD Viva today, and we were all very excited in the middle of the day when we got it. I passed. So congratulations to Mark. Mark is also one of our outreach workers, and he has a particular interest in supporting men who are not out or in peri-urban and rural areas, who need support around their sexual health and their well-being. And our newest member of the team is Andrew, and Andrew joined us in September, and he is our chemsex project coordinator. So he'll be specifically looking at developing responses to the needs of our community in the space of sex and drugs, which has been an issue that has warranted a response for a very long time. And so we're really looking forward to inviting you all to the launches of new services in that space in the coming months. So that's our team. I'll jump into rapid HIV testing. This is a peer-led, volunteer-based service that we do in community venues across Dublin. It's basically offering a finger prick test where you're able to get a result within 60 seconds. Davey has been involved, as I say, in training a huge number of volunteers. At the moment, we have 40 active volunteers that come from across our community, and it's gay and bisexual men offering this service to other gay and bisexual men, again to look at reducing barriers to accessing testing. We do it in our bars, in our clubs, our sex on premises venues, and again with that idea of if it's in a community space offered by a person from the community, that may lower the threshold to access testing. During the pandemic, obviously many of those venues, all of those venues, were closed, and so we did a bit of pandemic flexing, which sounds like it was, I don't know, like a gym in your front room. But what I mean is that we looked at how can we bring the service we were offering in community spaces into our office space and continue to offer, because people will have ongoing risk throughout the pandemic, and so our volunteers, HIV Ireland, the space at HIV Ireland, all flexed into making sure that we continued services, particularly important because many of our bricks and mortar services weren't available during that time. So a quick snapshot of 2021, we had 96 testing sessions that all took place at HIV Ireland. We had 750 rapid tests during that time. 4 results were reactive and all 4 were linked to care and confirmed positive. 83% of the service users identified as gay, bisexual, or men who have sex with men. Again, all of our work is targeted towards including gay and bisexual men, but often, many people, we would never turn anybody away who wants to know their HIV status. So it's good to see that 83% of those who are using the service are gay and bisexual men, and that the targeting is working. Also important that more than 1 in 5 had never tested for HIV before, which of course is a really important metric. So when people are offered a test, they register through their mobile phone number. It is a non-identifiable. We only take non-identifiable statistical information, but it also, when registering with a mobile number, it does allow for us post-service to send out a feedback form, a link that you can give some quick answers so that we can better tweak the service to better respond to needs. So we get a really, really high response rate. 24% is really, really good, and the feedback is on the whole also very positive and very constructive criticism or constructive feedback that allows us to make changes. We also, I guess HIV self-testing was something that we always wanted to achieve, but I suppose the pandemic gave us a bit of a kick in the bum to make it happen, again, because so many services were curtailed. We launched Ireland's first HIV self-testing programme, which was a nationwide campaign, and we developed a portal where people could log on, again, give very, very little information, so they could, again, removing as many barriers to accessing testing as possible, making the online ordering system as simple as possible. We'd pop it into a plain envelope, and it would be sent out and usually delivered within the next day or two. We offered support through the outreach team available throughout, either before, during, or after using the test. And that's available through phone, text, WhatsApp, Zoom if needed, to ensure that people have the support available to them if they need it. And of course, with both this service and with the rapid HIV testing service, we have really established referral pathways into care should there be a reactive result and a need for confirmatory testing and treatment. So again, a little bit of a snapshot of what we did in 21. We delivered over 1,500 HIV test kits in 2021. We actually launched the service initially just before Christmas in 2019. We had a donation of 2,000 test kits, which we were really eager to think would last us for a full year. And actually, such was demand that we actually thought something was wrong with the website, but such was demand that all 2,000 test kits were ordered within 13 days. And so it really showed that there was a demand. Some of that was because it was reducing the barriers, and this was a new novel way of accessing testing, which Kitty in her presentation earlier today highlighted. as an important reason why people want to use self-tests, but also was indicative of that wider access problem, I think, as well. So when we rebooted the service in 21, we had to limit the amount of tests available each week. In the whole of 21, we had over 1,500. All 100% of people who we offered the service to identified as GBMSM. Almost a third were not born in Ireland. 20% had never tested for HIV before. So again, really important that we're reaching people who've never tested before. A really significant number, 94% of those who tested with us used the self-test. We're not using PrEP. And even, I guess, most important from that is that more than a third of people had condomless anal sex within the last 3 months. So it's really indicating that people that were using the test who would benefit from PrEP aren't using it. And so there's an opportunity as well through outreach for us to encourage people to be aware of PrEP. So again, similar to our rapid testing, we're able to offer a feedback survey which goes to people a week after the test has been sent out. Again, a really high response rate. A third of people who ordered with us have responded. And again, it's kind of pointing to removing those barriers, feeling it's quick, it's reliable, it put people's mind at ease. And also maybe some barriers around people who are not born in Ireland. And we heard earlier about feeling that perhaps other services aren't available to them, and that this may be a gateway into accessing services. Outreach, how am I doing on time?
You're about
4 minutes. Outreach is an integral part of our work. I need to update that picture because we're a bigger team. Offering information, support and referrals through a number of different ways. We're very active on hookup apps and websites, so Grindr being one of the main ones. We're available through WhatsApp, Zoom, email, phone. We've tried to make it as easy as possible to be accessible. Obviously, during the pandemic, we weren't able to get into. We used to have our boots on the ground in many clinics, which we hope in the coming year we'll be able to return to. But we're also available in venues, and it's basically making ourselves very visible so that people can ask questions that they might feel they don't have the answers to, or they might feel more comfortable asking a peer. We also, through the National Condom Distribution Service, we make condoms and lube available through dispensers in LGBT venues across Dublin and in some venues across Ireland as well. And just a quick snapshot then, in 2021 we had nearly 3,500 interactions through our outreach team. The vast majority were identified as GBMSM. Again, the lion's share were interactions on our hookup apps, gay hookup apps and dating sites. Although a significant number of people felt comfortable reaching out through text or WhatsApp, and email is also in there. The kind of main areas of support is around HIV, also STI, particularly is around STI testing, and PrEP is a really important and kind of persistent topic of conversation. And then we do a lot of referrals, obviously, so from those areas, referring people in towards SH24, our own self-testing service, and on to the Gay Men's Health Service and St. Vincent's were the two most popular, because that was reflective of PrEP appointment availability during the year as well. So again, we in a different way, in that after an interaction that that people have with us, our outreach workers send a link to individuals. This tends to result in a much lower feedback, which is interesting, probably because their mind is on, maybe actioning what they've heard from the outreach worker as opposed to responding to a survey at that point. But it's still a considerable number of people, 146 people responding. And again, really, really positive conversation or feedback that we get from service users. So just really quickly, we've been involved in a number of different outbreak responses, and it's been a bit wild over the last year and a half. Obviously, there was a national outbreak of syphilis. Monkeypox visited us, and it's not specifically related to sexual health. We've also done some support around online safety, around hookup apps as well. So just very quickly, one of the things that's come across really strongly for me in today's conference is that partnership and collaboration is really, really key. And I think both the syphilis outbreak and the monkeypox outbreak is a really, really, really solid example of how important it is that we maintain partnerships and collaboration. And it's really, really the way forward, particularly I think when we're faced with emergencies like this, but also in the kind of quieter times that we maintain those relationships. We had a syphilis pop-up, which you heard about earlier, which was a really great opportunity for us to all come together and show that the value of the different expertise and how we can actually get to an output and an ending. We haven't ended the syphilis outbreak yet, but this is a great example of what we can do. Similarly, the monkeypox outbreak, a mixture between community engagement events, outreach in our venues, engaging Grindr to get our messages out there, using social media to our benefit as well. There's been a lot done in this space, and there'll be a lot more to do. And again, really, really important partnerships between public health, HSE, man to man. It's been a really, really important way to deliver work. I'm almost there. You did say I could go on a little bit longer. Nepotism. Is that nepotism? So what else do we do? As I say, Andrew is going to be leading out on our responses to chemsex. We've started with a sex party first aid guide so people know what to do in emergencies that arise. But there's lots and lots of work to do in this space, and there's a lot of need. We've definitely heard that from through research and from our community. Research, as I say, really an integral part. This was a nationwide survey that we did on the impact of COVID. We're about to launch a survey about the impact of monkeypox, and it's all so that we can inform, what we did it work, and what do we need to do going forward. And similarly to the speaker from the Rainbow Project, we were involved in a removal of the ban from 12 months to 3 months, and as of Monday the 28th, a full removal of gender and sexuality specific restrictions on blood donation in Ireland, which is a great win. Very finally, I just want to say that one of our volunteers, Darren Lacken, he passed exactly a year ago today, and I just wanted to dedicate this presentation and just take a little bit of space to remember him. He was a really wonderful man, and he gave a lot of heart and dedication to our work, so much so that his husband ran a benefit ball for in the name of Empower a couple of months ago, and that will allow us, as you've seen from a lot of our work, has focused specifically on sexual health, but the money that was raised from the benefit ball will allow us to work specifically now on more sexual well-being pieces, which are often more difficult to find funding for. And so we've earmarked that money into what we are calling the Darren Lacken Fund, and I really look forward to sharing what we develop in his name, maybe at the next Gay Health Forum. Thank you very much.
Thanks, Adam. Thank you very much. Just as we're getting the last presentation set up, I just want to say personally thank you to, as Adam just mentioned, first of all, the Empower team, the volunteers that work with us in HIV Ireland, but all of you volunteers, all of you who stayed on the front line during COVID-19 and how difficult that was, and people meeting people face to face, testing and other services continuing to roll out all that time. We couldn't be in venues, so all of us in this room were innovative in how we did that. And it really can never be said enough about how much energy and how much commitment people gave and are still giving. So thank you to all of the volunteers out there. And if you're watching, thank you. We're waiting for Philip from the Sexual Health Centre, and it is our last presentation. It is our last presentation.
Sorry, I get mixed up. No, hold on a second.
He's zooming in. So if we just put the YouTube, if we can share the YouTube,
Yeah.
that would work.
So it's on Google, is it?
Yeah.
YouTube.
Yeah. Just go to search there.
And what?
GCN Mag. Space Mag, I think. Oh, you can just click into this here. Okay.
Welcome to Mackenzie Fleet, Ireland's leading independent vehicle leasing and fleet management provider. Welcome to Mackenzie Fleet, Ireland's leading independent
Are we able to share it up on the screen? Do you need full screen it maybe?
So it's the camera.
But we're going to be turning that off and putting him on. Do you have the like HDMI setting thing, or where?
There, I'm going to do setting now. Display.
Do you want me to try plug in my HDMI?
Yeah. He's on yours now, is he? He's on yours.
Just waiting.
See what it works.
I don't know if I have the same HDMI.
Now, there's your.
Okay. Right, let's see if this works.
Put yours on mirror, isn't it?
Sorry?
Yours is an Apple, isn't it?
Yeah.
If you go into settings, I think put it on mirror display. In your settings. Yeah, Apple settings. Display and then if you are a pensioner, if you're on adequate pension, it gives you that bit more freedom to do stuff. And then if you're struggling, so it's kind of how people can access these situations. Or so how many, I can understand about white Irish, but how many of them are working class Irish as well. So it's something that ties into the whole thing about marginalisation. I can give them a speech here. The other thing was Telefriend. People say, how old is she? And I don't like telling anyone. Then I say, well, I was 32 and I went down Ballyfermot Road into the phone box, put my money in and phoned Telefriend. So that gives you, and that was 1981 or 82. So they're there around a long time. It's amazing, you know. That's what, there was a few others. The self-testing, the HIV one is interesting. It looked like to me that from the self-test, less than 0.5% were positive or reactive. 4 out of 700, isn't that right? So it's less than 0.5%. And then when people are testing, so is the rate of testing positive going down? That was one of the things that was in my head. And many were retesters. That's all. I don't know if anyone wants to say anything or add on to what I was saying.
I would say that one of the things that we've seen this year, which is very unfortunate, you can count these numbers any way you want, but it was mentioned I think it was in Martin's presentation, that there was 404 newly notified cases of HIV in 2021. We are hitting 750 not out this year, newly notified cases, and there's a lot of reasons for that, and I won't go into too much detail, but it's a concern and something that we need to watch, and if we are making a concerted effort to get to zero new transmissions by 2020, by 2030, we do have a long way to go. But these are the tools in our arsenal to help us get there, and self-testing is a huge part of that. Yes.
So to the party, that's like a really great presentation. I saw the marketing material for the self-testing. Actually, it resonates with what we were doing in Kenya, because it's the Swahili one, they were calling it chukua selfie, like take a selfie. So it's really good. I just want to know about the orders that you are getting about the self-testing kits. You talked about the service being anonymous, like you don't collect because I'm just wondering now, that data, how useful it will have been, because, if I ordered a self-testing kit 10 times, then what does that show? That I'm at risk, because, and I'm just at a certain continuous risk, and so what is the next line of intervention? Like, how can we reach out to that person in terms of, like making sure they're on PrEP, or STI counseling, or such kind of services, if you don't have the data of repeat ordering.
Yeah, I mean, that was very much a snapshot. I could probably do it. We record a huge amount of data. So what I meant was that we don't collect identifiable information. Of course, we need a name and an address to actually post it out, but that information is purged 2 weeks after the test kit is sent. But we do ask a whole number of different questions so that we have a really solid picture, and one of them being, are you repeat testing? How many times have you used our service? And so there's a huge picture. The biggest problem for us is that because we are so focused on delivering service, we quite often don't actually have the resources to be able to dig in and do full reports and really mine the rich data that we have. But we do have huge amounts of information that are coming from the service. So I suppose one of the things from what you're saying is that one of the things we've identified is that what would be great for us to have as a resource, that something that's able to jump in and really kind of mine that data and show us where the opportunities lie in the service that we're delivering.
Okay, just one last one. Okay. So in terms of options, I don't know, do you have the options of blood-based and oral based?
We don't. No, it's solely blood-based rapid test. we did ask in the pilot of the service, we did ask whether or not, whether they were happy with the use of the test and all those types of questions. And it came back strongly that they were. We also, so we've kind of maintained the use of the blood-based test and not the saliva test.
Thank you very much. Any other questions or comments? Anybody else? Okay.
Close, Michael.
Well, good advice. Michael.
You know that's gone. Yeah.
Good evening, everyone, and thank you all for being here with us today. My name is Michael Kiernan. I'm a board member with the Gay Health Network, and it's my pleasure to have been asked to close the forum this evening. I did have a presentation. It's nothing to write home about, but we don't have it. So I'll only get you out quicker in that case. I think you'll all agree that firstly, it's been so nice being back in a room together after quite some time, apart from one another and seeing each other just on the screen. But it's so nice to be back in the room and in the company of so many like-minded peers who are very much actively working and achieving a common goal, which would be improved sexual health outcomes for the wider queer community, in turn creating a greater and holistic approach to health and well-being in this country. I myself have attended a number of Gay Health Forum events in the past thanks to my day job, but I firmly believe, and maybe somewhat biased sitting on the board, that this year's has been a remarkable forum. From the offset with the kind words of Minister Feehan sent and a passionate introduction from Chief Commissioner Gibney, it's been such an enlightening, reaffirming, thought-provoking and motivational day. I was asked to put some thoughts together in terms of what I myself have taken away from this conference, and it's very hard to summarise in just a short few words with the huge amount of research we've heard from people today and the great level of activism and advocacy and service provision out there and on the ground. But a few things I did note in particular that really stood out to me was earlier on when David mentioned about how we identify risk and what exactly we actually mean by risk. Is it based on behaviour? Is it based on demographic? Is it outcomes focused? And I know there was 6 other factors there that you had mentioned and how they can be quite intersectional as well. When Kitty mentioned about the biomedicalisation of sexuality, or whether it was sexual socialisation of biomedicine. And I'd never looked at it that way before. Is it the medicine interfering in our sexual lives, or is it our sexual lives now interfering in the medical world? And it was very much thought-provoking. I loved hearing from Fernandos in terms of the safari he brought us on, listening to the comparison between Kenya and Ireland. And what was very striking was the limitations in accessing service provision. And that was recognised by Fiona Lyons at the start of the day in terms of the capacity issues with PrEP. And we see a huge amount of campaigns, and we're doing more campaigns. And I know the HSE are keen for campaigns around the promotion of PrEP, but with the HSE not having the capacity, I wonder, are we doing ourselves and our communities a bit of a disservice there if we don't continuously push that treatment as prevention, as urgent, with the great steps that medication has come, the great strides even. There are, of course, a number of thanks I'd like to give. Firstly, to the Minister for taking the time to record the video, in which he very much highlighted the vital role we all play in the implementation of the National Sexual Health Strategy. And I'm very keen personally to see what he called the refreshed version of that, based on the feedback and consultations that were undertaken. To Chief Commissioner Gibney for her input this morning, and to the staff here in IREC for the use of this venue today. It's a nice change of scenery. And to all those who submitted research projects and spoke at today's events, I did have your name and organisations on a slide, I promise. but thank each and every single one of you for what has really been an enlightening day from start to finish. There's a lot that I'm going to take with me. In my day job, I'm actually in youth work, and I know there's so much there that young people want, so much information, and they're often a forgotten about audience. So I know with the amount that's been covered today, whether it's specific to medication or trans healthcare issues, or even the 15 corruptible songs from the 80s, there is a lot that I will bring with me going forward. And a big thanks to our 4 chairs today as well, Bill, Susan, Derval and Stephen. Thank you so much. A huge thanks to the network members for your continued engagement, participation at network meetings, and for all the additional times we call on you throughout the work of the Gay Health Network. And to the subgroup of the GHN board who have worked so hard in putting this event together today, board members Mick Quinlan, Bill Foley, alongside the contractors Porrick Burke and Rohit Chowdhury, who work tirelessly with great dedication and enthusiasm to promote the values and mission of the Gay Health Network. Thank you so much for putting this event together today. And a round of applause for them, please. To our funders in the HSC Sexual Health Crisis Pregnancy Programme, without whom this event would not have taken place today, for their ongoing support as well, and as well to the HSC. I know we've Murren in the room, and thank you so much for your ongoing hard work, dedication, and your partnership specifically with Paddy since taking the role up last year. A huge thanks to Dublin Pride for your ongoing support and assistance with today's event, from registration, the refreshments, the lunch, and the amazing lanyards and the design we've done out today. And Jamie, to you as well, for taking up the interim position of chair of the GHN board. I know you've the full support of the rest of the board, and thank you so much for taking that on. And lastly, there to GCN for your support, for your continued support throughout the year, your partnership, and for live streaming today's event for those who are joining us online. And thanks so much to Alice in the room for that. Just a reminder for something Bill mentioned this morning, we do have our strategy, the organisational strategy 2023 to 2026 is going to be launched on World AIDS Day, so just short of 2 weeks' time. Jeez, it's already December, my God. And I would really encourage you, as that is launched, is to have a look at that, because I suppose without engagement from the community, there's only so far we can get with that. So we do take the time to look at that when that comes out, and we'd love for you to engage with us on that as we look to meet those the goals that we've set across the next 3 years. On that note, thank you all so much for being here today at what has been an amazing event. Next year is a big year. It is the 20th annual Gay Health Forum, which will no doubt be even bigger and better, if that's even possible, than today's event. So with that being said, thank you so much for your attendance and participation today, and a safe journey home.
And then just a bit of housekeeping. The Irish Human Rights were really great in giving us this venue. It's a brilliant venue, and just to help them, because we stacked the chairs, we put the chairs out. So could people just bring their chair over and put them in forward along there? That would help the people. And just to throw out, and that's there into the end. That would be